Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center. Commonly used therapy, which is being provided by Allergy and Asthma Treatment Center. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro. The best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic catenic protein or ECP, our products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffuse
Good morning, everyone.
Good morning. Good morning.
Good morning, Shambho. Good morning.
Yeah, good morning, sir. Good morning. So I think 5 minutes late. Dr. Vedantan sir had joined.
No, not yet.
Who else is supposed to join?
I think, sir, you and Dr. Shah will chair this particular session. So Dr. Gautam Shah had joined, and you will chair the session. So I guess the technical team has that PPT, that PowerPoint slide decks are available.
Dr. Shah is not visible here. Is he?
Yeah, Dr. Shah has joined.
Yeah, I know he has joined. I had a talk with him, but he's not visible here.
Now I am visible, I think.
Oh, yeah, now he is.
Mhm.
Yes. I am turning off my audio. I'm keeping a still picture.
Okay, and during the presentation, I also request Dr. Shah to please mute yourself and you
Sure.
please stop your video there at that time.
Sure.
Okay, that's wrong. So we called him. किसी अच्छा
ডক্টর দাস বলুন। হ্যাঁ বলুন। হ্যাঁ আচ্ছা, ডক্টর দাসকে একটু বললে এখন অরিজিৎ দাসকে, কারণ দুজনেই আছি তো বোর্ডে। আচ্ছা 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 ঠিক আছে, আমি কথা বলে নিচ্ছি, বা শাম্বকে জানিয়ে দিন না, কারণ ওই তো। ও আচ্ছা, সুজিতকে আপনার আগে দিতে বলবো, তাই তো? ঠিক আছে। হুম, হ্যাঁ আচ্ছা আচ্ছা ঠিক আছে, আমি বলে দিচ্ছি, জানি না ওরা কি করবে, তো আমি বলে রাখছি। হ্যাঁ হুম, ঠিক আছে।
nothing else is coming, so the banner.
আচ্ছা ডক্টর সাম্য, হ্যালো।
Hello.
Good morning,
হ্যাঁ
everyone. So
আচ্ছা
I was in the second hall, so we'll start the meeting here also. I think it is a real pleasure for us to introduce the chairpersons for this particular session, Dr. Gautam Shaha and Dr. Arijit Das. Please show the TV slide. Okay, so we all know Dr. Gautam Shaha, who is a renowned scientist teacher in the field of allergology. He is the professor of zoology in Calcutta University. And also we have Dr. Arijit Das, who is the director of Allergy Asthma Treatment Center in Kolkata. And he was the pioneer in the managing the allergic disease with allergen immunotherapy in Eastern India. So it is our real pleasure to welcome Dr. Gautam Shaha and Dr. Arijit Das as chairpersons for this event, this symposium on allergology, the clinics, that is the clinical approach to allergy patients. Welcome you, sirs. So now please proceed for the scientific session.
Thank you very much, Shambho. But hello.
Yes, sir, we can hear you, sir.
Yes, I would request Dr. Shaha to start off because I'm still having a few technical issues here. So, Dr. Shaha, can you start?
Vedantan, sir, have you joined, sir?
হ্যাঁ
Dr. Vedantan, sir?
Dr.
no. Should I start? Am I audible?
Yes, you're audible.
Good morning to everybody, and I welcome you all to the second day program of Allercon 2021. At the outset, I would like to extend my heartfelt thanks to the organizers for giving me this opportunity, and also to organizing such a mega event on allergy in Eastern India, and giving me this opportunity to act as chairpersons in this session along with Dr. Arijit Das. So I request Professor Vedantan to start with his deliberation. Shambho, please introduce Dr. Vedantan. Thank you. In this session, there are
don't
4
see-
speakers. Oh, not yet joined, no?
I don't think Dr. Vedantan has joined yet.
Yeah, so then we can proceed for the second presentation fast. So Dr. Vedantan has not joined yet, so we'll wait for him. In between, we can start our second presentation by Dr. Shivesh Das. So please project that the technical team. There is a pre-recorded video is there by Dr. Shivesh Das. He is also present physically, but the presentation will be on the video mode. So may I request the technical team to project that? And first of all, we can introduce Dr. Shivesh Das.
Good afternoon, everybody. At the outset, I congratulate the organizers to allow me to have an opportunity to speak something regarding clinical examination in the allergic disorder in this auspicious gathering. After the session, we will learn the importance of clinical examination in the allergic patient and the methods of clinical examination in the allergic patient. Why you do clinical examination? We have seen that 70 to 90% of the medical diagnosis can be made by history alone, and physical examination doubled the diagnostic power of the history test. The physical examination does not only includes the examination of the patient, but the first part of the physical examination is to observe the patient. So, examination of the patient starts at the patient enters your clinic, it continues with the history taking and ends with your stethoscope. Now, there are a few golden rules while examining a patient that should be remembered. Uncommon presentation of common diseases are more frequent than common presentation of uncommon diseases. Similarly, if you diagnose a rare disease, you are rarely correct. And there is Boyd's theorem which tells that diagnostic tests will have higher yield if the pretest probability is high. So, we should select the patient to do an investigation only when the pretest probability of that diagnosis is high. Always listen to the patient, and they might be telling you the diagnosis, which has been told by William Osler. How the examination of a patient differs from an investigation. Examination is generally performed by the clinician, and while the investigation is performed by other person other than the clinician. Examination is generally embedded within the consultation, while investigation occurs outside the consultation. Examination generally has a human touch and it improves the rapport with the patient, while investigation is a mechanical part. Examination of a patient is generally a sensory aspect, it is personal. On the other hand, investigation is generally technological and is abstract. Examination generally gives
Dr. Vedantan sir, good morning. Can you hear us, sir? Hello, Dr. Vedantan sir has joined. I had said, okay, so please carry on this presentation. We can start because there is some issue.
evidence, while investigation gives hard evidence. Examination is generally considered subjective, while investigation is generally considered objective. Examination generally gives immediate result, so it is very important, especially in case of emergency, while we have no time to do an investigation. On the other hand, investigation is more valuable in case of chronic disorder because it takes time and there will be delayed results. Most of the examination is generally non-invasive, while investigation has generally semi-invasive to invasive. Examination generally produces no or low adverse side effect, while other investigation generally produces, while the investigation generally may have adverse effects and complication. Look at this picture. This patient came to our clinic in the pandemic era with a radiological diagnosis of COVID. The patient was crying and he was accompanying with his father. On further investigation, detailed investigation or detailed examination and history taking, it was evident that the patient was having hemoptysis for the last 3 to 4 days. The actual diagnosis came out to be a case of hemoptysis. So only overreliance of a CT scan will give you a wrong diagnosis and lead to misdiagnosis, treatment, and ultimately adverse outcome. So why you are neglecting this clinical examination in spite of this important? Because of improvement in the technology and its widespread availability for diagnosis, and as you are a busy clinician, time constraint is also an important factor. But in spite of this having these problems, we should have spent sufficient time for clinical examination history taking of every patient. Like all other patients, an allergic patient examination should start with the general survey. In most of the cases, the vitals are normal unless there is anaphylaxis or acute severe asthma, where we may get tachycardia, tachypnea, low blood pressure, etc. Mouth breathing generally found in patients with nasal obstruction, that may be also important clue in the clinic. All allergic patients should have a cervical lymph node examination which shows sinusitis, tonsillitis, mastocytitis, and otitis media. In case of clubbing, generally found in bronchiectasis, which is a common accompanying disease of asthma. Regarding the systemic examination, the special importance should be given eye examination, ENT examination. In case of eye examination, এটাকে নিতে খুঁজতে হবে স্যার। Regarding the examination of the eye, generally the allergic disorders of the eye present should itchy eye, conjunctival congestion, discharge, and eyelid swelling. If it is a non-allergic, non-infectious disease, the eye will be dry, as for example in active rosacea or in the foreign body. In case of allergic conjunctivitis, there will be itching of the conjunctiva, clear and mucous discharge, and generally it is associated with the allergic rhinitis, and there will be no corneal involvement. So these allergic conjunctivitis can be divided into two types, like seasonal and perennial, on the basis of duration throughout the year. In case of atopic or vernal conjunctivitis, there will be chemosis of the conjunctiva, mucous discharge, and cobblestone appearance of the eyelid. In case of atopic keratoderma conjunctivitis, generally it is associated with the atopic dermatitis. There will be eyelid eczema, and there will be conjunctival papilla in lower tarsal conjunctiva. On the other hand, vernal conjunctivitis will be having intense itching, more common in the younger age group with male predominance, and giant papilla will be visible on the upper conjunctiva, and generally discharged with the keratitis. On the other hand, if the patient is having mucopollular discharge from the eye, it is not an allergic conjunctivitis, it is an infectious conjunctivitis. Look at the picture of allergic conjunctivitis. In case of atopic keratoconjunctivitis, it is eyelid edema and intense reddening of the eye. And in case of vernal keratoconjunctivitis, there is cobblestone appearance of the eyelid. If we go for the ENT examination, it has been seen that allergic rhinitis and asthma both are common disorder of the airways in the form of allergy. So, allergic disorder in case of asthma or allergy rhinitis are generally commonly associated. On the basis of one airway, one disease theory, both can be commonly associated. So, in our clinical practice, all patients of allergic rhinitis should be examined for evidence of asthma, and all patients of asthma should be examined for presence of allergic rhinitis. It has been seen that about 80% of the allergic rhinitis patient has concomitant asthma, and about 40% of the asthma patient has concomitant allergic rhinitis. So, whether they are commonly present or not should be evaluated. Examination of the nose will see the pale boggy nasal mucosa, thin watery discharge, and enlarged turbinates in case of allergic rhinitis. On the other hand, absence of discharge is generally found in case of ethmoidal sinusitis. A discharge occurs posteriorly. In case of thick purulent nasal discharge, that indicates an infective etiology. Regarding sinuses, presence of sinusitis is generally assessed by percussing over the maxillary and frontal sinuses to look for tenderness and by the transillumination test. For evaluation of the tenderness, either you can percuss over the sinuses or you can press over the sinuses to look for tenderness. In case of transillumination test, generally patient is asked to tilt his neck posteriorly with open mouth, and a torch is placed over the maxillary sinuses, and we see the transillumination from the inside of the mouth. If it is present, the sinuses are normal. If it is opaque, sinuses are infected. But all sinusitis are not of infective etiology, allergic etiology. The other causes should be considered by clinical examination, history taking, and by further investigation. It includes infective sinusitis, carcinogenous syndrome, bronchiectasis, vaginal synaldomatosis, dark structure disease, cystic fibrosis, sarcoidosis, and immunodeficiency. All can be associated with the sinusitis. Due to the ear examination, tympanic membrane will be appearing as dull in case of otitis media. Tonsils, they are generally enlarged in case of chronic sinus discharge, and white spots, the pus points within the tonsil is generally suggestive of infective etiology and exclude the allergic etiology. Tonsils may be absent in case of X-linked agammaglobulinemia. So examination of the ENT is very important. Most of the ENT surgeons now rely on nasal endoscopy for proper evaluation of the upper respiratory system. Now coming to the skin, the common allergic disorder of the skin is atopic dermatitis, which shows xerosis and eczematous lesion with different morphological aspects and different locations. In case of children, there will be generalized distribution, especially affecting the face and extensor surface of the limbs, while in case of adults, it is localized to periorbital area, extra surface of the limbs, and near the wrist and ankle joints, and is generally characterized by associated lichenification, which is evident in this picture. Now the contact dermatitis, which is also an important very common disorder. It is sharply demarcated erythema related to distribution of the irritant on allergen. As you all know, this dermatitis is divided into two types: allergic contact dermatitis and irritant contact dermatitis. Regarding the incidence, irritant contact dermatitis is very common, much more common as compared to the allergic variety. The distribution in case of allergic variety, it exceeds the area of contact of the allergen, while in case of irritant variety, it is well demarcated, restricted to the particular area. Allergic dermatitis is having very severe pruritus. On the other hand, irritant contact dermatitis generally presents with the burning sensation or reddening. Allergic contact dermatitis onsets within hours to days, while irritant contact dermatitis is more rapid, appears within minutes to hours. In case of allergic contact dermatitis, there is a crescendo pattern. That means it will go on increasing for few days, then it will start decreasing. On the other hand, irritant contact dermatitis is maximum from the beginning and starts decreasing from the next days. Patch test, which is very important for diagnosis of allergic contact dermatitis is generally negative in case of written contact dermatitis. The morphology of them is also different. In case of allergic variety, there will be erythema, edema, vesicle formation, and lichenification. On the other hand, irritant variety will be having erythema and edema, fissures and desquamations will be more important. The positive agent is also different. Metals, cosmetics, adhesives, and fragrances are mostly related to allergic disorder, while soaps, detergents, acids, bases, and solvents are related to the irritant disorder. These are the two varieties, irritant contact dermatitis and allergic contact dermatitis. The characteristic morphology is different. Now the urticaria. It is a very common disorder, extensively pruritic, circumscribed, erythematous plaques, often with a pale center. It can be of two types on the basis of duration. If it is less than 6 weeks, we call it acute. If it is more than 6 weeks, we call it chronic. Acute variety is generally related to drugs, food, insect bite, or some infection. On the other hand, chronic urticaria is generally idiopathic or autoimmune, sometimes related to physical insult, or sometimes related to secondary to vasculitis. So all the urticaria is not due to allergic disorder. Acute urticaria, if you get an acute urticaria, our job is to look for any anaphylaxis. In case of chronic urticaria, we should look whether there is angioedema or not. Predominant angioedema and less urticaria is more common with the drug-induced variety. If the patient is having fever, weight loss, arthritis, pigmentation, vertigo, or palpable purpura, we should think that most of the patient is having secondary causes of urticaria like vasculitis. And in case of physical variety, relationship with the physical stimuli is also important. Now coming to the chest. The allergic disorder in the chest most important is asthma, and it is characterized by presence of wheeze. Wheeze is defined as high-pitched, prolonged, uninterrupted musical sound produced by partial obstruction of the lower airways and mainly heard during expiration. It is a classical sign of asthma. In a good clinical background, presence of wheeze is almost diagnostic of asthma, but it will be absent in case of cough variant asthma, which is characterized by presence of only cough without any wheeze. But you must remember, all that wheeze is not asthma. Other common causes of wheeze is COPD, heart failure, bronchiolitis, and tumor or foreign body. In case of tumor or in foreign body, the wheeze will be localized to a particular area, but in other cases, it will be generalized and bilateral. In the context of allergic disease, it is very important to differentiate asthma and COPD because the management is totally different and there is no scope of allergy immunotherapy in case of COPD. However, wheeze is not a good guide for assessment of the severity of airway obstruction. If there is very severe obstruction, there will be no airflow, so there will be no breath sound and there will be no wheeze. That is called silent chest. So, absence of wheeze may be indicative of very severe obstruction. Now, what is the evidence for clinical examination? As we have seen that significant number of allergic disorders, the diagnosis is clinical. As for example, atopic dermatitis, contact dermatitis, urticaria, there is no definite investigation for the diagnosis of these diseases. It has been seen that skin tests and in vitro testing may be falsely positive and falsely negative. So, we should not rely over, there should not be an over reliance of these tests. So, we have advocated Choose Wisely campaign, which is advocated by American Academy of Allergy, Asthma and Immunology. It has been advocated that they have recommended that not to perform any unproven diagnostic test like indiscriminate battery of IG test either from the skin or from the blood in the evaluation of the allergy. They have also advocated that extensive panels of inhalant test should give false positive result, we should avoid. In case of food IgE allergy, food IgE testing should not be done in the absence of history, consistent with the IgE mediated food allergy, because false and clinically irrelevant positive allergy test of food is very frequent. Similarly, in case of drug allergy test, serological evaluation of the IgE has low diagnostic sensitivity, so should be avoided. So they are not useful to rule out penicillin allergy. So there should be skin test for allergy evaluation. So it is evident that we should have a background information of a patient to particularly select or wisely select a particular test for allergy evaluation. So what is the take home message? We should wisely select the investigation in the basis of history and physical examination. There should not be any random test. And we should always interpret the allergy test in the context of history and physical examination. But you must remember, allergy cannot be diagnosed solely on the basis of skin test or laboratory test. So proper history taking and proper clinical examination is a must. Thank you.
So technical team, please project Vedantan sir's CV now. So we'll move to Vedantan
Hello.
sir's stuff now.
Can I share the screen? Okay.
Please share your screen, sir.
Pardon?
Please share your screen, sir.
1 second.
So first of all, please share the Vedantan sir's CV slide. And may I request our chairperson, Dr. Arijit Das sir, to introduce Dr. Vedantan.
Hello, Dr. Vedantan. Very good morning to you.
Good morning, sir.
Good morning.
Dr. Arjit Das. Yeah.
It's a great pleasure to welcome you to our conference, Allercon 21. To give you a brief narrative about Dr. Vedantan, Dr. Vedantan is a graduate of Mysore Medical College in India. He is a consultant, AAI, Lakewood, Colorado, USA. His academic affiliation is clinical professor, University of Colorado, USA. He has global chest. He's the chairman of the Global Chest Initiative, International Asthma Services, chairman of PRA-AA-NA, Charitable Allergy Asthma Clinics, AAI Training Program, co-director, DAA Program CMC Vellore in India, DPAA Program SGHRC Delhi, AACC Madras, MedTrain in Bangalore, USA, Bangalore, India, sorry, DPS in Bangalore, India, and is the lead editor of Textbook of Allergy for the Clinician. Dr. Vedantan is an illustrious personality in the field of allergy and immunology. He has been mainly working in Colorado and USA, and it's a great pleasure for us to welcome him to our conference. We are having a few technical issues today, which was not there yesterday. I hope it'll be sorted out soon. But I would like to hand it over to Dr. Vedantan for his presentation.
Thank you, Dr. Arjit Das. Thank you very much for this kind introduction. Can you hear me?
Yes, you're audible, Doctor.
Okay, thank you very much. I'm very, very familiar with the Calcutta group. It's always a pleasure to
You're welcome,
spend
sir.
time with you, Dr. Das, Dr. Jayati Das, Aratrika Das, and Saibal, Jyotirmai. So I'm very, very familiar with the
Yes,
Calcutta
sir.
group.
We
Always
know
a
that.
pleasure to be with you. And thank you so much for inviting me to be a part of your group today.
Always welcome, sir.
Thank you, sir. So the topic that has been assigned to me is a very basic topic, but a very important topic. The art and science of history taking. So let us move on. I don't know, the slide is not moving. Okay. How do you make a diagnosis of allergy? There are three answers. Answer number one, answer number two, answer number three. And let us see what are those three answers. The first answer is history. Second is history. Third is history. So what it means is the history is the basis to make a diagnosis of allergy. It is not the test. And that's what the previous speaker was also mentioning. It is not the skin testing. It is not the specific IgE. It is not the eosinophil count. It is not all those different type of tests or physical exam also is partially helpful, but the most important part of the equation is history. Now, why history is so crucial? Because the other things, when you do allergy skin testing, what you are finding out is only sensitization. What type of specific IgE antibodies are there? And the same thing, when you do immunocap or specific IgE, you are finding out only sensitization about that person. Physical examination is very limited. And as you know, total serum IgE is not very helpful at all in the diagnosis of allergy. It is very non-specific. So history is very important. It is the correlationship of the history with allergy skin testing, correlation of the history with the specific IgE. And the same thing, that is the same as skin testing is specific IgE, but if you are doing in vitro, it is we call it trade name is immunocap. And correlation between history and therapy. Sometimes we treat with anti-allergic medications, and if they get better, we say, oh yeah, it seems like it is sort of correlates with what the patient is saying. So that is also some sort of a diagnostic importance. Now, how do you take a history? So history is not just talking. It is not just asking questions. It is sort of a very scientific way of interacting with the patient. The most important part of the equation is we should talk less and let the patient talk. Let the patient tell us what exactly it is in his or her mind is. What is the complaint? How is the patient suffering? What is he suffering from? Is he having any difficulty breathing? Cannot breathe through the nose, cannot breathe through the chest, having some itching here, sneezing there, doesn't feel good, cannot sleep well, cannot concentrate. All these type of symptoms, the patient is very anxious to tell you. And if we keep on interfering in patients talking, like we keep on asking questions and not allow the patients to talk, the patient cannot give you a good history. So it is important for us to allow the patient to express himself. Sometimes the patient will tell unnecessary things. He will take the history to somewhere else that you don't want, but you could sort of divert him to a proper path by doing a few comments here and there. And we need to realize an allergic patient is a very anxious patient. He has already seen many physicians or health providers or even friends, relatives, siblings who talk about allergies to him. So sometimes he's well informed and many times he is misinformed, and he comes to you with many built-in ideas, with many myths. He comes to you. And there was a study done to find out how many doctors these allergic patients have seen before they come and see the specialist. The number was unbelievable. They would have seen about 12 to 13 health providers before they come and see you. They may not tell you that, but they would have consulted or at least talked about their issues with many health providers before they come and see us. Now, the allergic patient, I told you, is anxious, but he's always looking for answers and he looking for a cure. He does not want just relief of symptoms. He has already tried this spray, that spray, many of these steroid sprays, antihistamines, allergy medications are over the counter. You don't need any prescriptions. In India, you don't need much prescriptions for any of the medications anyway, but many other countries, it's very strict. Here, we call it over the counter, where you don't need prescription. You just walk in, pick up the medicine. It will say allergy medicine. So this patient has already tried it. And some patients, especially the urban patients who have got all these iPhones, cell phones, computers, PCs, they are very inquisitive and they want to check on Google, what is this allergy about? What is this allergic rhinitis? What is inflammation? What is IgE? What is histamine? So he's already learned or at least studied all this, and he's more confused because half knowledge sometimes is much more dangerous than no knowledge. So you need to be aware that urban patients from urban areas already would have checked on many of these things online. And the other thing that patients thinks is every symptom he thinks it is allergy. You can't blame him for it, but that is what he thinks. And it is our duty to delineate what is allergy, what is not allergy. So a history taking actually is an educational thing. We need to let the patients know which is probably not allergy, which is definitely allergy, and which is definitely not allergic. Now, I already have told you these things. So one thing that you really have to practice is patient hearing and compassion. Sometimes it is not easy. Many patients irritate you by telling all sorts of different things, but we need to have that patient hearing, because patient hearing will help the patient to unload all his emotions. He should, when he gets out of the office, he has satisfied, oh, I have told the doctor everything. I have not forgotten anything. I have told him. And that is his comfort feeling. And that is an important feeling. And so we are like shock absorbers. We need to absorb all these different things which are necessary or unnecessary. And that is how that makes us a compassionate, good physician. And allergy history is a little different type of history compared to many other specialists. Allergist spends a lot of time on history alone. Very rare for several other specialists. And all of us have experienced it. We are physicians, but we are also patients. Because we are human, we go and consult other doctors, and then you find out, for example, an orthopedic surgeon might spend like 3 minutes taking your history and is already busy bending your knee or checking your movement and range of movement. And in the 5th minute, he wants to do some surgery. A dermatologist will never speak to you much, except he will just look at it and says, this is what you have and this is what you need. And that type of thing, allergists do not do. They spend a lot of time because they really they need to know all about the patient's, not only his different complaints, but also what are all the different factors that can influence his symptoms. Because allergy is a type of disease which is caused by gene-environment interaction. Genetically, the patient is wired, and environmentally, he's having all these different symptoms because of the exposure. It could be dust, it could be cockroach, it could be animals, it could be moldy environment, it could be smoke, fumes, perfumes, irritants. Patients think everything is allergy. So that type of information you will get only if you spend time and get all the details. This is the only specialty where the doctor will be asking, where do you sleep? What type of pillow do you use? what type of carpet you have. Do you have any pets? Is the pet in your bedroom? Who along sleep with you? Does he have symptoms? What type of medications you have? And how many windows there are? Is the window open or closed? No other doctors will ask these questions. There is no specialty that where so much detailed information is obtained. And what it does is the patient starts feeling, this doctor is something special. The previous doctors I have been, they have spent only 5 minutes or 3 minutes with me, and they're already charging me 300 rupees. But this doctor is spending half an hour with me and asking me all these questions, and still his face is the same. So that relationship in an allergy office between the physician and the patient, between the patient and the office assistant is very strong. They develop this they become friends and they feel like they're a part of their office. So because it is a chronic disease, these patients keep on coming to this office. They will know all these employees by first name, and they become like a family. So it is very important for you, for the staff, to be well educated, because the patients generally talk to your staff more than they talk to you as a physician, because they're always nervous to talk too much with doctors, but they don't feel any type of nervousness talking to your office assistants. So the office assistant has to be educated properly, trained properly, otherwise he will give misinformation. Now, points in allergic history, the most important point is not just symptoms, but progression of symptoms. Because allergy is a progressive disease. It keeps on moving, progresses. That is what allergic march is. And the history can be very subtle. In progression, there is nothing much where information is given to you ready hand. Patient will not come and say, my allergies are getting worse. He will just give you some subtle points. Say, for example, patient has allergic rhinitis, and the mother has noticed that he starts coughing at night. Patient will not tell you that, but it has been noticed that he coughs at night. He also coughs with physical activity. That is progression. That means the lower airway is getting involved. That is something subtle that you need to be sensitive to, and you need to pick it up. And the mother may say, whatever medications that you gave, doctor, has helped, but in the last 4 weeks, the same medications is not helping that much. He still has some more, he has symptoms, but that doesn't bother him. That doesn't bother me also. But overall, he's better. But the medicine seems to be working less. That is again a sign of progression. So the disease is progressing. And we also should be knowledgeable about the disease completely. That is, if you are asking any questions to the patient, when you're taking history, you should know why you are asking that question. When you are asking, do you sneeze much? Do you have itching? Behind in your mind, the reason why you are asking those questions is there any histamine release? Is there a mast cell involvement? If it is stuffy and the patient says, I can't breathe, and I also have this mucus, okay, and you ask more questions behind, what you are thinking is this is a sign of inflammation. Okay, so he has inflammation, he has histamine release, so he has got all these mediator release, so that, and seasonal pattern, all these things. And is it indoors or outdoors? Is it more early in the morning or late in the evening? All these factors have to have a meaningful information to you, and it will be meaningful to you only if you are knowledgeable about the disease. That is when you are able to correlate, and you will be correlating in your mind as you are taking the history, because the patient's family is watching you very closely. They are looking at you like a hawk. They are looking at your face. If you show some insecurity in your face, that is not a good sign. Patient already will have lost confidence. The family will lose confidence if you show security, especially if you open a textbook and start looking at it. That means you really don't know anything. So it should be, you should have that expression of confidence, and you should ask the right questions, and you should be completely be attentive. That is, you should have eye-to-eye contact with the patient. Don't look at a window and somewhere else and ask a question. Okay, don't keep on reading something and ask a question, because patient wants attention. So you need to see eye to eye, pay 100% attention to the patient, because the patient is paying 100% attention towards you. And when you have a pediatric patient, like a 5-year-old, you should have a conversation with the child. You can't just depend on the parent alone, because many times children do not tell everything to the parent. The parent will not know what happens at school, what happens when he spends his own time in his bedroom or with his friends. So the child has to be interviewed also, so that you need to ask these patients, these children, what exactly happens, and that can be a very useful information in the history. So what does the history tell you? The history will tell you everything. History is giving you the diagnosis. If there is a patient who says, I'm itching, I'm sneezing, I can't breathe, and these symptoms are more when I get up in the morning, I sneeze like 8 to 10 times, you already know there is some histamine release occurring, and you already know that this could be a dust mite sensitivity question. Dust mite. So you might ask a little bit more leading questions there. So your job when you are taking history is not mechanical. You are not taking a history, just ticking mark, yes, no on the sheet. You are thinking, you're analyzing, you're planning as you are taking the history. So you're doing 4 things when you are taking the history. Okay. It's very important for you to show that face of confidence in front of the patient, as I mentioned to you before. So what is the second history? So you take the initial history, then you do the evaluation, do the physical examination. Then based upon the initial history, you feel like this patient has allergies. Then you determine what type of skin testing you want. You go ahead and do the skin testing. You have the result. You may do spirometry. And with that type of information in front of you, you will have what we call as a second history or a summary conference. This is the most important part of the patient's interview, because you are putting everything together. You are putting the results of the skin test along with the patient's history. You are putting the history of the results of the spiro along with the patient's history. So you are putting all this together and coming up with a treatment plan, a management plan. And this is what we call as a summary conference, as a second history. This is where you spend more time. And this is the time when you are deciding whether this is a patient where I can manage with only environmental measures, or is this a patient I need to add some pharmacotherapy, or is this a patient where I need to do allergic immunotherapy? And allergen immunotherapy is a big decision. You probably should not start allergen immunotherapy in first visit, because this is a decision that should be taken not by the patient alone, but by the whole family. So it is important that you give some time to the patient to mull over this important treatment modality, because it is a treatment modality that will go on for the next 5 years or maybe much longer. So you give some time for the patients to think, because it also involves a change in lifestyle, a lot of travel back and forth doctor's office and finance and all that type of stuff. So give some time, at least like a month, to think over, and the second visit you can again discuss about it. So second history or correlation is very, very important. So how do you, I already touched upon it, but I'll again go through it. Needs, how do you know that allergic disease is progressing? How do you know that? Because there is nothing this progression of allergic disease is never talked about in guidelines. If you look at any of the area guidelines, they don't talk about progression of allergic disease. This is a clinical type of experience with the patient that you need to make out whether the disease is progressing or not. When the patient needs more medicines, I used to take this pill once a day. Now I'm taking it twice a day, but I'm getting relief with 2 pills rather than 1 pill. That is a sign of progression. Medications were working very well, but in the last 1 month, not that great. I am having some breakthrough symptoms. That means the disease has progressed. And I'm having recurrence of symptoms. New symptoms are coming. I'm having some night symptoms. I'm having physical activity, symptoms with physical activity. All these things will tell you clinically, the disease is progressing. The question is it progressing immunologically? Is the question. So many times what we do is say, like, over a period of 6 months or 8 months, you see the patient, a pediatric patient especially, has a history suggestive of clinical progression. I would do a few skin tests, repeat the same skin tests I did that were positive. You don't have to do a whole lot, maybe 8 or 10 skin tests, and you will see the reactions that were like 8 millimeters in diameter now are like 10 to 12 millimeters. They are also having pseudopods. So there is immunological progression also. Along with clinical progression, immunological progression also, which means the allergic march is progressing. The disease is progressing, and it probably is a signal that you may have to intervene. Environmental control alone may not be enough. Pharmacotherapy may not be enough. You may have to do immunotherapy on these patients, because immunotherapy, only treatment modality that can interfere or halt or slow down or modify the progression of the allergic disease. There is no other modality of treatment that will do it. So progression, I am spending more time because it is of a huge importance in the practice of allergy. And if you are not tuned to get the proper input to assess the progression, you probably may not be successfully treating the patient. So general instruction, when you are doing all these type of things, you should be gentle, be kind, compassionate, truthful. Better to tell the patient, I cannot cure you, but I can control your problem. With immunotherapy, I can actually modify. I might be able to reverse some of these things for you, but don't use the word 100% cure. There is nothing like a guarantee. In India, especially, they ask for, oh, is it guarantee, sir? Can you give me 100 guarantee? So there is nothing like a guarantee. You're not a car salesman. You're not a motorbike salesman. You are dealing with human beings which are dynamic. It's not like a car, So you can never do guarantee anything, but you can say the percentages based on your knowledge of the subject. And another thing is, somebody has not treated this patient well, another physician, do not badmouth that physician. He is a stupid fool. He doesn't know what he's doing. Don't say those type of words in front of the patient, because patient will go and tell the other doctor, he called you a fool. So that itself may be a major issue. So it's very, very important for you to be you should be professional, you should be compassionate, you should be truthful. And how long will it take for you to become a successful historian, a successful allergy specialist? It won't happen in 6 months. It won't happen in 2 years. It will take 5 to 10 years before you are a perfect allergist who has done a fantastic job, who is compassionate, who is efficient, and who is also very, very highly respected and does the best job for his patient. Thank you very much. And here the colors are changing. This is the color from my backyard. The whatever green is becoming yellow, it becomes a red, and the leaves will all fall off. And here what we have, what we call as change of seasons.
So that is the fall season.
So it's called fall season. So
Right.
thank you very much for giving me the opportunity. I might have exceeded the time, but I thought this, although this is a basic topic, this is an important topic. Thank you, sir.
Thank you
Thank
Thank
very
you
much.
very
Sir.
much, Dr. Vedantan. It's always been a pleasure to listen to him. It's always fascinating and enlightening. Thank you so much, sir.
You are
Thank you,
welcome.
sir. Thank you, sir. You have so nicely elaborated the importance of the history taking and for the diagnosis and also to evaluate the progression. No matter in this age, we might be having this multiplex system or the complementary resolve diagnostics, but the history taking is the crux of the treatment of any allergy patient. Thank you so much, sir.
Thank you. Thank you very much. Continue. Wish you all the success in the meeting.
Thank you so
Bye-bye.
much.
Bye-bye. Nice seeing
Bye.
you. I'm going to go because I have to go to bed.
Yes, sir.
Yeah, I realize that.
Bye-bye.
Hello. Hello.
Sir, you are audible.
Hello.
Dr. Das, you are audible. You are audible.
Okay. Hello. Am I audible?
Yes, yes, you're audible. You're audible. Please
Okay.
go ahead.
Okay. So we go to the next speaker. I suppose it's going to be Dr. Aratrika Das. So a little bit about Dr. Das. She's a renowned pulmonologist. She's a renowned pulmonologist, analogist
Oh,
in the city.
One second. Can
Yes,
I
go ahead.
interrupt once, please?
Yes, go ahead. Go ahead. Go.
I had already informed. Professor Shaha and that I'll be speaking after Dr. Surojit Chatterjee.
Okay. Okay. Okay.
There is some
So-
connection problem here. That's the reason I
Yeah,
said
there are
after
a lot.
Surojit.
There are a lot of
Let
technical
Dr.
issues today.
Surojit.
There are a lot of technical issues
Yeah.
today. So anyway,
Right.
I'll request Dr. Shaha to take over then. Hello, Dr. Shaha.
Hello, hello, am I audible?
Yes, you're audible.
Next speaker, so Aratrika will be the last speaker. Just now he rang me and informed me that he wished to talk last of this
Yes.
session. Now I request Dr. Surojit Chatterjee to deliver his presentation.
Very good morning. Am I audible?
Yes.
Let me give some time to share my screen, sir.
In between, we should actually introduce Dr. Surojit Chatterjee. He is assistant professor of chest medicine in IPGMER SSKM Hospital, and also he's a consultant allergologist in Allergy Asthma Treatment Center, Moulali. Welcome, sir.
Thank you. Is it visible?
Yes, your slides are visible now.
But it's not full screen, I think.
Yeah, you have to make it full screen. Yeah, now it is full screen.
I think it is visible now.
Yeah.
So very good morning. And at first, I would like to thank Dr. Shambho, my junior, for organizing this conference. Dr. Arijit Das, Dr. Gautam Saha, for being a chairperson in this topic and this conference. So as my topic is the interpretation of spirometry and pheno in allergy. As my previous speaker, Professor Vedantan, has said that for allergic diseases, the most important thing for diagnosis is history. The history comes first. So a proper history with addition of some investigative procedures that can help or aid us to come to a definite diagnosis. And I think this spirometry and pheno has a limited but very definite role in the diagnosis of allergies, specifically the respiratory allergy part. So the presence of spirometry and pheno, it comes in the second history taking part, when the clinician or an allergist wants some reports to make a diagnosis or make a treatment decision. So uh, till now, the GINA, the International Guideline for Asthma Management, has defined asthma as a clinical diagnosis. But recently, they have changed their their definition that asthma should be an clinicospirometric diagnosis than a merely clinical diagnosis alone. Coming to the allergy, the new endemic in India, so we know that estimated 300 million people worldwide are suffering from asthma. About 10, more than 10% of those world asthma patients live in India. And in India, the burden of allergy and asthma is so much that it even exceeds the amount of tuberculosis and also HIV. So the data shows that 7 to 10% of Indian children have wheezing, and around more than 11% have allergic rhinitis. In the development of allergy and asthma, we can find that allergy is a recognized major risk factor for asthma. A set of allergy or individuals, sorry, the reaction is often biphasic. It's an initial allergic symptoms by mast cells or basophils, and the late response by eosinophilic inflammation. The role of spirometry, specifically the PFT part in diagnosis of bronchial allergy, is that we have to prove or disprove that we have the patient who is coming for the treatment is having asthma or asthma or not. So patients are often fond of hearing that patient, he or she is having a bronchial allergy but not asthma. So to prove that, we have to have some spirometric data in front of us, as well as pheno is also helpful in the diagnosis of eosinophilic allergic reaction in the airways. So the role of spirometry, specifically in diagnosis of asthma, is a very simple test. It usually measures lung volumes, especially the dynamic lung volumes. It allows the diagnosis of airway obstruction, especially, and it can diagnose specifically the asthma, COPD. I'm not going to the restrictive defects or other lung defects which can be diagnosed by these spirometric methods. So these are the different spirometers available in our country and worldwide. The handheld spirometer, and these are different spirometer like Spirobank, Microloop, Spirostar, and all. So we can see the different spirometric devices. What spirometry produces? Spirometry produces two graphs and some data. So among these, the two graphs, one is volume time curve. This is a normal volume time curve where we can measure the dynamic lung volumes, and another is flow volume loop. From these two, looking after these two curves, one is flow volume loop and one is time volume curve, we can easily interpret that whether this defect is either obstructive or whether this defect is restrictive, or whether the defect is mixed defect, that is both obstructive and restrictive. And the data that can be generated by spirometry are mainly the three principal data. That one is FEV1, forced expiratory volume in 1 second, FVC, and the FEV1 FVC ratio. And from the flow volume loop, we can get some additional data like the peak flow, the FVC, the FEF 2575, and some other data, along with inspiratory flow data. Now coming to the normal values. Before going to the abnormal value, we have to first know what are the normal values, and these values depend on the age, sex, the gender, and ethnicity of the person examined. So coming to the FVC first, is normal value is more than 80%, and when it is 70 to 80%, it demonstrates the mild defect. When it is 50 to 70%, it is moderate, and if it is less than 50%, it is regarded as severe reduction. Coming to the FEV1, its normal value is more than 80%, and if it is 70 to 80%, it demonstrates the mild reduction. If it is 50 to 70, it's demonstrate the moderate, and if it is less than 50, it's demonstrates the severe defect. Sometimes the FEV1 is used to grade the severity of the disease, and if it is less than 30, then it is called very severe disease, especially in cases of COPD. Normal values for FEF 2575, it indicates the small airway function. So again, it's more than 80% is normal. For 60 to 80%, it reflects the mild obstruction. 40 to 60%, it reflects moderate obstruction, and less than 40%, it reflects severe obstruction. So criteria for normal post-bronchodilator spirometry are, in spirometry, we usually see the post-bronchodilator values. The normal spirometric values in cases of normal spirometry are FEV1 should be more than 80%, FVC should be more than 80%, and the ratio FEV1 FVC ratio should be more than 70 to 80% or 0.7 to 8, depending on the age. So based on these normal values, we can, and the abnormalities that is shown in the patient's spirometric data, we can divide it into obstructive pattern and restrictive pattern and the mixed pattern. And there we also see the reversibility. So in obstructive disease, the primary basic criteria is that the ratio should be less than 70% of the predicted. So we have to see the ratio first. Then we have to look for the FEV1, that whether it is less than 80% or not. FVC can be normal or reduced, usually to a lesser extent than FEV1. In restrictive disease, the reduction of FVC is more than the FEV1. In obstructive disease, the FEV1 component is reduced. So as I have described that in restrictive pattern, FEV1 may be normal or mildly reduced, but the FVC should be reduced, and that's why the FEV1 FVC ratio may be normal or increased. And in mixed defect, we can see both FEV1 is reduced, FVC is reduced, and the ratio is also reduced. So then we can call it as a mixed defect. And regarding reversibility, the criteria is it should be more than 12% and 200 ml or more improvement in either FEV1 or FVC after application of bronchodilator. And the usual bronchodilator which is applied is that salbutamol or levosalbutamol. Sometimes there may be steroid responsibilities. I mean, steroid reversibility are again sometimes that can be measured. The FEV1 FVC ratio should not be used to assess the reversibility in this context. And the correct interpretation of spirometry requires that it should be performed correctly according to the ATS-ERS criteria. So there are spirometry is just like a ECG of heart, ECG of lung. So, but the difference of spirometry and ECG is that spirometry is an effort dependence test. So we have to do it properly. The technician or the doctor should guide patient properly so that they can perform the spirometry properly. So to obtain an accurate recording, the subject should be told to sit upright, there should be a good seal around the mouthpiece, and firstly, he or she has to rapidly inhale maximally, that is, breathe in all the way. Then, without delay, he has to blow out as hard and as fast as possible. That is called blast out, and continue to exhale or keep going until the patient can blow no more. That is, he can achieve the residual volume. The point at which no more air can be exhaled is the RV, and the patient is then instructed to inhale fully to the TLC again in order to record the IVC. So that forms the flow volume loop properly. The initial exhalation part, then blow out, that keep going, then come to an end, and again he has to inhale maximally. So the test is then repeated to ensure the reproducibility in order to meet quality control criteria. Now, this is the one of the flow volume loop where the peak expiratory flow is obtained, and by convention, the upper part is the expiratory part and the lower part is the inspiratory part. The acceptability criteria, there are two criteria. One is acceptability criteria and another is reproducibility criteria. Among the acceptability criteria, it should be free from artifacts, especially the cough artifact or early glottic closure, free from any leak. It should be good start, that extrapolation back from the peak flow, which is the steepest part of the spirogram curve, produces a theoretical start time from which the measurement should be timed out. And this is called a new time zero. And this should occur within 5% of the SVC or within 150 ml. The acceptability criteria, the acceptable exhalation should be for adults. It is at least 6 seconds of exhalation and a plateau in the volume. Plateau for at least 1 second. And for children, the time children under 10 years of age, the time should be less. That is, it is regarded as 3 seconds of exhalation and a plateau in the volume curve. Now we can see what artifacts can occur in this spirometry graph. In the left-hand side, we can see that in the time volume curve, there is cough within the first 1 second. There is a major artifact, and which is clearly shown in the flow volume loop. That is a cough artifact within the 1 second. This graph indicates the variable effort. Good end of the test, as demonstrated by time volume curve, is a must. So its plateau of time volume curve should be at least 1 second, and volume is not changing much with the time, indicating that the patient is approaching the residual volume. So this is a must for a good acceptable test, and reasonable duration of effort, and 6 seconds in the minimum acceptable duration for the adults and 3 seconds for children. 10 seconds is the optimal. This is the in the left hand side, we can see the poor end of the curve that ends abruptly, and in the right hand side, we can see the good end of the curve. In the left hand side is a normal curve, and the right hand side is called the PEF is not sharp, so it is not a good acceptable curve. In the left hand side, we can see the cough at 1 second. In the right hand side, we can see the poor end of the test. Here we can see that start time is there is a gap between inspiratory curve and expiratory curve. So this indicates a significant air leak. Now coming to the repeatability criteria, we have to select the 3 acceptable maneuver. The two that means the 2 largest FVC measurements are within 150 ml of each other. 2 largest FEV1 measurements within 150 ml of each other. And when both acceptability and repeatability criteria are met, the test can be concluded. And a maximum of 8 maneuvers should be performed until the criteria are met and the patient is unable to continue. As a minimum, the 3 satisfactory or best maneuvers should be set. Coming to the reproducibility, after obtaining the acceptable maneuvers, again the reproducibility criteria should be met. The 2 largest volume of FVC should be within 150 ml. The 2 largest volumes of values of FEV1 should be within 150 ml of each other. And if the studies are not reproducible, then the studies should be repeated until the ATS criteria are met, or within the total of 8 trials. So these are some graphical representation of acceptable or reproducible trials. Some acceptable trials are not necessarily be reproducible because the patient may not produce maximum effort in all the trials. So that is evident. Now the interpretation of spirometry, we usually get the curve of obstructive or restrictive or mixed. We have to see the flow volume loop, we have to see the time volume curve, the shape of their curves, and we have to read the values. Depending on that, we can get obstructive pattern, restrictive pattern, fixed large airway obstruction, variable airway obstruction, like variable extrathoracic or variable intrathoracic. I'll show the graphs. These are some acceptable and unacceptable loop. We can easily interpret it looking at the loop or curve. I'm quickly skipping these slides. This is one of the curve where we can get in some of these spirometric measures that tongue obstructing the mouthpiece. This is a slow start. Left hand side there is a normal curve. Right hand side there is a defect. The slow rise, broad late peak, early glottic closure of the cough, incomplete exhalation, the poor end. And this is a classical diagram of what type of curves or loops we can get from a spirometry test. In the left hand side, there is a normal. In the middle of the upper part is the obstructive pattern. In the right hand side of the upper part is the restrictive pattern. And there are some variable and fixed obstructions in the lower part. In variable extrathoracic obstruction, the inspiratory part is flattened. In the variable intrathoracic obstruction, the expiratory part is flattened. And the fixed obstruction, the curve is box-shaped. So we don't have to look for all the data in spirometric measurements, but we have to look for FEV1, usually the post-bronchodilator, the FVC, and the FEV1 FVC ratio. And to see the reversibility, we have to see the both pre and post bronchodilator and see the reversibility, whether it is significant or not. So in a nutshell, the diagnostic features of obstructive disorders, the diagnostic features are there should be a low FEV1 FVC. FEV1 is individually low, FVC is low or normal, and there are some other criteria, and there should whether there is significant bronchodilator response or not. If significant bronchodilator response, then it indicates the significant reversibility. That also indicates the asthmatic pattern of the spirometric curve. And whether the curve is scooped or concave, descending limb, that is the effort independent part. So sometimes it indicates small airway obstruction, and sometimes when the pattern is dogleg, especially in emphysema. So again, I'm skipping this part. So this is a typical flow volume loop of obstructive pattern where the effort independent part is scalloped or scooped, where FEV1 is less than 70% of FVC. So there are 5 features that make the diagnosis of significant airway obstruction. One is decreased PEF when compared to the predictive curve, scooping of the curve after PEF indicating airflow limitation. The first second mark is almost in the middle of the curve, indicating that the FEV1 and FEV1 FVC ratio are significantly decreased. FVC is decreased when compared to the predicted curve. The inspiratory component of the curve is normal, excluding a central airway obstruction. If there is not a central airway obstruction, in obstructive pattern, the inspiratory component should be normal, and all the defects are seen within the expiratory part. So there is a clear response to bronchodilators indicating reversibility and supporting the diagnosis of obstructive disorder, most likely asthma. So in some special conditions, in mild or early airway obstruction, the classic reduction in FEV1 and FEV1-FVC ratio may not be seen. The morphology of the flow volume curve can give a clue, as the distal upward concavity may show to be the more pronounced or prolonged. And another clue is the prolonged FET, that is force expiratory time, evident in the time volume curve. It may extend up to the 20 seconds in cases of prolonged expiration. In emphysema, and because of the loss of supportive structure tissues, the airway tend to be collapsed significantly at low lung volume. So there is a characteristic dogleg pattern in the flow volume curve. So this is the typical dogleg pattern of flow volume curve. So in allergy practice, for spirometry, we have a definite role, but limited but definite role, that we have to prove that whether this patient of bronchial allergy is suffering from asthma or not. We can also do some bronchoprovocation test with the help of spirometer device alone. I'm not going to the detail, but that is also an important integral part of diagnosis of asthma or bronchial hyperresponsiveness in an allergic person. Coming to the pheno, actually nitric oxide has a definite role in airway smooth muscle as well as the airway vessels. So both of by nitric oxide, both the bronchial muscles and vascular tone, they are dilated, and it also facilitates the coordinated beating of the cilia within the airway, and it also acts as an important neurotransmitter for non-adrenergic, non-cholinergic neurons running through the bronchial wall. So FeNO can be measured, which varies in health and disease. So by FeNO, what we measure, we have certain criteria. FeNO gives some value, and there are standardized values. We can measure against these standardized values that whether it is normal or whether it is increased. Usually, FeNO is increased in the eosinophilic allergic reactions in the airways. So in cases of eosinophilic asthma, we can get the higher FeNO values. So effect of nitric oxide in the airway, the exhaled air of asthmatic individuals contain higher levels of nitric oxide than healthy non-smoking individuals. This is for sure. Exact role of nitric oxide in asthma is less known, but some studies suggest that increased nitric oxide relaxes the bronchial smooth muscle, leading to bronchodilation. It also inhibits pro-inflammatory signaling events. And nitric oxide may also have an antioxidant role in some consuming reactive oxygen species during the immediate asthmatic response. So nitric oxide has variable roles in the airways. Now, measurement of exhaled nitric oxide, we can do offline measurement, and we can also do online measurement. By offline measurement, we can use an apparatus to collect exhaled air without loss of any nitric oxide. In online measurement, we can obtain while the substance exhales at a constant flow directly into an analyzer. So there in the machine, there should be a nitric oxide analyzer, and that analyzer analyzes how much nitric oxide is exhaled by the patient. And that by this, they analyze and they put a value. The FeNO value is recorded over a 3-second plateau, but not at the early peak. So what are the clinical uses in asthma? Can FeNO be diagnostic for asthma? It is actually is not a diagnostic test, but it aids to the diagnosis, and it acts differently, acts in different ways, or it helps in different ways to diagnose the eosinophilic asthma variant, whether, and also is a very important tool to diagnose whether the asthmatic patient is steroid should be steroid responsive or not, and it can also prognosticate that the steroid response is adequate or not. So no single test can diagnose the asthma. The background pathology of asthma is often but not always the eosinophilic inflammation of the airway. So they are not synonymous. But FeNO in patients of eosinophilic asthmatic patients, the FeNO should be higher. It is often said that FeNO can be diagnostic for asthma, but in cases of asthma not due to eosinophilic inflammation, FeNO might be low. So it also occurs in cases of smokers where there is neutrophilic predominant inflammation. So in smokers, the FeNO value are falsely low. So you usually do not advocate FeNO test in cases of smoker. So nevertheless, the values of FeNO in predicting the glucocorticoid responsiveness is high, even in the absence of induced sputum eosinophilia. So there are some ATS recommendation, ATS 2011 recommendation of using FeNO. There's strong recommendation that the use of FeNO as diagnostic of eosinophilic airway inflammation. Again, this is a strong recommendation, the use of FeNO in determining the likelihood of steroid responsiveness in individual with chronic respiratory symptoms, possibly due to airway inflammation. And there are weak recommendations that suggest that FeNO may be used to support the diagnosis of asthma in situations where objective evidence is needed. So we can get some objective evidence by measuring FeNO. So these are the normal values versus some relevant cutoff points for FeNO. For adults, it is 50 parts per billion. Now the cutoff point, if it is less than 25 parts per billion in cases of adults, or if it is less than 20 parts per billion in cases of younger children, less than 12 years, it implies the absence of eosinophilic airway inflammation. So less than 25 for adult and less than 20 for children. Now, if it is more than 50 parts per billion in adults or more than 35 ppb in children, it suggests that it is some eosinophilic airway inflammation is going on. And if it is between 25 to 50 in cases of adults or 20 to 35 in cases of children, the test should be repeated or interpreted cautiously with reference to the clinical situation. So again, we have to go to the history, whether there is a possibility, high possibility or probability of eosinophilic inflammation or not. Can FeNO be used to monitor airway inflammation? Yes, there are again some recommendation from ATS. The strong recommendation is that to use FeNO in monitoring airway inflammation in patients with asthma. Weak recommendation, rather a suggestion that determine significant increase in FeNO if greater than 20% for values over 50 ppb or more than 10 parts per billion for values less than 50 ppb from one visit to the next. This is a weak recommendation. So more than 50 parts per billion, whoever showing values, initial values more than 50 parts per billion, the increase in FeNO more than 20%, or whoever showing less than 50 parts per billion, for them is more than 10 parts per billion, it signifies that the disease has increased. And the weak recommendation is that reduction of at least 20% in FeNO for values over 50 or more than 10 for values lower than 50 as a cutoff point to indicate a significant response to steroid therapy. Versus steroid therapy, the recommendation, though weak, but we can interpret that whether the value is 20% reduced from the initial value or not in cases of people who are showing FeNO value more than 50. So in a nutshell, by doing spirometry or and or FeNO in cases of bronchial allergy or asthma, in cases of spirometry, it should be interpreted with caution. The clinical diagnosis should not be entirely given based on only spirometric diagnosis. Spirometry may help in diagnosis of COPD, but as asthma being a clinical diagnosis, other factors to be kept in mind. Borderline abnormal values to be interpreted with caution. And before commencing to the diagnosis, quality of the test should be kept in mind because it is an effort-dependent test. And in cases of Pheno, where we can use a pheno in allergy to assess the etiology of respiratory symptoms, to help in identifying the eosinophilic asthma phenotypes. This is the most important indication to assess potential response or failure to therapy, especially for ICS, to establish a baseline value for subsequent assessment of chronic persistent asthma, to guide the change in dose of anti-inflammatory agent and the time to stop it, to evaluate the adherence of therapy, and to assess whether airway inflammation is contributing to the poor control, particularly in presence of other contributors. So thank you all.
Thank you, Dr. Surojit. Thank you very much for your technical presentation, rather to say. So, friends, we are at the end of this session, almost at the end of session. So our last speaker is Dr. Aratrika Das. She will speak on the topic, the role of laboratory investigation in diagnosing and prognosticating allergic disorders. Dr. Aratrika, please. Please make it slideshow mode, please.
Hello, Dr. Aratrika Das. Madam, are you there? Let me call her. Yes, madam is joining. There is some technical glitch from her side. So, Dr. Aratrika Das, she is a consultant pulmonologist and allergologist at Allergy and Asthma Treatment Center, Molali. And she had done in MD in pulmonary medicine, then DETRD from Mumbai and FCCP. She had also completed DAA, Diploma in Allergy and Asthma from CMC Vellore. So now she is also attached with RN Tagore International Institute of Cardiac Sciences, Kolkata. So as there is some technical glitch, I think madam is joining soon. From her side, there is some internet problems. So let's wait for 1 minute, then we'll start our presentation.
Dr. Shamasdar, are you there?
Yes, I am here.
So can we take some questions if the delegates are having some questions?
We can take some questions.
We can take some questions. By the time Dr. Das is ready for her presentation, we can take some questions.
So may I request our delegates to type your question, or you may unmute yourself and may ask. I think it is better to type your question in the chat box. In between, we can address those questions to our respective speakers. I had a talk with Dr. Aratrika Dash. She is joining soon. So in between, we can welcome some questions. Our topic is on role of lab investigations in diagnosing and prognostication of allergic disorders. But the initial talk by Professor P.K. Vedantan from Colorado University, USA, he had clearly mentioned to diagnose allergy, the most important three things, that is number one, history taking, number two, history taking, and number three, history taking. There is very minimal role of these lab investigations and other diagnostic things. History taking is most important one, but I think yes, there may be some role of different lab investigations, and Dr. Aratrika Das madam will let us know about that. We are very sorry for this technical glitch, and this is, we all know, very common with this type of platforms. So let's wait for 2 minutes. Otherwise, we may have to proceed for our next presentation.
Dr. Samazzar. Hello. Hello, Dr. Shambhu Samazzar. Can you hear me? Hello, Dr. Shambhu Samazdar, can you hear me?
Yeah. Hello. Am I audible?
Yes,
Yes, madam,
Hello.
you are audible.
yes, you are now.
Am I audible?
Yes, madam.
Yeah. How? But it's not sharing the whole screen now. Yeah. But my presentation.
Yeah, we can hear you now, Dr. Dash.
Okay. Now the presentation display. I think.
Yeah, you have to share
is
your
the one.
screen.
Yeah, that's what I'm doing. Yeah, but it's not sharing the whole screen then. Yeah. Now is it okay? Hello.
Yes, yes, it is okay.
Okay. So, shall I proceed?
Madam, it is not full screen. You have to do full screen.
Yeah. So how do I do that? That it's not sharing properly. New share.
Shambhu, please help her.
Yeah, hello. We can see your screen. You have to make it full screen.
Now, okay. Let me see.
So you can find there is one
Slide share icon. Yeah.
Yeah.
Now is it okay?
Yes, it's okay.
Okay. Thank you. Okay. Good morning, everybody. And I am Aratrika Das, and our Allergy and Asthma Center has been doing great work on allergies for a long time. So today the topic I have been given is laboratory investigations in allergic diseases and also prognostication of allergic disorders. Pardon me for a croaky voice today. Okay. Now, before we start, I'd like to share some very few details on the statistics, epidemiology. That is, the incidence of allergic diseases is definitely rising, and in fact, it's becoming 3 times in last 20 years. And in especially Asia, Southeast Asia, India, the incidence has risen all the more. Now, why is it increasing? So is it because of genetic predisposition, or because of environmental changes, because of migration of people, decreased exposure to infectious microorganisms, that is almost negating the hygiene hypothesis? Or is it because of the more of Western lifestyle that we face? So this is a very, very favorite slide of mine. This is basically the overview of the main research developments in the fields of allergy and clinical immunology. And what we see is when we go from the outer circle to the inner ones. So initially, when we try to address allergies, we look at the epidemiology. Pathomechanisms have been detailed discussion yesterday. And plenty of newer generations of molecules have come up which signify the pathomechanism of allergic disorders. And why do we need to know that? So that we know exactly what are the points in diagnostics we should address so that we come to a final diagnosis. Diagnostics is something which I'll be talking about today in a nutshell, and therapy is further on. Now, in diagnostics, when you come to this diagnostics part, the first is individual history taking and clinical examination. Now, Dr. Vedantan, who has also been a teacher of mine, has made a wonderful, very interesting discussion on a mundane subject like individual history taking, and it's been covered by him. So what do we do after history taking and clinical examination? Go for a skin test, go for certain sensitization tests. What are sensitization tests? I'll tell you. Go for the skin test or go for IgE test in blood, specific IgE levels to different allergens, or go for a basophil activation test. And the next step will be, we know what the person is sensitized to, so we go for the interpretation. How significant is that sensitization? And to get a final result, a challenge test is usually needed, especially in case of food allergies. And finally, of course, how they conglomerate and give us an idea on therapeutic consequences. So the investigations. So when we talk history, as I said, has already been done by Dr. Vedantan. Laboratory tests, they are basically in vivo tests are there. There are in vitro tests also. Now, in vivo tests are like the skin tests. And when we talk about skin tests, what do we tend to see in the skin tests? Yesterday, we have had a lot of talks on mast cells and certain immunoglobulin E, immunoglobulin G, etc. So what do we do in case of skin tests? We inject a certain amount of the allergen extract in the skin, and we see the reaction to that injection. As we find these wheals formed here, and they are also surrounded by some amount of rubber. Now, in this skin test, we basically tend to measure the amount of immunoglobulin E, which are attached to the mast cells. And positivity in skin test does not mean definitely that the patient is allergic to it. It means that the patient has been sensitized to it. This is the way a scratch test is performed. This is also a type of skin test. It is known as the prick test and done by placing a drop of solution basically on the forearm. That's the preferred site, and then we prick it at maybe 45 degrees inclination or 90 degrees inclination, and we see the amount of wheal that is produced there, measure the wheal and compare it with the negative solution as well as the positive solution. There is another type of skin test, which is the intradermal test. Intradermal test means here what we do is we take the solution, we take the extract. This is in a larger dose, diluted, and we inject it intradermally. This is primarily, of course, usually we do this for drug allergens. An intradermal allergy test may be done when a substance does not cause a reaction to the skin test, but we still suspect that that particular substance may be responsible for this patient's allergy. So first, we go for the skin test. No result, we can still go for intradermal tests if we suspect that substance to be the culprit. So diagnostic test may be important for disease management, but diagnostic test, I wouldn't say does not have a prognostic value, does have, but a sort of borderline prognostic value. Patch test, this is another type of skin test. For a skin patch test, the allergen solutions are placed on a pad which is taped to the skin for 24 hours, sometimes even for 48 to 72 hours. And this basically detects those antigens which come in contact with skin and cause allergic or contact dermatitis, not exactly allergic, contact dermatitis. Next, we come to the blood tests. Blood tests basically detect specific immunoglobulin which are there present in the blood to the particular allergen. So what is done here? This is done by certain different techniques. And the most common technique used is ELISA, or enzyme-linked immunosorbent assay. It measures the blood level of a type of antibody, that is immunoglobulin E, that the body may make in response to certain allergens. Immunoglobulin E levels are often higher in people who have allergies or asthma. So this is the pre-immunoglobulin level which are present in the blood. Other testing methods are like the radioallergosorbent test, or maybe the immunoassay capture test. And they are supposed to be more authentic, more specific than the ELISA test, but definitely as far as sensitivity is concerned, as far as sensitivity is concerned, the skin prick test is actually more sensitive than these blood tests. So when do we do a blood test and not a skin prick test? Whenever there is a risk of anaphylaxis. If there have been issues where the patient had undergone a skin test earlier and had severe hives or eczema developed, or there is extensive eczematous skin is already present where we don't get a clear skin for the skin test. The patient is already on many medications like antihistaminics, tricyclic antidepressants, maybe beta blockers, ACE inhibitors, other immunomodulatory creams, topical steroids, not systemic steroids. Topical steroids, even nothing can actually stop us from doing the blood tests. But for skin test, all these medications like antihistaminics, tricyclic antidepressants, topical steroids, not systemic steroids, of course, they should be stopped. But skin blood tests, as I have already mentioned, are less sensitive than the skin test, and they are more expensive too. Now, routine measurement of circulating allergen-specific IgE antibodies in the patient's sera was basically initially done by this radioallergosorbent test. This used a radioisotope detection method. And this has been superseded with detection now taking place using the enzyme-based methods or the fluorescence-based method. The methods used employ allergens, a mixture of allergens, which are on a solid phase support. These allergens or extracts are on a solid phase support. And that is incubated with the patient's serum, and the patient's serum contains the specific IgEs which bind to the allergen on the matrix. This is then washed to remove unbound immunoglobulin E, and a second labeled anti-IgE antibody again is used to detect the bound IgE. Now, this method is definitely a very robust method and fully quantitative, but again, this is somewhat less sensitive. Unlike skin prick tests, the intradermal tests, these methods detect free specific IgE, not the mast cell bound fraction, and it is assumed that these are proportionate to the amount of allergy that is seen. Advantages of the blood tests: they are not exposed, patients are not exposed to the allergens. There is no interference, as I have already said, with the drugs that the patient is already taking. And again, these tests actually, the blood-based serum IgE monitoring, this particular test does not have any contraindication as such. The only difficulty is, in this case, there is some amount of discomfort due to phlebotomy, and of course, that's the only most important discomfort in this particular test. Specific IgE can be assessed to a wide range of allergens from a single blood sample, and a large test menu is available. Disadvantage, as I said, for venipuncture And again, in all these tests, there are basically a mixture of allergens which are used, and that can give misleading results. So, because the amount of any single allergen in a mixture can be limiting, or it can give certain false positive results also when the patient's serum contains low levels of specific IgE antibodies recognizing many components of the mixture. One mixture might be containing many other components also, which may be allergenic to the patient. So this can give a false positive result too. Again, it can give falsely low result also, because the antigen that is present in the extract can be in very low quantities to be detected as serum antibodies in the serum test. Some individuals have IgE antibodies to non-pathological cross-reactivate carbohydrate determinants, resulting in apparent false positive results. For example, amongst Bengalis here in India, Bengalis do have a lot of khaskhas in their food. Now that shows cross-reactivity with potato. So if we do the serum IgE test and the test turns positive for potato, we may not be sure whether the patient is positive for potato or for that khaskhas, which is also used very commonly. IgG antibodies to the allergens, especially when present in a very high titer, can compete with IgE antibodies for binding to the allergen, giving rise to falsely low results for specific IgE. There are certain additional tests in assessment of suspected allergy, like the eosinophil count, relatively non-specific finding, but in case of allergic asthma, eosinophil count is an important entity to be taken into account, and also in various eosinophilic syndromes. Again, eosinophilic cationic protein. Now, this is produced by activated eosinophils. This is a protein component. High levels of eosinophilic cationic protein occur with more eosinophil activation, such as with fungal upper and lower respiratory tract disease, eosinophilic esophagitis, bronchial asthma, atopic, and primary hypereosinophilic disorders. Serum tryptase level. Serum tryptase levels are very important in case of anaphylaxis, because within 1 to 2 hours, the serum tryptase level rises and then reaches the peak after 2 hours, and then comes back to the baseline level within 6 hours. Now, how much should the tryptase level rise to make it sound significant? The elevated tryptase level should be greater than 1.2 times the baseline tryptase plus 2 microgram per liter. Baseline tryptase is a marker for mast cell number, and in case of mastocytosis, baseline tryptase levels are quite high. So if we don't know a patient is having mastocytosis or not, and the patient is exposed to certain allergen, there can be severe anaphylaxis, especially in case of food allergies. We see this very commonly, or even in case of insect stings. There can be very severe anaphylaxis to that particular antigen if the baseline tryptase level is high. So these are the traditional, whatever I have shown you, are the traditional methods and well-proven method of detecting allergies. Now, there are certain newer diagnostic methods which we should also know when we are discussing diagnostics of allergy. For example, a nanofluid assay. What is it? It measures 5 allergens maybe, which which achieves 81% agreement with a conventional serum IgE test. And maybe if we take the clinical history properly of the patient, a skin prick test, serum IgE measurement, and combined with the nanofluid assay, we can be 95% sure of the diagnosis. The CAP inhibition test. Now, what is this? The CAP inhibition test produces the most accurate results in evaluation of double sensitization. Now, what is this CAP inhibition test? Excuse me. It is basically, it depends on certain molecular tests. And this, in case of doubles, if a patient is sensitized to two different antigens, in that case, this CAP inhibition test is very important to be done. It is still in the process of coming in the market. This cannot be replaced by alternative tests like SPT or even molecular diagnostics. And the basophil activation test is actually a diagnostic method which is an alternative to skin tests based on the finding that values for the basophil activation percentage and the mean stimulation index for CD203C expression. CD203C expression is basically with another platinum-based molecule, oxyplatin, higher in those patients with hypersensitivity reactions than in control. So in patients with drug hypersensitivity reactions, the basophil activation test was shown to be effective in differentiating adverse drug reaction from actual allergic drug reactions. So in case of drug reactions, this basophil activation test has been shown to be very important. D-dimer levels, which are used in plasma, serum D-dimer levels, they are especially useful in chronic urticaria, and they correlate with disease severity, may also serve as biomarkers indicating clinical response to omalizumab therapy. The patch test, which I have already shown with food allergens. In fact, patch test is traditionally done with those antigens which are which cause contact dermatitis. But now, even in food allergies, patch test has a diagnostic value, and it is in fact done with, say, cow's milk, egg, wheat, soy in children. With the development of the newer matrices, as part of antigen use or allergen use, a long-term application of food challenge test with the placebo has been shown that this patch test, atopy patch test with the newer matrices have proved to be very safe. Now, compared to skin prick test, allergen molecule-based diagnostic testing allows just a molecule-based. In most of these allergen tests, there's an allergen mix. So in the molecule-based, it is more specific for a particular allergen, and that gives a more precise prescription for allergen immunotherapy. So this also has its own place in the diagnostics of allergies. So what is this molecular allergology? What is it about? The use of single allergenic molecules instead of the extracts have been introduced as a new area of high resolution molecular allergy diagnostics. And this has advanced the diagnostic sensitivities and specificities for allergens in various types of allergies. So this has been introduced. I mean, this is in the process of being introduced in these tests, like, for example, the diagnostic workup and targeted a single molecule or it can be multiple molecules also, a multiplex. Molecular-based IgE testing is actually shown here. After sensitization testing with the SPT and IgE test and or the basophil activation test. Second, IgE testing with selected molecules have to be done. And this can actually, the diagnostic, this is known, and then we interpret it and come to therapeutic consequences. And this particular diagnostic approach is basically called a top-down approach and is followed by a thorough interpretation, including challenge test also if needed. This is basically a top-down approach. Now, unfortunately, this particular slide has been changed. I think we have to turn our head to look at this. I could not make it stand straight. Now, this is a diagram basically shows this is a combined diagnostic workup of a top-down and bottom-up approach. What is this bottom-up approach? Where we do the allergy test, molecular test, go on to the skin prick test, and come to a therapeutic conclusion, the history. Now, combined diagnostic workup with top-down and bottom-up approach starts with the history, extract diagnostics with SPT, with serum tests, and with basophil activation tests. Then the molecular diagnostics and subsequent application of extended molecular panels, which actually contain many other allergens, further differentiation of allergenic specific IgE repertoire. This approach is called U-shaped approach and has been proposed in complex cases. In spite of the traditional tests as well as the molecular diagnostics, we can't come to a conclusion. In that case, both the up-down test as well as the bottom-up test will have to be taken into consideration. Now, apart from these tests regarding molecules and certain allergens, we have to actually tell us about inflammation in the airways. So, in case of type 2 and in case of non-type 2 asthma, excuse me, the main cytokines which we can detect in type 2 are IL-4, interleukin-13. They are the ones which are responsible for this type of asthma. And they are actually produced by the Th2 cells, the helper T cells, the interleukin C2 cells, and the mast cells. And large proportions are elevated in total IgE is also elevated, and along with specific IgE levels. But in case of the non-type 2 asthmatics, cytokines and cells are not very well characterized, and in them IL-4, 5, 13 are not the main players. In fact, in these cases, polymorphonucleosides are known to be elevated. So how these inflammatory biomarkers are utilized? They have been shown to play an important role in predicting severity and responsiveness to certain therapies. Because nowadays we have a lot of therapies on hand, like and especially where the eosinophil as well as the neutrophilic types of asthma are concerned. And to get the best out of these therapies, we need to do these inflammatory markers because they will play an important role in deciding which molecule to take up for treatment. Eosinophils is an inflammatory biomarker. Variable number of blood and airway eosinophils are present with patients with type 2 cytokine profiles. And basically, they relate to the level of type 2 reactivation, type 2 activation. So basically, eosinophils are supposed to be measured both in the blood as well as in the sputum, though the latter, sputum eosinophil measurement, is definitely a highly specialized affair. Sputum and blood eosinophils correlate with bronchial type 2 cytokine mRNA. If I look at this small table, in case of sputum eosinophils, if it is 2%, the sensitivity is 54%, but specificity is 100%. But in case of blood eosinophils, sensitivity is 76%, which is very high. And specificity is 100%. See, in all these cases, specificity level is 100%. So this is just a table showing how severity of asthma, severe exacerbation of asthma varies according to the to the number of eosinophils in the blood or in the sputum. Now, sputum eosinophils identify patients even with frequent asthma exacerbations. Like if the ICS dose is 800 in a non-frequent exacerbation, sputum eosinophils may be 8.2%. But in frequent exacerbations, betas who consume ICS to the tune of 1700 and a large amount of oral corticosteroid dose, in them we find sputum eosinophil percentage almost 25. Means it's almost 3 times in non-frequent exacerbation. Sputum neutrophil is an inflammatory biomarker. In certain subgroups of asthmatic, sputum neutrophils do rise. Most often they are in combination with eosinophils, but may occur as isolated neutrophilia. Factors that influence polymorphs count in sputum are use of inhaled corticosteroids, air pollution, that's another very important factor. It has been discussed yesterday by Dr. Salve. Lower respiratory tract infection, fungal sensitization, and also gastroesophageal diseases. They can cause, like reflux esophagitis, can cause a rise in polymorphs in the sputum, and they correlate with higher levels of asthma severity also. Serum proteins, certain serum proteins. Cytokine protein measurements in blood and sputum are difficult. They may not be accurate, but there are certain surrogate markers which indicate predominant cytokine profile in lung. Airway IL-13, interleukin 13 is found to correlate with epithelial proteins, periostin, and dipeptidyl peptidase 4. So this particular interleukin 13 is secreted by airway epithelium into the blood. As they correlate with periostin, which is an epithelial protein, so that is probably, that also can give an inkling to obesity-related asthma. Initial studies which are on the way show a good correlation with interleukin 13 and predictive of response to anti-IL-13 agents. Uncertain, of course, whether they will be employed as biomarkers in the future. Exhaled nitric oxide is a marker of type 2 pathway. Yes. Oh, have I crossed the time? Yeah, I think I'm on to my last slide.
Okay, thank you.
So thank you, because the exhaled nitric oxide has already been elaborated by Dr. Surajit Chatterjee. So I have come to the end of my talk. Thank you for your attention. And I think by giving a sneak peek into the recent advances in diagnostics, I'm able to actually excite many inquisitive minds here. Thank you.
Thank you, madam. Thank you very much. So as we are running short of time, we have to move fast a little bit. And now we have our oration lecture. And to give the oration lecture, we are really fortunate to have Dr. Gagandeep Kang. So may I request Dr. Arijit Das, Professor Shantanu Kumar Tripathi, and Dr. Aratrika Das, madam, to chair this session. That is Professor Sunirmal Chando oration lecture. So may I request our respected chairpersons, Professor Shantanu Kumar Tripathi, Dr. Arijit Das, and Dr. Aratrika Das to chair the session. That is Professor Sunirmal Chando Memorial Oration. The topic is on SARS-CoV-2 infections, vaccines, and the immune response. Little bit information regarding Professor Sunirmal Chando, because the Allergy Asthma Research Center, we are really fortunate to have the legacy of Professor Sunirmal Chando, who was a great teacher, who was a great scientist, and a very renowned in the field of allergology in India. So he was the first president of East Himalayan Society for Spermatophyte Taxonomy, and he was also attached with multiple societies related to palynology, aerobiology, paleobotany, pollen chemistry, immunobiology, plant ecology, and biodiversity. So with that, may I request Dr. Aratrika Das Madam to introduce Professor Gagandeep Kong.
Thank you, Dr. Shambu. And it's definitely my pleasure to introduce Dr. Gagandeep Kong, with whom I have studied in school. Is it? Anyway, Dr. Gagandeep Kong has a huge degree which will take a lot of breath and respiratory effort to pronounce: MD, PhD, FRC PAC, FFPH, FAAM, FASC, FNASC, FNA, etc., etc. And she is an alumnus of Christian Medical College, Vellore, professor of microbiology. She has been an adjunct professor of Tufts University School of Public Health. She has got plenty of research interests, including enteric infection diseases. In fact, she is one of the persons to pioneer the manufacture of rotavirus vaccines in India. And typhoid, cholera, SARS-CoV-2. She is seen every day almost on social media as she speaks on newer innovative researches regarding coronavirus. She has more than 400 publications to her merit, and a large international and national collaborative research programs are on under her guidance. Dr. Gagandeep Kong is an advisory committee in the advisory committee for government, WHO, and several international agencies. So, Dr. Kong, I won't hold you back for a longer time, and we all are waiting with a bated breath to listen to your lecture. Dr. Gagandeep Kong, please.
Thank you very much for the introduction, Aratrika. Can you let me know if you are able to see my slides?
Yeah, I am. No, the slide share has to be there. Slide share is not there.
It's showing now. Can you see them?
No.
No.
I think you'll have to stop sharing the other slides so that I can put these on. Let me try it again. Can you see the slides now?
Yes.
Yeah.
Yes.
Okay. So thank you very much. It's an honor to be asked to deliver the Professor Sunirmal Chando Memorial Oration, and I'm going to be talking to you today about SARS-CoV-2 infections, vaccines, and the immune response. Since I have just 25 minutes, I will move quickly. So this is a virus that we are all familiar with. A year and a half, almost 2 years now into the pandemic, we are all familiar with the fact that coronaviruses are viruses of which we have multiple representatives that have been seen in humans in the past, that among the most pathogenic coronaviruses, SARS-CoV, SARS-CoV-2, MERS, it is the spike protein that is critically important. And in the spike protein's trimeric structure, there are two components that really matter. One is where you have the binding to the ACE2 receptor, and the other is where you get the fusion of the cell the viral membrane with the cell membrane. So you have the ACE2 binding with the receptor binding domain, and then in the stem of the spike is where you see the fusion peptides. Now, in order for these fusions to take place, there needs to be interaction with the number of cellular proteases. The best known ones, of course, are TMPRSS2, but there are other proteases that also matter, including some that are common for other viruses like trypsin. Once the SARS-CoV-2 gets inside cells and the RNA payload of the virus is released, that then takes over the cellular machinery. And SARS-CoV-2 has a very, very large genome. Among RNA viruses, one of the largest genomes possible. And this encodes for over 25 proteins. And it does this in a very interesting way, where you have the same open reading frames that encode the early parts of the genome, but then to make individual proteins, you get translation from different subgenomic mRNAs, which results in the production of all the proteins that are responsible for creating new viruses, as well as for the function of these viruses in replication. Now, the virus itself is a virus that infects a number of cells in the body, everything that has an ACE2 receptor, but it also has a particular predilection for endothelial cells, and that's what results in a lot of the pathogenesis of the virus. I'm not going to walk you through each of these slides demonstrating how and where the presence of the virus and the damage to cellular tissue has been demonstrated, both in terms of biopsies from people who were ill, but also from autopsies. But to summarize all the pathophysiological processes, this is a virus that is truly protean in its ability to cause damage. There is direct virus-mediated injury to epithelial cells. There's endothelial activation and damage. This can result in micro and macrovascular thrombosis. There's complement activation and deposition. There's complement-mediated cell lysis. In addition to that, we see cytokine-mediated injury. In severe disease, we see widespread neutrophil netosis, hyperactivation of RAS. We see autoimmune manifestations, which may be partially responsible for what we see as the long COVID syndrome, and then the clinical manifestations are across a range of different organ systems and presentations. It's very clear that despite the fact that we've been working on this for near on 2 years, we have learned a lot, but we do not completely understand what leads to moderate or severe disease. And there are multiple endophenotypes of disease. Now, coming to vaccines, everybody is familiar with the older technology platforms shown in the top row here, where you have inactivated vaccines, virus-like particles, and just protein vaccines. But we also have had, for the very first time, 3 different new kinds of platforms on which vaccines have been made. These have been vectored vaccines, as seen in India with the Covishield vaccine and with the Johnson & Johnson vaccine that is being made by Biological E. We have the DNA vaccine that's made by Zydus Cadila. We have the RNA vaccines already made by Moderna and by Pfizer-BioNTech, and in India in development with Genova in Pune. Now, why has it been so easy for us? We've never been in a situation before where we have had so many vaccines against a single disease. Why has it been so easy for us to be able to make these vaccines and to make them so quickly? The main reason for that is because of the work that was done prior to the pandemic, where we had learned many lessons from other coronaviruses, where we had identified that the spike protein was the critically important protein for prevention of infection of host cells, that if you could interrupt binding to the spike protein, particularly to the receptor binding domain of the spike protein, you would reduce the pathogenesis of the virus. So taking those lessons from what work had been done with SARS and MERS, it was possible to design across the range of platforms vaccines that largely focused on the spike protein. And the fact that our hunches that this was going to work was correct is shown by the efficacy and effectiveness data that we have seen with the vaccines that are currently in use. Now, if we look at SARS-CoV-2, the question now is being raised about the fact that although the vaccines that we have prevent severe disease and death, the protection from infection and the protection from transmission tends to be a little bit limited. So you see very good protection against transmission for the first 3 months or so after people are vaccinated. These are data mostly from mRNA vaccines, and after that, protection from infection drops by about 20%. Now, this has resulted in a widespread use of boosters in countries where they can afford to use boosters and where they are very interested in lowering the transmission of the virus. In India, of course, we are taking a different approach where we are looking at developing new vaccines, including vaccines that target the nasal tract in order to be able to think about limiting transmission. Now, if we look at the pathogenesis of SARS-CoV-2, there are a couple of things that are really important for us to understand in terms of the immune response. So when the virus is largely limited to the nose, and this is in the first few days after infection, you have mostly asymptomatic disease or very few symptoms. When you see spread to the oropharyngeal tract, you begin to see more flu-like illness. And disease becomes more severe as you get greater infection of the lungs. Now, this usually takes somewhere between 10 days and 2 weeks. And this is an advantage in that the early infection tends to be very localized, and it is in later disease that the infection becomes much more widespread to the lungs and then to subsequent organs. This is important for us because it means that there is time for vaccines to work. And particularly if we are thinking about memory responses, there is sufficient time for vaccines to be able to summon up a memory response when it is needed. So overall, what have we learned about SARS-CoV-2 and the immune response? We've learned that the immune response behaves pretty much as we had expected. SARS-CoV-2 infects through the upper respiratory tract, goes into the lower respiratory tract, can become symptomatic, can become systemic, spreading all across the body. And the kinds of antibody responses that we make and T-cell responses that we make are very similar to those that are seen with other respiratory infections. So for example, almost everybody who gets infected makes an IgG response. When you measure a local IgA response, that's seen in about 80% of people. And if you look at the cellular compartment of the immune response, you see CD4 cells in almost everybody that react to spike proteins, to matrix, to nucleocapsid, and to non-structural proteins. You see somewhat less of a CD8 response, but in about 70% of people, and this can be to most of the major proteins to which CD4 cells also respond. In addition to that, you also see cross-reactive responses in T cells in people who have been unexposed. And this is believed to be because of people who have been infected with common cold coronaviruses previously. And one of the early hypotheses was that we saw less disease in children because children had higher rates of recent seasonal coronavirus infections. Now, what can these responses to common coronaviruses do? These may modify our responses to infection or to vaccination. So when we study the immune system, it's important that we look not only at responses specific to SARS-CoV-2, but also to other coronaviruses. So what is it we study? First and most important, we study antibodies. And in order to study the longevity and functionality of antibodies, we also look at memory B cells. And then we look at cellular responses, CD4, CD8 responses, and also at T cell memory and T follicular helper cells. Now, what mediates protection against SARS-CoV-2? Pretty much as expected, pretty much as we knew from SARS-CoV-1 and from MERS, is that when we wanted to make a vaccine, we wanted to make a vaccine that would give us high-level, long-lasting, neutralizing antibodies. And this has been proven over and over again. This virus is susceptible to neutralizing antibodies. Antibodies do protect against COVID-19 in humans and animal models. This has been demonstrated by passive transfer experiments that have been done in primate models. It's also been demonstrated that if you can get convalescent plasma into people in the early days of infection, and that convalescent plasma has high levels of neutralizing antibodies, there is some mitigation of disease. It's not a good treatment, but in terms of the proof of principle that antibodies matter, that was our first evidence. Of course, we now know from the monoclonal antibody therapies that are available that antibodies do work to prevent progression to disease. Now, antibodies are the only mechanism that could provide truly sterilizing immunity. And from the early data from mRNA vaccines, we know that that happens. It doesn't last for very long, but you do get in the early days after infection against some of the variants like alpha variant and the ancestral variants, you can get pretty close to sterilizing immunity, and it could only be antibodies doing that. We also know that antibodies correlate with protection from symptomatic COVID-19, and we know that antibodies are a correlate of CD4 cells. Neutralizing antibodies depend on T cell help. So antibodies are a surrogate marker of vaccine-specific CD4 cells, at least for T follicular helper cells. Now, these are data that are taken from multiple vaccine trials, where essentially what you're looking at is in vaccination, how much more neutralizing antibody do you make compared to convalescent sera, and what is the protective efficacy of the vaccine. So the red line is just showing you all the various vaccines, the amount of neutralizing antibody made plotted against the protective efficacy of the vaccine. You can see that the inactivated vaccines have the lowest efficacy, except for Covaxin, which seems to have a higher efficacy. And this may be due to the adjuvant that Covaxin has. But the highest level of antibodies and the highest level of protection that was seen in phase 3 trials were really with the mRNA vaccines. And shown here in these diagrams is essentially what proportion of people had neutralizing antibodies and how much protection they saw against disease. So first, we saw that antibodies are protective. And the second thing we need to look at is, what do T cells do? Now, if we look at contributions of T cells, we know that T cell responses correlate with better outcomes and lower viral loads in SARS-CoV-2 infection. If you remove all antibodies, you know that with CD8 cells, you can provide control of virus replication in primate models. There have been other studies that have looked at people who don't make antibodies and have shown that in them, there is only a moderate increased risk of hospitalization with COVID-19, indicating that T cells may be giving some protection. If we look at the dose 1 data from the Pfizer and Moderna vaccines, we see that there was substantial protection, even though antibodies really started to be made with the mRNA vaccines after the second dose of vaccine. We also know that T cell responses to vaccines in non-human primates correlated with lower viral loads and with better outcomes in challenge studies. And T cells have been measured as potential correlates of immunity, but not been demonstrated. So it's been shown in animal studies, but has not been shown so far in human studies. These are studies that are still ongoing. Now, if we look at T cell responses and look at associations with severe disease, when we look at both T cells and antibody responses in average cases of COVID-19, that looks pretty much like the pattern that we would expect to see in any viral infection. And this combination of antibody and T cell response seems to be what contributes to the controlling of SARS-CoV-2 infection. And the stronger both arms of the immune system are, the better it works. However, one of the things that it's really important for us to remember, and one of the reasons why we see lower performance of vaccines, is because of what happens to T cells with age. Dana-Farber has shown that once you're over the age of about 40, the amount of T cells that you have starts to come down. And this correlates pretty well with what we see in SARS-CoV-2 with age, where what you get is lower protection from infection, as well as lower vaccine responses in the older age groups. So if we look here at the figure, this one is from Dana-Farber's lab, essentially showing that there is a huge decline in naive T cell responses with age after the age of about 40, and certainly by 60, you see much lower numbers. And then again, if you look at naive CD4 and CD8 cells, as people get older, you see that they make fewer T cells. And those fewer T cells correlate very much with disease severity. Now, if we look at the next important question, not only about how strong is your immune response, how long does it last? Again, the ways we measure it is by looking at memory cells, antibodies, and the presence or absence or relative presence of T cells. And this has been studied particularly by the groups of Alexander Sette and Shane Crotty, working at the La Jolla Institute of Immunology, where they have followed up cohorts of individuals from the early days of infection, as well as have started to study vaccine responses, where they've essentially shown that you do make good antibody responses, good T cell responses to infection and to vaccination. And if you have a functional immune system, then you make really good germinal centers as well. and that leads to the formation of a solid memory response. That memory response can be measured following people up after infection. And if we look at CD4 cells here, you can see that memory CD4 cells decline only a little bit out to 8 months. If we look at memory B cells, we see another interesting phenomenon where you actually see that the B cell memory response matures over time. Not only does it not decline, it actually improves with time. And this speaks to one of the reasons why you would want to widen the gap between vaccine doses so that you maximize the value that you get out of every dose of vaccination. Now, if we look at data that came out from a study that was done with the Moderna vaccine, this is comparing with a low dose mRNA vaccine with what happened with the full dose and comparing it against natural immunity and with age. So this is just summarizing all the responses that were seen. So first, let's look at antibodies. You see antibodies going up with vaccination, and then the antibodies start to decline. If you compare that with natural immunity, the picture is very similar with vaccination and natural immunity. If you give a higher dose of mRNA, then you see more antibodies being made. With increasing age, you see lower antibodies. And if people already had cross-reactive responses to seasonal coronaviruses, you saw a higher antibody response. If you look at CD4 cells, and this is over a period of 7 months, you do see a decline in CD4 and CD8 cells with time. This is similar to what is seen in natural immunity. If you give a full dose of vaccine, it pushes up your CD4 cells, paralleling what you saw with antibodies, but doesn't do much for CD8 cells. And if you look at age-related responses, then they stay very similar across different age groups. And if you look at pre-existing T cells, again, the antibody and CD4 patterns go together, and the CD8 pattern is distinct. So if we summarize all of the data that has been produced so far, looking at what happens over time, and this is over a period of 6 months, if you had people who responded either by making antibodies or by making memory B cells or by making having an increase in CD4 or CD8 cells, at 1 month, what you see is that almost 97.5% of people have one or the other responses. And the bulk of them actually have all the 5 kinds of responses that are shown here. However, when you look at those people over 6 months, what you see is that while antibodies might decline, 95% of people still have at least 3 of the 5 kinds of immune memory responses persisting. So the hype that is going on now about booster vaccines is not taking into consideration the fact that we need to understand more about memory in the immune system than is generally considered. So to summarize, if we look at protection against detectable infection, the thing that matters the most is antibodies. And when you have high levels of antibodies, you have lower levels of infection. There's a minor component contributed by T cells, but if you look at protection against hospitalizations and disease, what you really need is all arms of the immune system, antibodies, as well as T cells that need to be in place for us to stay out of hospitals. What are vaccines doing? What vaccines are doing is, if there is a race between the immune system and the virus, vaccines give you a bit of a head start by making sure that you are primed and ready for the virus when it comes along. And finally, We know that we are so far able to handle variants quite well. And the reason for that seems to be that we can increase the breadth of our response with additional exposures or additional doses of vaccines. This has been shown both in terms of antibody responses and in the types of CD4 T cells that respond to multiple SARS-CoV-2 variants. So to summarize, the first and most important thing for any vaccine development is to make high levels of neutralizing antibodies. This happens with SARS-CoV-2 vaccines. T cells play an important role in protecting both in terms of a vaccine response as well as against infection. So if we look at infection and disease, then we know that protection from hospitalization, which is our key outcome, is prevented by a combination of antibodies, memory B cells, CD4 T, and CD4 and CD8 T cells. Thank you very much for your attention.
Thank you, Dr. Gagandeep. It had been a very inspiring, very exciting talk on COVID, antibodies, and how to proceed in future with vaccines. So, and we are really honored to have you here. Dr. Tripathi, would you like to say something, please?
There is some network issue from Tripathi sir's side, and as we are running short of time, madam, so we have to move to our next session, and we are really thankful to Professor Gagandeep Kong, madam, for this wonderful deliberation. We are really enlightened by this very important talk. So now may I request to start our next session. So the team Allercon, please project our next series of our next presenters. So the next talk is on gut microbiota, and specifically we are really blessed to have Professor Abhijit Hajra, who is a senior pharmacologist and in the very well-known figure in the field of pharmacology and medicine in all over India, to chair this session. And with that, we have also Professor Indranil Haldar, who is a very renowned pulmonologist in this country. And may I request Dr. Abhijit Hajra sir and Dr. Indranil Haldar sir to proceed for our next session, which will be on lung and gut microbiota crosstalk and impact on allergic disease. There is one modification in this slot. There is a second talk on gut, the talking point of microbes and host immune system by Dr. Abhijit Choudhury. But due to some unavoidable circumstances, Dr. Abhijit Choudhury could not attend today's session. So instead of him, later, maybe after at around 2:30, Professor Shantanu Kumar Tripathi sir will take that topic. So now the topic will be only presented by Professor Dr. Rajadhar sir. So over to you, Dr. Abhijit Hajra sir.
Thank you, Dr. Shambho, for giving us this opportunity to chair this session. Dr. Rajadhar is already here. Welcome. And I think he needs no introduction. We can see his slides, his focus there. So in the interest of protocol, I'll just highlight a few achievements of his career. So Dr. Rajadhar is presently serving as Director and Head of the Department of Pulmonology at the C.K. Birla Group of Hospitals, Kolkata. He's also the Director, Research Education at the National Allergy, Asthma and Bronchitis Institute, that's NOBI in Kolkata. He's presently Chair of Training and Education Initiatives at the Indian Chess Society. He's the ICS National Representative for the ERS. Now, also governing body member of the Indian Chest Society. Is a director of the first two Hermes exams Asia, which is a European diploma in respiratory medicine. Is a governing body member of the Indian Academy of Bronchology, joint secretary of the Indian Academy of Allergy, founder member of the Southeast Asian Academy of Sleep Medicine. He has a prolific research output, 124 international and national publications in international in index journals, along with 17 book chapters. He has been an associate editor for respirology and is on the editorial board for multiple other journals. He has won the Dronacharya Award for Excellence in Continuing Medical Education in India, and he has been the coordinator for DNB course in respiratory medicine in the state for the past 5 years. So welcome, Dr. Raja. Quite apart from what is written on the slide, we know him as a down-to-earth person, very knowledgeable person, and today he is going to enlighten us with this new and exciting topic of gut-lung crosstalk. Dr. Indranil, are you there? Dr. Indranil Haldar? Okay, so I don't see his name. I'll continue and hand over the microphone to Dr. Raja, who will enlighten us on this very exciting and challenging topic of how our gut microbiome, influences our immune system, our inflammatory cascades, and ultimately crosstalks with lungs, and their contribution of dysbiosis to respiratory diseases. Over to you, Dr. Raja.
Just give me one moment to visit that there's a noise upstairs. I'll just ask these people to stop. So just 10 seconds.
Okay. So, as we know, the human gut is host to, some say, 10 to the power 14 microbes, most of it bacteria, but also viruses, fungi, and protozoa. And I'm sure that there must be a reason why we are host to such commensals. And I hope Dr. Raja shares this with us, particularly with respect to the respiratory system. So please continue.
Thank you very much, Abhijit. Thank you for those kind words. It's a blessing for you to have you as a chairperson for my session. It's been a long time since I've seen you in the real world and others in the real world. So I'll be honest with you. I had to read most of the night last night because of the challenging topic that Shambhu and Shoibal have given me. I am a bit more aware about what I'm going to speak on today. My knowledge about the lung microbiome was limited to an extent because it's not really an area of expertise for me. But I have to thank all of you in the organizing committee for having given me this topic because it's enhanced my knowledge about something which could have clinical repercussions in the future. So what I'm going to do over the next 20 odd minutes is to speak to you about my understanding of the lung microbiome and how it's relevant both to a researcher and to a clinician. So that's what I'm going to do over the next 20 minutes. So this is a talk that I did about 15 years ago in the UK. And there, if you look at the textbooks, it said that the normal lung is free from bacteria. So if what was true 15 years ago still holds true, then I could actually thank you and finish my talk now. But what I'm going to do is to try and show you that the normal lung is actually not free of bacteria, and the lung microbiome is as important as the gut microbiota, which is probably the source of the lung microbiome in the first place. So this is looking at PubMed hits from 2016. Again, this is a slide which is borrowed from my own collection from a few years ago. This is still 2016. I did a search yesterday night to look till 2021. And I found that between 16 and 21, the number of PubMed searches, the number of articles which crop up on a PubMed search has actually plateaued off in the last 5 odd years. Hi, Shoibal, good to see you. So the number of articles on PubMed between 2009 and 2016 went up exponentially, which shows the amount of interest there is in this microbiome topic. I have put up some questions which I think are relevant to me and to the audience, and I'll try and answer them with data that's available to us today. The questions are in front of you. I'll go through them one by one, and that would be the main part of my talk. And then I'll translate this data into some clinical input as to what happens between health and disease. So the first question, which comes back to my presentation from about 15 years ago, are bacteria detectable in the healthy respiratory tract? And this is a resounding yes. So we know for a fact that there are about 25 odd studies now with more than 700 healthy subjects, in all of whom there's been DNA, bacterial DNA, that's been isolated. I show you one study, other studies are similar. This shows you 4 different specimens. It shows you saline, so sterile saline. It shows you a sterile bronchoscope, which has been flushed with normal saline. It shows you a bronchoalveolar lavage from a normal subject, and it shows you oral rinse. So the oral flora and oral rinse and the liquid that you see there. And the findings are very interesting. So if you look at BAL, the amount of bacterial DNA that you see in the BAL is 100 times that what you see from a sterile bronchoscopic saline rinse. So 100 times greater in BAL as compared to what you see in a bronchoscopic rinse. What about an oral rinse? So you wash your mouth, you put it on a petri dish, or you look at bacterial DNA in the way it's seen, and you find that in an oral rinse, the amount of bacterial DNA is 100 times of what you see in the BAL fluid. So bronchoscopic saline rinse, 100 times greater in a lavage fluid, oral rinse, 100 times greater as compared to what you see in a BAL rinse. So answer to the question, are bacteria detectable in the healthy respiratory tract? Things have changed in the last 15 years, and the answer is a yes. Question 2. Where do these bacteria come from? So we're talking about this. I know Shantanu is going to talk about the gut microbiota. So does it come from the gut? Where do these bacteria come from? And let me try and answer that question with a little bit of evidence for you. So this is a lovely proof of concept study which tried to look at where bacteria is present in the human body. And without going into great details, you can see on that slide that there's bacteria everywhere in the human body. And this is, mind you, healthy subjects that we are looking at. However, again, similar to what I answered in the first question, the amount of bacteria that seems to be present in an oral wash seems to be the greatest. The other important factor that the audience has to remember, that the amount of bacteria in an oral rinse, the nature of the bacteria, and the amount of bacteria in the lung seem to be similar both in quantity and also in nature. However, this does not hold true for the nose. So the isolate from a nasal wash or a nasal brush, nasopharyngeal swab, is different to what it is for oral and what it is for the lung. So hold that thought, because it's going to be important in what we say as we go along. This is again a study which I don't understand well. I'll tell you the essence of the study from what I understand, which is that the oral bacterial flora and the nasal bacterial flora are different from each other. So oral and nasal are different from each other. Compare this with doing a bronchoscopy through the nose versus doing it through the mouth. Lots of pulmonologists in the audience, a lot of us do bronchoscopies. So if you went down with the bronchoscope through the nose versus going down through the mouth, it shows that the flora that you get in the lung is very similar. So what it means is that it's the oropharynx which is the most important storehouse of bacteria in a normal healthy subject. So answer to second question, where do these bacteria come from, is the main source of bacteria is from the oropharynx. The third question that we'll try and answer is, how do these bacteria get into the lung? So we know it's from the oropharynx, but how does it actually migrate into the lung? And these are 3 possible routes. These are not routes that happen, but these are me hypothesizing the 3 routes from which bacteria can actually get into the lung. The first is by doing a bronchoscopy, or by doing any intervention which pushes bacteria down either from the oropharynx or from the nasal cavity down into the lung. So that's the immigration routes number 1. What about immigration routes number 2? So similar to route 1, if you have bacteria which gravitate downwards from the nose or the oropharynx into the lung, so it's migration rather than pushing down by means of an intervention, that could be immigration route number 2. What's immigration route number 3? And immigration route number 3 is if you have microaspiration from the lung, from the gut into the lung, into the breathing tubes, into the trachea, into the main bronchus, that could be route number 3. Now, route number 3 probably is a no-brainer, because we know for a fact with radioactive labeled studies for a very long time that there is microaspirations during the night. So if you're a completely healthy subject, you don't have gastroesophageal reflux disease, your upper airway is completely patent, it works well, there's no bulbar weakening of any nature. In spite of that, through the night, if you did radio tracer studies, and if you looked at the upper airway, and if you had look at the lung, you will find through the night, there's microaspiration of particles which happen in the youngest and fittest of subjects, and obviously in others too. So we know there's microaspiration for sure. We don't need further studies to actually prove that. So this is a wonderful study which got published actually about 2 years ago, which I came across, and I have borrowed these slides from that particular presentation. So what these guys did, very, very interesting, intriguing study, is to have different sites from which the airway is sampled. So the first they had was what they called the bronchoscopic contamination control. So they put the bronchoscope just proximal to the vocal cords. So it stays in the larynx and in the oropharynx, and you have got the bronchoscope there. It shows you whether there's contamination in the upper airway, which results in the bacteria being pushed downwards into the airway, the first theory that I talked about a little while ago. So that's bronchoscopic contamination control. I hope you can see my cursor. That's the pyramid which says number 1. And then they had a protected specimen brushing, and they brushed various areas. And you can see the upper trachea, the proximal trachea as being one side. Number 3 is mid trachea. Number 4 is main carina, and then so on and so forth. So they sampled sites, and they went down to site number 7, which was the right middle lobe orifice. So you understand you're going right from the top down to the bottom up to the right middle lobe orifice. And then they did a couple of lavages from the right middle lobe and from the lingula. So all the way down, they have sampled, and they're looking for bacterial DNA in these samples. So what they found, so keep in mind the 3 routes we spoke about. The first is bronchoscopic contamination. The second is migration of bacteria downwards around the wet mucosa of the airway. And the third is by means of microaspiration. And they found out where there was the greatest amount of bacterial DNA. So take the first route first. If the theory that bronchoscopic contamination happens is correct, the most amount of bacteria would be up there, where the larynx is, where the oropharynx is. And as you go downwards, there'll be less amount of bacteria till you reach the right middle lobe bronchus or the lingula. The second is if the bacteria is creeping downwards. So it's sort of gravitating downwards down the wet mucosa of the larynx. And in that case too, the most amount of bacteria will be at the top, and then it will gradually go downwards. The third, the microaspiration theory, is when you aspirate, most of the bacteria would go and hit the carina. So it would hit the carina, and then it would go downwards. The right middle lobe, the apical segment of the right lower lobe would be the likeliest site where you get the most amount of bacteria. So topmost, bottom less is the first 2 theories. Carina most, and then downwards into the right middle lobe and lingula maximum is the other theory. So let's see what happened. So this shows you the most amount of bacteria. And you can see on the slide that the most amount of bacteria, where there was a mouth-lung similarity, is site 4 and site 5. So site 4 is the carina, site 5 is the proximal bronchus intermedius. That's where the most amount of microorganisms were found in this particular study. So answer to the third question, how do the bacteria get into the lungs? The answer to that question is definitely microaspiration. That's the most likely route from which the bacteria would get into the airway. The next question I would want to ask is, are these microbiota that are available in the lung viable? I told you we were looking at bacterial DNA. Finding bacterial DNA does not tell you whether the bacteria is alive or whether the bacteria is dead. It might well be dead bacteria. People who don't believe in microbiome might actually argue. So how do we know whether this microbiota is dead or alive? So this particular study looked at different media. I'm not an expert on media, so I wouldn't try and speak about them, but you can see these are not conventional culture media that we use on a day-to-day basis, but there's soy agar, there's mannitol salt-rich agar. These are media which would promote the growth of bacteria even when they are present in very minute quantities. The other thing that they did in the study was to change the concentration of oxygen within the media. So they cultured at 21% oxygen, they would culture at 2% oxygen, they would culture in media which was bereft of oxygen, which was without any oxygen at all. And doing this and increasing the culture output, they found that in 61% of normal subject, there was encoding gene for bacteria which was present, which indicates that we're dealing with live bacteria here rather than dead or non-viable bacteria. So answer to the question, are microbiota detected in healthy lung viable, is a resounding yes again. So a yes, that these are viable bacteria. The next question, Obijita, do I have another 5 minutes? Is that sort of, am I okay on time?
Yeah, please carry on. I think you have time.
Okay. So the next question that I would want to answer is, are lung communities spatially heterogeneous? So what does that mean? That's the first. It took me a little while to understand what that means. So this question means, do we have a predilection of bacteria in a certain portion of the lung as compared to others? Or is it more or less homogeneous within one lung? In other words, the fact that this is microaspiration, we keep saying it's the apical segment of the right lower or the right middle lobe which is affected by aspiration. Is that a phenomenon we see in normal healthy subjects? Is aspiration more in one area of the lung? And we have this proof of concept study which looked at lavages from various segments of a person's lung. And they did it in about 25 different subjects, all of whom were healthy subjects. Now at the bottom, you see what the microbiome shows, names of various bacteria, some of which I am familiar with, some of which I'm not. But the important factor is that there was bacteria in all zones of the lung. Then what they did was, they did a protected lavage of certain segments of the lung. And you can see on that slide, it's both upper lobes, the right middle lobe, and the lingula that's been looked at in an individual and then compared between different individuals. And they found that the microbiota in healthy subjects in various segments of the lung was more or less similar, give or take a little bit of variation. However, between subjects, so between myself and Shambhu, for instance, if we did lavages, then the nature of the microbiome in my lung versus Shambhu's lung would be somewhat different. So there was inter-subject variation. However, within a subject, in intra-subject, looking at various portions of the lung, they were more or less similar. Which brings us, so that's, our lung community is spatially heterogeneous in health? The answer is not much. The next question we ask is, are these communities shaped by selective pressure? What we mean is, suppose you get a streptococcus, would there be more growth of streptococcus compared to growth of pseudomonas? So are certain bacterial communities in healthy subjects growing more and overpowering other communities of bacteria that are present? So the answer to this question is that there is no selective pressure. I've taken out the study here for the want of time. However, take my word for it that there isn't a selective pressure in normal healthy subjects, even though when you subject these people to treatment with antibiotics, there is selective pressure and there are overgrowth of some bacteria and there is diminution in growth or there is death of certain bacteria within the lung. So this is, we're talking about disease subjects, not in healthy subjects. The last question, I think the most relevant from a clinician's perspective is, are the lung microbiota immunologically inert in health? So in healthy subjects, I have bacteria, I have live bacteria, we've talked about that, but does this mean that the immune response of my body would be any different to Shambho's if I have an immune response to the bacteria that are present normally in my lung. So this was a study which came out about 5 years ago, neat little study. I'll tell you what little I understand of this study. They looked at the microbiota and they looked at immunological response by looking at cell type and then looking at mediators. And again, to cut a long story short, they found that in individuals where the oral and the lung microbiome was similar, there was increased amount of lymphocytes in the bowel cells. The larger number of lymphocytes where the oral bacterial flora and the lung bacterial flora were similar to each other. More importantly, in response to the lymphocytes, it was mainly the CD4 and the IL-17 which were increased within the bowel liquid. So the response that you get from the lymphocytes is also focused for a particular individual depending on the nature of the microbiota. And then you have the distance from the upper airway and a variation in the response with lymphocytes and the IL-17, etc., depending on how far away you are. So there is immunological response which is peculiar to an individual. So answer, are lung microbiota immunologically inert in health? The answer is no, it's not immunologically inert. It's actually active, and you do mount a response even to microbiota in healthy subjects. So this brings me to my last 3 or 4 minutes, and I want you to look at this interplay between what happens with microbial immigration, microbial elimination, and how these are connected by environmental growth conditions. So let me try and give you an example. Take the city of Kolkata. There are people who come into the city on a daily basis. There are people who leave the city on a daily basis. There are people who get born in this city. There are people who die in this city. The population, the nature of the population of the city, what it was 10 years ago and what it is today is markedly different. Maybe not markedly different, but significantly different. The people who come into the city and people who go out of the city, a lot of factors determine it. Job opportunities, how livable the city is, how polluted the city is, how much people love their hometown, and so on and so forth. All of these factors will determine the nature of population that a metro city like Kolkata or Delhi or Mumbai would actually harbor. Translate that into what you find in the immune system. So the microbial immigration depends on microaspiration, inhalation of bacteria, and direct mucosal dispersion, like we said. The elimination would depend on your protective mechanism, the individual's protective mechanism, which is cough, mucociliary clearance, and the innate and adaptive host responses. And these two factors are balanced by the nutrient availability, the oxygen tension, the temperature, the pH, and so on and so forth within a particular airway of an individual. So this is the balance that we are talking about. You can see the balance between, so I want you to look at the bottom of the slide. You can see immigration, elimination on one hand, environmental growth conditions on the other. And you can see as the environmental growth condition changes, the temperature and pH changes, the oxygen tension changes, there'll be more of lung disease as compared to when the balance is maintained. So when the balance is maintained, there's not much of interference or change in the environmental growth condition during health. As the situation changes, think of this as triggers for asthma, change of climate, change of temperature, causing a change of microbiome, and hence an exacerbation of asthma or COPD in the population of patients we have. So that's the link of the environment and the microbiome that we see. Think of this in the perspective of other diseases. This shows you the microbiome in healthy subjects and the microbiome in diseased subjects. And you can see that in patients with IPF, which is at the bottom there, there's a small difference between the healthy microbiome and the IPF microbiome, but the microbiome seems to trigger disease to an extent, to a large extent. There's something called the MUC5B mutation, which triggers IPF, idiopathic pulmonary fibrosis, and this is relevant from a microbiome perspective. The same in COPD, the same in the transplanted lung. So microbiome matters, and I would argue and show you in the next couple of minutes that it's the microbiome which will probably dictate how we treat these individuals in the future. So what are the lung microbiome predictive of? I've run out of time, so I won't show you data here, but I'll just show you facts. So the lung microbiome is predictive of disease progression and mortality. Two studies that I've quoted, the more recent studies, which I haven't managed to put in because I did all of this last night, but there is, take my word for it, that disease progression and mortality depend on lung microbiome. And hence, so does exacerbation frequency. The disease progression mortality model is from IPF. The exacerbation frequency model is from bronchiectasis. Hence, it's no wonder that a response to macrolides and corticosteroids would also be dependent on the microbiome of the lung. So you can predict response depending on what the lung microbiome at the time shows. The microbiome can be altered by antibiotics, and this is shown up on one antibiotic, that's ceftriaxone on there. You can see a gram-negative. I won't even try to pronounce these bacteria, but that's a gram-negative bug. And you can see with ceftriaxone, the amount of microbiota, the amount of proteobacteria there comes down significantly. But a different gram-positive bacteria, the numbers grow up. So the gap that's been created by the gram-negative being eliminated is filled up by a gram-positive, which is present in normal healthy subjects. So this is ceftriaxone as an experiment in normal healthy subject, and the gut microbiota, that the lung microbiota changing there is relevant. So altered by therapies like antibiotics, it's altered, we know, also by proton pump inhibitors. Interestingly, and that's the last part of my talk, it's changed by oxygen therapy. So this is looking at a phase 1 trial with healthy mice. It looks at lung communities with people who are on 75% oxygen and people who are on 21% oxygen. And you can see that there's change in the concentration of bacteria in the lung depending on the concentration of oxygen there is. So whether it's the erysipelotracheides bacteria or whether it's streptococcus, depending on the concentration of oxygen, the amount of bacterial flora goes up or comes down depending on how much oxygen you use. So that's my last slide. I think we need to think about the microbiome. I need to think about the microbiome more, because going forward in the next 10 years, I think a lot of treatment, both in healthy subjects and in diseased individuals, would be dictated by the microbiota in the lung and also probably the oral and gut microbiota. And response, prognostication, and even mortality would probably be predicted by the microbiome in these individuals. I'm sorry if I've run over time, and thank you very much for inviting me to this meeting.
Thank you, Dr. Raja, for this illuminating talk. What we have clearly learned from your presentation today is that the lungs are host to a microbiome, microbiota. There is a state of normal microbiota. The source is probably the oropharynx, microaspiration playing a large role. And that state of normal state has a diversity of microorganisms, which we call a state of eubiosis. And disruption of this eubiosis, whether as a result of disease, drugs, environmental conditions, might be a factor behind, who knows, the etiology, prognosis of diversity of lung conditions, starting with allergic airway disease, idiopathic pulmonary fibrosis, and I've also read somewhere that perhaps lung cancers might be influenced. So these are exciting days ahead, and as you said, that in the coming years, we may be speaking more about lung biota and the crosstalk between lung microbiota and the microbiota in other parts of the human system. So thank you, and over to Shambhu.
Thank you, sir. Thank you, Professor Abhijit Hajra, and thank you, Professor Dr. Rajadhar, sir, for giving us time. So as we are running short of time, we are moving to our next topic, and to chair the next session, it is our real honor to call Professor P.P. Mukherjee, sir. Professor P.P. Mukherjee, who is a professor and head of Department of Medicine in CNMC, Calcutta National Medical College. So welcome you, sir. And also we have Professor Shivendu Ghosh, who is professor and head Department of General Medicine in Medical College, that is Bojboj Medical College, and he is also the Vice President of Association of Physicians India. Welcome you, sir, also. So actually there is some problem happens with Dr. Narayan Prasad Modi. So instead of him, we are fortunate to get Dr. Shoibal Moitro as speaker for this session on treatment updates in mast cell activation syndrome. Now over to Professor P.P. Mukherjee sir and Professor Shivendu Ghosh sir.
Dr. P.P. Mukherjee, are you there? Dr. Shivendu Ghosh here. Do you know Dr. Mukherjee has joined or not? Oh, no. Professor Mukherjee, just unmute yourself, sir. Unmute yourself. So, organizer, do you have any biodata of Dr. Soibal Mitro so that Dr. Mukherjee can read it out or say something?
I think, sir, that is in the screen. We can see the designation of Professor Shoibal Moitro. Professor Shoibal Moitro is a professor of Department of Allergology in Apollo Gleneagles Hospital.
Yeah. Okay, Professor Mukherjee, can you unmute? You are still muted. Please unmute. Again unmuted.
Mukherjee, sir, you have to unmute yourself, sir.
Unmute. It is muted. Okay, sir.
Can you hear me? Shivendu, can you hear me?
Conversation.
You are very much audible. Dr. Mukherjee, you are very much audible. Please be louder a bit.
One partho to another partho. Okay.
Yeah. Sure.
Professor Mukherjee.
Yes.
Start.
Yeah. May I request, without wasting time, Dr. Shoibal Moitro to start his deliberation. And at the end, I will tell. So,
Thank you, the respected chairpersons, and good afternoon all. And I once again welcome you all to be a participant in this 10th National Conference on Allergy 2021. So unfortunately, because of some unfortunate incident in Dr. Modi's family, so we won't be having him in today's session. And so I will be taking the lecture on the mast cell activation syndrome. So this is the picture which has been taken from Mariana Castell's workbook. Mariana Castell, she is one of the leading figure who has the maximum number of work on the mast cells, and she is credited to have identified the mechanism of the various pathways of the mast cell activation and also the mast cell functioning. These mast cells, so these are very interesting cells. These cells are actually found in the interface of the body and the environment. So wherever there is an interface, we find a mast cell. So mast cells form an important immune effector cells, and they are also a part of the innate immune system. But during the healthy time, the mast cells have numerous functions to play, but there are certain instances in the disease states where there is unprecedented and unchecked activation of the mast cells, which causes some of the disorders, which we'll be just having an overview, because these are the conditions which, if we do not have in our mind, we won't be able to catch them, treat them early to prevent subsequent further complications related to this disease. So now, what are diseases of the mast cells? It could be just like a mast cell deficiency, which is not found yet, but it could be excessive mast cell number of functions in the localized environment or in the systemic environment. These are the classification of the mast cell disorders. I won't go into detail of this because this is available in the textbooks. But one thing I want to focus, now there is a mast cell activation syndrome. Now the mast cell activation syndrome is actually what we'll know that what is this, where the mast cells are unchecked, they're activated. They go on degranulating and they go on releasing all the chemicals, both the de novo and the preformed chemicals into the local environment and also into the system, which brings about a constellation of the signs and symptoms pertaining to the various organ systems. And this makes a condition where until and unless we have this muscle activation in mind, we won't be able to catch them. And this could be a primary muscle activation syndrome, which we find in a monoclonal muscle activation, because there is a clonal activation of the mast cells, which is quite akin to any cancerous condition. It could be secondary muscle activation. This is the most common condition that we find in relation to an allergy practice. That is where there is an atopy, there's a drug allergies, or patient has come to the emergency department with an anaphylaxis to a drug or to any Hymenoptera sting anaphylaxis, then definitely we have to always evaluate this patient for an underlying mast cell activation syndrome, or the idiopathic mast cell activation syndrome, where there is no reason for the mast cell activation is found, but the mast cell is degranulating and activating. So this is the diagnosis of exclusion. So in this, definitely, there we have this mastocytosis, which could be associated with the mast cell activation, or the mast cells could be just inert, only the number is increased. So there could be a systemic condition, there could be cutaneous, which is more common in children, and there could be some other rare conditions like mastocytoma and the mast cell sarcomas. So if we talk about the localized mastocytosis, which is more commonly seen in children, and if we keep this in mind, definitely from the dermatology OPD and dermatology practices, cutaneous mastocytosis cases can be diagnosed. It could be an urticaria pigmentosa, it could be diffuse cutaneous mastocytosis. And systemic mastocytosis is more common in adults, where the most common disease is the indolent systemic mastocytosis, which is more or less not a very grave or the serious disease as the other forms of the systemic mastocytosis, like the systemic mastocytosis with associated clonal hematologic non-mast cell lineage disease, or aggressive systemic mastocytosis, which has quite a high mortalities. And there could be also mast cell leukemias, mast cell sarcomas, monoclonal mast cell activation syndrome, or non-clonal mast cell activation syndrome. We don't have any data from our country. We don't know what is the prevalence of the mastocytosis or mast cell activation diseases in our country, because we failed to pick up these cases and report these cases. But what data we have from the US is estimated 20,000 to 30,000 people are actually afflicted with this disease, and male-female ratio is 1:3, but is found in all ethnic backgrounds and may occur at any age, and this is not a familial disease, which is an unusual thing. Now, just a short about the pathogenesis. Of this, the most important is the KIT-dependent pathogenesis. What is KIT? KIT is actually what we call it is a protein, and this is a mast stem cell growth factor receptor, just like a tyrosine kinase receptor. So it has both an extracellular domain and the intracellular domain, and it is formed from also called a proto-oncogene c-KIT. This is a very important receptor. Its activation is actually leads on to this mast cell activation. And this activation has occurred because of some mutations in the chromosome 4 in the position 12. And this most common mutation is what we call a D816V mutation, which is actually, if it is found in the peripheral lymphocytes, so which are then checked for these genetic studies, and which is clinically available also. And this is one of the tests which detects the mast cell activation syndrome and also the mastocytosis. Or there can be, whether it is inheritable to the next generation, there is no evidence. At the same time, there can be some other mutations which are of not that importance, and we do not have any clinical tool to detect the other mutations. They are on the research tools, but we have a clinical test to detect the D816V mutations of the KIT gene. This is the most important mutation we find in the mastocytosis. There can be some other mechanisms like the inhibition of the apoptosis. When the apoptosis is inhibited, the mast cell becomes almost immortal, and they goes on living and degranulating and causing the symptoms. One of the most common on what we call these changes which we find is the FIP1L1 PTGFR fusion. This is the most common genetic changes or mutational changes we find in case of apoptosis inhibition. Other fusions, other protein mutations are the less common. The clinical features are actually the protein manifestation. We need to actually have a strong suspicion of the mastocytosis in the proper clinical settings. It could have a systemic symptoms, dermatologic symptoms, GI symptoms, musculoskeletal symptoms, hepatosplenic symptoms, and neuropsychiatric symptoms. Few days back, there was a patient in my OPD who had come with a manifestation of the multiple organs having in the multiple actually systemic manifestations, both the cutaneous and also she had the manifestation, the GI manifestations of diarrhea, and also the neuropsychiatric, like she was depressed, she was having headaches, and she had visited a number of the doctors before she came to our OPD. And anyway, so she was taking the treatment from the various doctors, but since the diagnosis was not clinched, so she had to suffer a lot. But what happened is that this is, since fortunately we had this D1816V mutational study to be carried on. So then, and somehow we picked up the D1816V mutation in her case, and she was diagnosed to be suffering from the indolent systemic mastocytosis. This is the story not over here, but it's a story common all over the world. Since this patient has a protein manifestation, so it takes around minimum, there is a duration of around 1 to 2 years, even 3 years before the diagnosis of a mast cell activation or a systemic mastocytosis is made. Systemic symptoms could be flushing and episodic hypotension. Hypotension is usually provoked by, these are the provoking antihistaminergic foods like alcohol, aspirin, stinging insect allergies, very common, and various infections. Exposure to the iodinated contrast medias, as both in the iodinated contrast medias and other contrast medias can cause an anaphylaxis in a patient who is underlying this disease. But there's no increased risk in bacterial, fungal, or viral infections, because the mast cells do not have a very high role to play in actually preventing these infections or actually stopping these infections. So dermatologic manifestations, as I've said, urticaria pigmentosa or maculopapular rash or maculopapular cutaneous mastocytosis is a very common manifestation, especially in the children, and it can be also found in more than 90% of the indolent systemic mastocytosis patients. So these are kind of the rash. This is the picture which has been taken from the Middleton's allergy textbook, and this is a kind of rash which we find. And these are the rash, maculopapular rash all over the bodies. And this is the urticaria pigmentosa. An important sign is the diarrhea sign. Diarrhea sign is when you rub this rash, there is erythema and induration at the side of the rash. So this is because of the release of the histamine from the mast cells, which has got accumulated over there, just like we do in the skin prick test. So this is what we call a diarrhea sign. This is a diffuse cutaneous mastocytosis, a diffuse involvement of the dermal layers of the skin throughout the body. And this is also picture taken from the Middleton's allergy textbook. They can at the same time have these bullous lesions. And at sometimes these bullous lesions do look like this. The blisters, they may erupt spontaneously or associated with the infection or immunization. They have these blisters which then erupt, they discharge, and these are the kind of findings we can find in these patients. GI symptoms, what we find over here is quite common. And they have like abdominal pain, which could just pass away like a dyspeptic pain, and they can have a gastric acid hypersecretion, and they can have a high plasma concentration of histamine, which is correlated with the basal acid output. But GI bleeding is quite uncommon. So if we have a GI bleed along with these symptoms, definitely we should not think of the mastocytosis in these cases. They can have a diarrhea with a hypermotility or transit day disorders, and malabsorption is found in quite a number of patients because they reduce the food intake because of their diarrhea, abdominal pain, and all the GI symptoms. And there can be primarily as a mild steatorrhea with impaired absorption, the D-xylose or vitamin B12. Main thing is that any patient coming with this type of cutaneous rash with the GI symptoms of diarrhea, abdominal pain, we should always think of the mastocytosis. Musculoskeletal symptoms is of uncertain etiology, but patients do give the history of the osteoporosis quite frequently. And they can have an hepatosplenic evidence of liver disease like the hepatomegaly. Neuropsychiatric symptoms important, like the decreased attention span, irritability, they are quite depressed, and they may have headaches and all. Bone marrow pathology is seen in these patients, so bone marrow test may be done in few patients if we are definitely suspecting the mast cell activation syndrome. This is the proposed algorithm. The typical signs and symptoms, think of mastocytosis. It could be a monoclonal mast cell activations, that there is this SDH16V mutation, which when you call it primary mast cell activation. If there is a type 1 allergy, like type 1 hypersensitivity reaction, say to bee sting or to drugs, it could be secondary mast cell activation. And then we see the major and the minor criteria. If they fulfill, we go about in diagnosing this. Typical signs and symptoms we have just said. These are the flushing, pruritus, articulated angioedema. And along with that, there has to be an increased total serum tryptase level. At least 20% level should be above the baseline. And one test should be done within 48 hours of the onset of the symptoms, and later on about 4 to 5 days later. So there are some major and the minor WHO criteria. And if the person fulfills else a 3, at least 1 major or 1 minor or 1 minor or at least or 3 minor systemic criteria for this disorder, then we classify the person to be having systemic mastocytosis. For the cutaneous mastocytosis or mastocytosis in skin, they should have a 1 major and 1 minor are met, and their criteria to the systemic mastocytosis are not met. And this is how we go about in diagnosing. One important thing is the REMA score. REMA scoring is done actually for the patient. This is actually clinical scoring, because when a patient whom is suspect, like a bee sting allergy, comes to the emergency, we just score this patient, and if the score, this is very entirely clinical scoring. We don't have to do any tests on these patients except the tryptase level. And if it is within this, if it is like more than or equal to 2, then there's a high probability of clonal mast cell activation disease. And this REMA score has been validated in the Caucasian. We don't have the validation of the REMA score in the Indian population, but in the Caucasian it has been validated and it has been shown to be a screening tool when we suspect the mast cell activation. The treatment options, first of all, is a symptomatic treatment. Then we have the GI symptom treatment, osteoporosis, and the hematologic abnormality treatment. Always these patients needs to be given epinephrine auto-injector, unfortunately, which is not available in our country, because they may land up into an anaphylaxis to any things. And intensive therapy for anaphylaxis might be needed, but epinephrine auto-injector is a must for these patients. And they have usually given the H1, H2 receptor antagonist, which reduces flushing, and along with the leukotriene receptor antagonist. Disodium chromoglycate, or a mast cell stabilizer, it has a role in these diseases because they inhibit the degranulation, relieve the GI complaints, but they're not reduce urinary or plasma urinary histamine levels. And this PUVA treatment is given for the skin diseases, which can reduce the pruritus. We have the topical steroids, the plastic wrap occlusion therapy used for the treatment of the diffuse cutaneous mastocytosis. GI symptoms, definitely the PPIs and the H2 receptor antagonist, and diarrhea is treated with the anticholinergic. We see that mainly is symptomatic treatment. For the osteoporosis, really bisphosphonates or the radiotherapy. Now we have coming onto palliative therapy with the interferon alpha 2B. And for the hematologic abnormalities, definitely this is the interferon alpha 2B and 2-chloro-2-deoxyadenosine, which is coming up. There have been some studies which have shown that it has good role and to play in the hematologic changes which occurs in mainly in the clonal mast cell activation syndromes. And the bone marrow transplantation is an option. Imatinib definitely is for the aggressive forms of the mastocytosis in patients who do not have the D816V mutations, because D816V mutations usually get worse with the imatinib mesylate. And patients with increased mast cells and peripheral eosinophilia with a FIP1L1 PDGFR fusion, they may respond to the various tyrosine kinase inhibitors like the midostaurin, and these are the drugs which is being on the clinical studies. Splenectomy, radiotherapy, and a bone marrow transplant is an option. The prognosis with cutaneous mastocytosis is quite good, which is followed by the indolent systemic mastocytosis. more than 50% of the children with isolated urticaria pigmentosa, they usually resolve by the adulthood. We only need a symptomatic treatment. Urticaria pigmentosa in adulthood may evolve into a systemic disease. Occasionally, the immunosystemic mastocytosis converts into more aggressive forms of the mastocytosis. Mean survival of the leukemia associated with the mastocytosis is less than 1 year, which is quite an aggressive form of the disease. The take-home message is that mast cell disorders vary greatly in clinical presentations. We need to have a strong suspicion of this disorder. Primary pathomechanism is the activation mutation of the KIT, which makes the unchecked activation of the mast cells. Signs and symptoms are caused by the mast cell mediator release, increased mast cell burden, and also hematologic disorder. Symptomatic treatments are the mainstay, along with the specific treatment for the hematologic disorders. 28th October is the International Mastocytosis and Mast Cell Disease Awareness Day. In our country, we usually try to have observe these days an increased awareness of the mast cell diseases, because the increased awareness is the crux to identify this disease early and treat the patients accordingly to reduce their suffering. Thank you.
Hello.
Yes.
Can you hear me?
Yes, yes.
Dr. Shibendu here. Dr. P.P. Mukherjee, with the permission.
Hello.
Hello. Dr. Moitro, can you hear me?
I can hear you. I can hear you. Yes.
Yeah. Actually, maybe out of your lecture, the subject, we have seen some patients having, particularly when the patient is getting some equine type of antibodies, like your immunoglobulin, particularly patients is having snake bite. But very much we are confused whether it's a case of anaphylaxis or a anaphylactoid reaction because of excess production of histamine and other chemicals. So can you just clinically, at least in the bedside, is it possible to differentiate? Because treatment, at least for the adrenaline, is the best treatment for anaphylaxis management, whereas you can treat with other antihistaminics and others for the anaphylactoid reaction. So can we clinically at the bedside, can we differentiate? The first question. And second is, if the patient has got hyperacidity with mastocytosis, is it the PPI or the H2 blocker will be preferred for the treatment of acidity? I mean, for the treatment of hyperacidity or GI dyspepsia due to systemic mastocytosis. That two common question, maybe silly, but I'm asking this. Okay, thank you.
Not silly. I think these are very pertinent questions. Number one is that now we have the very good anaphylaxis guidelines. Anaphylactoid term is mostly going into taking a backseat these days. What we know is that anaphylaxis, that this is an acute reaction which is being occurred to any external agents. It could be drugs, it could be a sting, it could be anything, and which has involved now we have gradations for the severity of the anaphylaxis. So if a patient has maybe consumed some food and or maybe the patient has been stung by some insect or maybe some medicine, and patients within an hour, patient develops an acute symptoms pertaining like type 1 hypersensitivity symptoms pertaining to at least 2 organ systems, then we call it an anaphylaxis. It could be a skin symptoms like an urticaria, flushing, and skin rash. It could be definitely GI symptom, which includes the diarrhea, vomiting. Along with that, it could be a cardiovascular symptoms. So like a patient having a low BP, patient having a shock, patient collapsing, or even it could be respiratory symptoms like a shortness of breath. So whenever the patient comes to the emergency with this kind of symptoms, always we stamp the diagnosis of the anaphylaxis, and first and foremost, we give the patient epinephrine. So we think anaphylaxis, we give epinephrine. So this is what now the present consensus is. Anaphylactoid term, which we were using pretty commonly before, and where the symptoms or the reactions, they were manifestations were just like an anaphylaxis, but they were not type 1 hypersensitivity reactions. Now, from the clinical point of view, this terminology has taken a backseat, because what has been seen worldwide and in also by the WAO and also the American Academy of Allergy, Asthma and the Immunology and the IACI guidelines, they all say that these patients clinically has to be diagnosed on the basis of this is criteria to be anaphylaxis and given the epinephrine as a first medicine as drug of choice. Second thing is that when a patient of a mastocytosis has an increased secretion of the gastric acids, definitely we know that the increased secretion of the gastric acids, it is both the action of, or number one is the histamines, which is acting, and also by the other mediators released is from the mast cell degranulation. So it is the simultaneous use of the H2 blockers along with the PPI to manage these patients who have an underlying indolent systemic mastocytosis for per se and causing a gastric hypersecretion of the acid. So that is what is the current status of the treatment guidelines in these patients.
Professor P.P. Mukherjee, you can now think this is open for the forum, and you please continue the proceedings. If there are any questions and answers, please tackle that. Professor P.P. Mukherjee.
Not audible properly.
Good.
পার্থদা একটু সাউন্ডটাকে বড় করো, ঠিক করো, সাউন্ডে প্রবলেম হচ্ছে। You are unmuted but sound is not coming. তাই তো পার্থ কর্মকার?
একটু অসুবিধা হচ্ছে, তোমার কথাটা স্পষ্ট বোঝা যাচ্ছে, পার্থদার কথাটা একটু লেস ডিস্টিংক্ট।
Yes.
শোনা যাচ্ছে।
শোনা যাচ্ছে পার্থদার কথা?
পার্থদা একটু জোরে বলতে হবে,
আওয়াজ উঠছে না পার্থদা।
I think there's
সমস্যা।
Yes, sir. I think there is some issue regarding the sound from Professor P.P. Mukherjee, sir. So I think we are running short of time. So we are really.
Can I conclude the session then?
Yes, sir. Yes, sir.
So I think, Soibal, we are fortunate rather than unfortunate to get a lecture, very excellent exposition of the mastocytosis, which is very much, I think it's a neglected one to a great extent, and probably it is detected after a long-term treatment with some anti-allergic for years together, and then it comes to our purview. So with these few words, and with the permission of Professor P.P. Mukherjee, who is my co-chairman and very senior person, I am concluding this session. And with this, may I hand over the mic to the organizers. Thank you very much. Thank you.
Thank you, sir. Thank you very much. Thank you, Professor P.P. Mukherjee, sir. Thank you, Professor Shivendu Ghosh, sir. And thank you, Dr. Shoibal Moitra, sir. So now we are moving to our next session. And for that, we are really fortunate to have two well-known chairpersons, Professor Soumitra Ghosh. He is the professor and head of Department of Medicine at SSKM Hospital and IPGMER. And we all know him. He does not require any introduction. And also today we have Professor Shomir Malhotra, who is the professor of Department of Clinical Pharmacology at PGI Chandigarh. Professor Malhotra sir, are you there? So with that and the top, may I introduce Professor P.S. Kormakar sir also. He is the professor at the Department of Medicine at CMSDH Hospital, Kolkata. So with that, I am requesting our respected chairpersons to take care this event. Professor Soumitra Ghosh sir and Professor Shobir Malhotra sir.
Thank you, Dr. Shambhu Somajdar, for this nice introduction of the chairpersons before this session. And this session is very important because in the last one year, almost after this vaccination of COVID, this was the most asked question by everybody, that whether I can take the vaccine because I have some allergies to these and these, etc., etc. So vaccination in atopic subjects, the immunological perspective would be held no other than by Professor Partha Karmakar. He's an luminary in our city in India, also is well-known personality in India. He's the, governing body elect member of this Association of Physicians of India. He's a well-known professor in West Bengal medical education. And he is a very important person to deal with this vaccine and vaccination in atopic subjects, immunological perspectives. So without wasting much of time, I will request Professor Kormakar to please start this deliberation on this important topic, sir.
Am I audible, Dr. Soumitra Ghosh? Hello, am I audible?
Yes, sir. Yes, sir. You are audible.
Okay, okay. Thank you. Good afternoon, everybody. And at the very outset, I am really thankful to Chairperson Sir, Professor Soumitra Ghosh, for all those kind words. Before coming to my topic, this topic, I will be definitely thankful to all the organizers for giving this very timely, appropriate topic for discussion with this learned gathering. So that is vaccine and vaccination in atopic subjects, immunological perspective. Now, vaccine and vaccinations, the whole world, globally, it is being discussed every day, whether the second vaccines or booster dose or something like that. So my discussion in atopic subjects also revolve around the vaccines related to COVID-19, basically. So I shall try to cover this topic by briefly touching upon this points, that is atopy and allergy. What do we mean by these two terms? IgE and atopic diseases, real case discussion, and vaccine allergy related atrocities, guideline for COVID vaccine in atopics and take home message. Before going to my topic proper, I am really especially thankful to Dr. Shambhu Somajdar, because he has helped me a lot in preparing my presentation. So I have borrowed many slides from him also. So I'm really thankful. Thank you. Okay. Now, what is atopy and allergy? So atopy is nothing but we have understood from the discussions from the previous lectures. It's just tendency to produce an exaggerated, dysregulated IgE immune response to otherwise harmless environmental substances, which are usually potent and called allergen. And these harmless substances are usually nothing but house dust, mice, animal debris, farts from dogs or cats, pet dogs and cats, and insect sting like bees and wasps. And these are always type 1 hypersensitive reactions from the basis of that forms the basis of allergic reactions. And allergic diseases are manifestations of inappropriate IgE immune response. Whatever clinical manifestations we are getting out of this dysregulated IgE immune responses, that is, these are the allergic diseases. And these are really increasing to a great extent in the last few decades. This is due to why it is increasing allergic disease. And it is best explained by hygiene hypothesis. We all know, because of the too much protections of a child, we are gradually increasing these allergic diseases in recent era. So, and these allergic diseases can ranges from very minor symptoms like rhinorrhea, sneezing to anaphylaxis. So we are really dealing with atopic various manifestations, and when the patient complains of atopic asthma along with allergic rhinitis and atopic dermatosis, these three symptoms are together called atopic TARD. Apart from these three symptoms, there are several other manifestations we may come across, that is dermatological urticaria, atopic eczema, allergic contact dermatitis, and angioedema. In respiration, either in the form of atopic rhinitis, that is allergic rhinitis, along with sneezing and asthma. And ophthalmological manifestations of due to atopy is allergic conjunctivitis. And in gastrointestinal, we were talking about, that was being talked about by the Rajadhar, Dr. Rajadhar, that is food allergy is also an important manifestations of atopic in atopic subjects. And other, definitely anaphylaxis is the most grave, most manifestations of allergic diseases, along with some drug allergy, food allergy, as well as allergy to snake venom. So pathophysiology, so far pathophysiology is concerned, very briefly I can touch upon that. So for pathophysiology, whenever this harmless environmental allergen is coming in contact with our body, our B cells are coming forward to protect, fight against them, and they form some IgE immunoglobulin. And that IgE immunoglobulin, usually there are several receptors for IgE over the mast cells, and they occupy the receptors of the mast cells. And these mast cells, when are coated by the IgE as a result of exposure to allergen, these are called sensitive mast cells. And whenever we are being re-exposed to those allergens, there is vigorous deregulated, the extra activations of the mast cells, and give rise to mast cell granulations, and there is secretions of vasoactive peptides, tryptase, and histamine. So this way, the mast cells are yearly giving rise to development of all atopic manifestations. These are this is in short the pathophysiology. What is pseudoallergy? Just a few minutes before, in the previous, Dr. Shoibal Mitra was talking about that is anaphylactoid sort of reactions. This is in the back seat, because this sometimes this anaphylactoid type of reactions can occur as a result of some opioid drugs, liposomes, NSAID, and tricyclic antidepressants. But these are all IgE independent mechanisms. So we have to face IgE dependent sort of atopic diseases to call it allergic diseases. So I will just go through a patient, female doctor, who is by profession microbiologist, and this story has been received from Dr. Shambho Sundar, and because they came to the clinical pharmacology of their institute, that is STM, that is School of Tropical Medicines. She does have the background of multiple drug allergies. In the year 2012, she was diagnosed to have temporal lobe epilepsy and was initiated with carbamazepine. After just 2 days of being exposed to carbamazepine, he started showing severe itching and some drug and macular lesions. Carbamazepine was stopped, and she was put on lamotrigine for this temporal lobe epilepsy. And after taking lamotrigine for a few days, she developed foul-smelling discharges from the different follicular areas of skin, scalp, and axilla. Count going up to the tune of 40,000. Out of that, eosinophils constituted 34%, and this was withdrawn. Patient became all right. Other pharmacologically, they are anticonvulsants. Though they are anticonvulsants, they gave rise to some drug-related reactions. And hypotension, being exposed to some chemicals in microbiology laboratory in the year August 2017, and she was brought to here. Immediately, all precautions and treatment was taken, including adrenaline, and she survived. And in that, after all these eventful manifestations of drug allergy, in the year December 2022, he had respiratory tract infections, took cefodoxime as one of the antibiotic, and after 5 days, she again developed rashes and fever. So what conclusion we can come to this after this fact of a female doctor being microbiologist, that she is having drug allergy to similar to unrelated pharmacological molecules, even some chemicals of microbiology lab. So in these cases, we are really in dilemma. Whether these sort of patients are to be put on any vaccines, including COVID-19 vaccines. So here we have to balance between patient safety and risk. Sometimes we really give answer to our patients if they ask that I am having allergy to this and that, and should we go for? We either reluctantly say yes or no. But that answer should be very thoughtful answer. Here you are really, that lady is really facing allergy to so many unrelated drugs. So if you want to give him COVID-19 vaccine, you may invite once again another complications like anaphylaxis, and so that's a great problem for any person, whether put him on being on the safe side. If you don't say no to COVID-19 vaccine, what you will do, you will definitely take risk of infection with COVID-19 and its related morbidity and mortality. That is to be kept in mind. So whenever patient is coming to you with some allergy, balance between patient safety and risk is a very important, and your answer should be a very thoughtful answer, whether it is yes or no. So I will discuss whether this lady could be given COVID-19 vaccines or not. So before coming to the vaccine proper, we have to know what are its constituents. Then only we can come to a very concrete platform whether patient is to be vaccinated or not. So we are dealing with two vaccines in India. One is Covaxin, another is Covishield. So I will little bit discuss about the Covaxins. We all know it is just recapitulation. Covaxin is an inactivated whole virion vaccines, and it contains, apart from its molecule, that is a whole inactivated whole virion viruses, whole virion. It contains aluminum hydroxide gel, TLR, that is toll-like receptor 7 and 8 agonist, that is imidazoquinone. And what it does, it actually tries to reduce through actions through interferon 1 to reduce the allergic actions in relation to the vaccine, and 2-phenoxymethanol and phosphate buffer saline up to 0.5 milliliter. So these are the constituents of Covaxin. And what is the constitutions of our commonly used Covishield, that is Chadox 1S vaccine, and that is yes.
Sometimes this connection is actually fluctuating.
Fluctuating.
Okay, you
really?
continue.
Okay. Sometimes it's really fluctuating. Also happening. So I'm checking it out. Thank you. So includes the excipients that is we do see in Covishield, that is Chadox S vaccine, that is polysorbate. I have written it bold because it deserves a little bit of discussion. Polysorbate 80, the amino acid L-histidine, ethanol, salts, sugars, and buffers. So why I have written polysorbate 80? Because polysorbate 80 is a very good surfactant. It is biologically and pharmacologically active, and it is a common emulsifier and stabilizer in the food industry, as well as in the manufacture of some vaccines, as in Covishield, as well as some medicines. So what are the common medicines that contain the polysorbate 80 excipient in medicines and vaccines? That is medicines out of the all medicines: amiodarone, vitamin K, etoposide, docetaxels, as well as erythropoietin stimulating agents. All these pharmacological molecules do contain the polysorbate as emulsifier as well as stabilizer. And among the vaccines out of the COVID, apart from the Covishield, the common vaccines like influenza, hepatitis B, and human papilloma virus also contain polysorbate 80. So why I'm talking about this? Because if a patient does have reactions to hepatitis B, so they are very much likely to have developed because of this polysorbate, because in Covishield vaccines too. So we have to have this knowledge that what are the medicines or what are the vaccines, they do have polysorbate as emulsifier or stabilizer. So again, another important common molecule that is being used in medical in our vaccines as well as various medicines, that is PEG, polyethylene glycol. And polyethylene glycol and and polysorbate 80, they share an allergenic epitope. And for this reason, they may have cross-reactivity between PEG and polysorbate 80. So whenever one is showing, reactions to PEG, they may show reactions to PS80 also. So PEG allergy and clinical history and very common medicines like medroxyprogesterone, depomedroxyprogesterone, or dipomethylprednisolone, they do contain PEG as emulsifier. So to depomedicine methylprednisolone, if one is having allergy, they shouldn't take COVID-19, that is Covishield vaccines, for that reason, because they contain PS80, that's polysorbate 80. So history of immediate anaphylaxis to multiple and different drug classes with the trigger identified, always consider the PEG could be the culprit molecule. So whenever not related molecules, patient is really showing to unrelated molecules the atopic activities, we have to think about, or vaccines, we have to think about the presence of PEG in all these unrelated molecules. So in that case, COVID-19 Covishield is could be the one of the culprit vaccine to produce atopic reactions. So what are the guidelines available to prevent COVID-19 vaccines allergy-related atrocities? So we all together have for last few months from the very beginning globally licensed vaccines are, we all know, Moderna and Pfizer vaccine, that's the mRNA. Covishield vaccine, that is the adenovirus, chimpanzee adenovirus vector vaccines. Johnson & Johnson is human adenovirus vector vaccines. And last of all, on 3rd November, another vaccine that is indigenous, our India-made vaccines, Covaxin, has been given license by WHO. So atrocities that we can have from the from vaccine, from a jab. So we have to keep the common molecules, that is, I have already discussed PEG and polysorbate, and in some vaccines, promethamine could be the culprit molecule for productions of atopic problems after taking the jab. And whenever we have to educate our patients, because after knowing little bit through Google search, they may think that fever, chills, and muscle aches and tenderness following, which is really actually showing the protective response, immune response to that jab. They take it as allergic reactions and they don't go for the second jab. So we have to educate them that it's not an allergic reaction, it's just the immunological positive response to that molecule. So far Pfizer BioNTech COVID-19 mRNA vaccine is concerned, there is total 21 cases of anaphylaxis has occurred when almost 20 lakhs, that is 2 million jab has already been given. That is, its incidence is almost 11.1 cases per million doses. So it's very minimal. So in those cases, whenever patient is in, that's why we all the time keep patients on observations for 30 minutes, because if they do have allergic reactions due to atopy, so this thing occurs within 30 minutes, and 70% of all people usually show their manifestation by 15 minutes. That's why 30 minutes observation is very important. And what about the Covaxin? It has covered its phase 3 trial, and it has shown that no severe vaccine-related adverse events, the bottom part of the slide, our deaths has yet been reported. So that's a very good, with efficacy is almost 77.8% efficacy. So that's a very good result so far our indigenous vaccine is concerned. So other atrocities, whenever we are getting atrocities, and a patient is giving allergic manifestation, don't say no to that you cannot have any vaccines, because all the time try to get to the facts before assuming the worst, that you may develop anaphylaxis reactions. So detailed history that has been told by our first international speaker, the detailed history is very much history to find out whether patient is really having allergic reactions to that, and whether this jab or this sort of vaccine is can create the same manifestations in that very particular patient or not. So history is very important, and through history, allergic reactions to any of the ingredients in the available vaccines whether patient is, you have to know the ingredients and whether to that ingredients patient is allergic or not. Or any drug or drugs allergy, drugs and vaccine, whether whatever you are going to put to the patients, whether patient is having that molecule as excipient or not. So if this thing is there, then what you can do, because you have to go for COVID vaccinations also. So in that case, what you can do, the provider, the medical person over there in the vaccine hub, that might recommend different vaccines not containing the allergen. So that could be interchange between Covishield or Covaxin or vice versa. Or if the patient is having allergy to Moderna or Pfizer BioNTech vaccines, messenger RNA, you can go for Johnson and Johnson's vaccine, that is the human adenovirus vector vaccine, or vice versa. This way, if this vaccine is not containing that culprit molecule, this way you can cover up the weakness that is patient is showing in the form of allergy. Same interchange can be done if patient is showing actions, allergic actions to the first dose of vaccine. You can switch over to another vaccines from Covishield to Covaxin, like that. But having seasonal allergies, we have to keep in mind seasonal allergies or shellfish allergies or some drug allergy. That doesn't mean that you cannot get vaccinated. So our reluctant answer, that is yes or no, should be a very thoughtful one. So severe allergic reactions or anaphylaxis to another vaccines or drugs, injectable medications, which injections a patient is really allergic to, you have to look for, and whether PS80 or PEG or some other constituents are there to produce that. So can one still receive the COVID-19 vaccine if they show? Yes, they can. As I have already discussed, they can have the COVID-19 vaccines, but you may have to interchange from the one to the another, as I have already discussed. And what is the most important part that I have said, that at least you have to put that patients, that's why all patients are being put on 30-minute observation. And that vaccine hub in a setting should be done in a setting where personnel, equipment, and supplies are present to manage if any anaphylactic reaction occurs. So you have to be well equipped. Before thinking that nothing will happen. So anaphylaxis commonly occurs within 30 minutes, I have already discussed, but 70% of those who are likely to develop anaphylaxis develop within 15 minutes after getting the jab. So for guideline is concerned, whenever you are asking 2-3 slides more, so possible allergic reaction to first dose COVID-19 vaccine, how can you guess? If you get allergic reactions within 2 hours, then you have to immediate type of allergic reactions you have to think of, and that immediate type of allergic reactions, if patient has to seek advice, systemic symptoms, allergic systemic symptoms has occurred, then they, before giving patient for the second dose, from allergy specialist or clinical pharmacologist. Similarly, if the patient does develop some allergic reactions in the form of delayed urticaria, on the right side panel, that is delayed urticaria or angioedema, and if that ultimately needed some admission in the institution or some great care, so better to go for allergy specialist before getting the second dose. If not, if it is if it has disappeared with 1 or 2 doses of antihistaminics, in the same vaccine hub, it could be taken the second dose. So proceed with vaccinations. You have to be very careful. You have to be very show very positive attitude. Just try to remember a few statements, that is previous allergic reactions, including anaphylaxis to a food, insect bite, and most medicines where trigger has been identified. If that trigger is not in that vaccine, you can jolly well say that yes, you can go for that vaccine. Previous family history of allergy does not contraindicate. Previous non-systemic reactions to a vaccines, that is non-systemic allergic reactions, just little bit of reactions on the site of skins, some edema, some tenderness, is not at all contraindications to that. And hypersensitivity to non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, and allergic to shellfish is not contraindication. and likely mastocytosis is also not a contraindication. So you should go proceed with vaccination in all these conditions. Then what is the contraindications of vaccines? If there is prior systemic allergic reactions to the COVID-19 vaccine, you shouldn't give that vaccines once again for the second time. You may have to opt for another vaccines. Or there is prior allergic reactions. We know patient know that he is allergic to that molecule, and you know that the vaccine contains that molecule as a excipient. You shouldn't give that molecule. So these are the two important contraindications to some specific COVID-19 vaccinations. So take home message, atopy is nothing but exaggerated IgA immune response to otherwise harmless environmental allergen. Usually they are potent. And increasing incidence of allergic reactions explained by hygiene hypothesis all over the world. This is hypothesis. This is being thought of that's why it is gradually getting increased in last 2 decades. And we all know that many of our patients and many doctors suffer from allergic rhinitis, rhinorrhea, as well as sneezing, almost 20 to 30% cases, both doctors as well as non-doctors. Allergic clinical features ranges from rhinorrhea, sneezing to anaphylaxis. Polyethylene glycol and polysorbate 80 and trimethanol are the common excipients having the potential to elicit systemic allergic reactions. PS80 and PEG is a good emulsifier and stabilizer and used in various vaccines and depositories and other antibiotics I have already discussed. So allergic reactions to seemingly unrelated drugs and vaccines are likely to contain PEG in that molecules, and PEG could be the likely culprit molecule for formation of atopic reactions. So cross reactivity, that is to be kept in mind. Cross reactivity between polyethylene glycol and PS80 is a distinct possibility. Post-vaccination 30-minute observation is a must, and 70% of allergic reactions do occur within 15 minutes after getting the jab. Contraindications, allergic reactions to the specific COVID-19 vaccines or prior allergic reactions to a component of that vaccines. That is a known fact when that is known to the patients through history. And vaccinations could be done if history of allergy. This is very important. We should go for vaccination if patient gives a history of allergic reactions, including anaphylaxis to a food, insect sting, and most medicines where trigger has been identified, and you know for sure that vaccine is not containing that trigger molecule, that culprit molecule, and family history of allergies is also not contraindications to any vaccine. So these are my references, and whatever I have discussed so far vaccinations and atopy is concerned. So a very good saying is there from Winston Churchill in the year 1942. This discussion as of today still prevalent, and this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. So we have to keep remember we are still toddlers. So for COVID-19 cases and vaccination is concerned, we have to know more and more, and clear picture will definitely take a few years to come. So with this, I give thanks to our learned audience for this patient hearing, and I will definitely love to have questions, comments, and advices from this learned gathering. Thank you for your patient hearing once again. Over to Professor Soumitra Ghosh.
Thank you, sir. Thank you, Professor Karmakar, and congratulations for beautifully exposing and throwing light on this most asked question about this vaccination in the atopic subjects. Because I already have told that is the last 10 months, it is the most important and the most asked question. And what he has said, that is whatever be the situation, vaccination should go on, number one, and it is the component of the vaccine which is creating trouble. Particularly in the Pfizer vaccine, he has already informed this polyethylene glycol component was the culprit, and in some cases this polysorbate is also this important culprit. So if we can identify, then we can switch over to some alternative modes. Particularly in our experiences in the last 10 months, we have seen that those who are grossly atopic, they have been hugely benefited with Covaxin without any of these problems where there is any doubt. But few questions have come from these few of our faculties. which I just simply modify the question to some extent, and I will place to Dr. Professor Karmakar. So whether you want any kind of pre-medication for those who are this history of atopy sort of things before any type of mandatory vaccination program. You want any kind of pre-medication, because many people have come with so many pre-medications, and there are a huge number of people, those who have some kind of allergies, and they ask these questions whether this kind of pre-medication will help. The specific question has been omalizumab, and you can just throw light on this pre-medication in a very nutshell, because we are lucky short of time.
Yes. So pre-medications in the form of some antihistaminics when patient is having non-systemic allergic reactions, we can give. But when patient is having systemic allergic reactions in the little bit severe, moderate to severe, even including anaphylaxis, better we shouldn't go for that molecule once again. Because if patient develops on the second exposure anaphylaxis, something like that, it's a grave medical emergency. Whether you will be able to save that patient or not, better to not to venture that thing seriously. And the biologic, Soumitra Ghosh has already said, that is being treatment for other atopic sort of manifestations like intractable asthma, intractable dermatological manifestations. But whether this biological will be used before any vaccination, particular vaccination to which another one culprit molecule is there, I should say that it's my answer that vaccination should not be tried once again. And Professor Ghosh, if he knows better than me regarding this thing, so if there is anything extra.
Professor Karmakar, can you please throw some light? Those who are not having any kind of anaphylaxis, but having some kind of adverse event in some different way, maybe Grace syndrome. So those who are having this Grace with the first dose, what should be your advice for the second dose?
Grace syndrome following any vaccination?
Yes, even after COVID, we have seen plenty of cases with Grace syndrome presenting after the first dose. So what will be your advice before the second dose? Should he go with some medication, or should he switch over to another one, or should he actually go for the second dose without fear?
Yeah. So Grace syndrome, majority of the Grace syndrome is, after the molecule is after a few days or weeks, patient will be automatically cured. Patient just needs some supportive therapy, not that sort of biologicals or some other things. And patient may need little bit of, the steroid. So in that case, if that Grace syndrome was not very serious one, so I can go for the second same vaccine with little bit of precautions of NSAID, antihistamine, something like that. And if needed, I can put patients on steroid afterwards if the patient's symptoms is really hampering his daily life. So I don't think that biologics is to be given to those patients if that first Grace syndrome was not very severe one.
Thank you, sir. So as there is no further questions, only just congratulations and thanks from these audiences in the form of these messages and in the chat box because your presentation was so excellent. It's a lovely presentation. Everybody will become envious to your flow of presentation and this tempo and this body language of this presentation. So I thank you, sir. So I will just hand over my dais to the organizers, to Dr. Shambhu Samasdar, please.
Thank you, sir.
Thank you, sir. Thank you very much. May I request Professor Soumir Malhotra, sir, are you there? I think Professor Soumir Malhotra, sir. Okay.
He is not there.
Yeah. So thank you once again, Professor Soumitra Ghosh, sir, for giving us your valuable time. As we are running short of time, we are moving to the next topic. And for that, to chair that session, may I request Professor Nihar Vishwas and Professor Shoilendra Handu to chair this session. Professor Nihar Vishwas is the director of IGIMS Patna, and Professor Shoilendra Handu is academic dean of AIIMS Rishikesh. So with that, may I request Professor P.A. Mahesh who is the Professor of Pulmonary Medicine at JSSMC. So may I request you, sir, to proceed for your presentation on research gaps in allergy medicine, considering the Indian context.
Okay, thank you. I would like to thank the organizers for having given me the opportunity to share some of my thoughts with you. I am not allowed to share the screen. Okay. Can you see my screen?
Yes, sir, we can see you.
Okay, thank you.
Yes, yes.
Thank you. So I would like to spend time looking at what are the research gaps in allergy medicine in the Indian context. And I have taken that in the context of the research that I have been doing over the last 25 years. And I would like to look at whole gamut of the factors, looking at the prevalence, looking at the pathogenesis, looking at the diagnostic tools available, and looking at the management. These are all the points I would like to touch upon briefly, because the gaps are too large. So I've just chosen a few important relevant ones. If you look at the prevalence of allergic diseases, as one of the previous speakers mentioned, it is definitely increasing all over. So we have been surveying about 2,000 children in Mysore every 5 years, starting from 1998. And we find there is a 50% increase every 5 years, reaching about 17% in the last survey. Now, the same holds good for rhinitis also, again, more than 50% increase every 5 years. Now, we looked at whether pollution was one of the reasons, because a lot of people say it is due to pollution. But if you actually look at over the period of time, because of the strict regulations that came somewhere around 2003, there's a big drop in pollution in the key levels of the pollutants in Mysore, but that did not reduce the increase in the prevalence of allergies. And therefore, the pollution may be a contributing factor to asthma and allergy exacerbations, but definitely, as we see here, and this is shown in studies from Delhi also, that it is not going to increase the prevalence of allergies. And this is with the PM2. With the PM10, we have similar findings. Now we are working, of course, with Yale, and we have mapped the whole pollution data of NO2 across Mysore. And we have a much larger study. This is the preliminary. We are fortunate in Mysore. Most of the areas in Mysore is within WHO standards. So that is rare for an Indian city. And we are now going to have data from the Global Asthma Network. We are going to do a more detailed study. I think in the next year, we will try to come out with those publications. Now, the research gaps are, we need to understand the real reasons behind the steep increase. And we need to have a combination of clinical and basic scientists in India to not only look at the risk factors, but also the protective factors are critical. Now, possibly the antenatal care is important, possibly the breastfeeding is important. When we studied urban and rural children, we find that rural women breastfeed for 2 years commonly, urban women 6 months. Now, if an urban woman were to breastfeed for 2 years, what is the reduction in the prevalence of asthma in the community? Now, that will take a decade to answer, but that's the kind of studies that we really need these days. I do find physical activity important. And after 25 years of research, I have now come to diet as one of the most significant, important, easy, modifiable factor that we should really, I think Raja spoke beautifully about the microbiome. And of course, we need to look at the air pollution in more detail. We need to look at how and why the genes are switched on at that particular point in time. We looked at urban and rural children in South India. And these are the areas. Due to paucity of time, I won't go into a lot of details. If you look at the prevalence of both asthma and rhinitis, much higher in the urban area. If you look at the skin prick testing in urban and rural, again, there is a vast difference between the two groups. If you look at various factors that can influence, we find that the animal exposure, the endotoxin, because a lot of people in the rural areas use cow dung, very rich in endotoxin, but it's a very protective factor because these are non-pathogenic gram-negative bacteria. So we need to look at how this is going to influence the prevalence. And it is not possible for an urban household to keep cows. But if you know the pathobiology, for example, this is mediated through toll-like receptors. That's one of the ligands for the endotoxin. So can you come up with a new molecule or a new drug that can help to prevent, or are there any dietary factors that can do the same aspect? So those are some of the critical pathways, like the GPR43 is very critical. And such studies can only be done in India and similar countries, cannot be done in the West. We did one of the largest studies on food allergy in the world, funded by the European Commission. And if you look at the effect of diet on sensitization, if you look at the vegetarians for any sensitization, it was 6.3. If you look at inhaled, 3.8, and foods about 2.53. But if you look at the non-vegetarians, it is far higher. My first task is, how is this possible? Fortunately, at that time itself, there was a paper that came in Nature, and they gave a fantastic explanation as to why this is so. Now, there is an increase in the dietary fiber. Now, that can, because of the gut microbiome, that can lead to the short-chain fatty acids, polysaccharide A, and peptidoglycans, and that's very critical for the immune regulation, homeostasis. And the short-chain fatty acids has receptor on every single immune cell in the body. And therefore, higher fiber or higher vegetarian diet has a significant bearing on the development of sensitization as well as clinical allergies. Now, our study shows only association. It's not causation yet. We need to establish a birth cohort and adult cohorts in India. Diet has the potential to modulate the immune system, I am convinced. Intervention studies for primary prevention need to be established. Lowest prevalence of food allergy in the world. We found that even lower than Africa. So the Indian diet has a definite bearing on this. And food allergy is a very, very difficult disease to treat. It's not easy at all, unlike asthma. There is an increasing trend even in food allergy in India. Again, such studies can be done in only a few countries in the world, and India should lead. Now, coming to the pathogenesis, we had with the Mysore University, with the genetics department, we looked at different polymorphisms, we looked at the concentration of the cytokines, and we were quite surprised to see when we studied single cytokines. Again, due to lack of funding, this is what we could do. If you look at the gamma interferon, if you look at IL-13, these are very well known. One is protective and one is a risk factor, but we did not find any difference between asthmatics, severity of disease, and healthy controls. That's when we started realizing this is a study when we did about 40 cytokines with Kaustubh Ganguly from Karolinska. We want to again do similar studies on asthma. I think single cytokines are not sufficient to explain why somebody has asthma or somebody has not. And you need to look at the whole gamut combination of cytokines before you can understand why somebody has developed a disease or why somebody is not responsive or somebody has severe disease. And it is not very simple. It is a whole complex pathways that come in, and studying only single molecules may not actually be giving us a good explanation as to why this is happening. So such sort of studies has to happen in the Indian context. So the gaps are, what are the influencers? What is the risk and protection in the allergy pathways in the Indian context? The immune system behaves in a very different way. When the dendritic cell is exposed to an allergen in a pathogen-associated molecular pattern low and PMP high environment, when it is high, the TLRs are activated, and then you get an entirely different language of the immune system, and then you get an entirely different outcome. And of course, when you look at the spirometry, this is one of the papers where we looked at the limitations of the spirometry. Again, with paucity of time, I won't go into the details. Suffice it to say that the gaps are, we need a normogram in the larger number of subjects. Only few states have done it. Possibly serial spirometry is important for the diagnosis of asthma, for the diagnosis of airway remodeling. And we need more studies in India looking at pheno and impulse oscillometry as aids to asthma diagnosis. What is the role when there is no reversibility and you want to say whether this is asthma or not? If you look at the skin prick testing, we have a lot of gaps here. We don't have a standardized extracts for SPT. We don't know a lot of locally relevant allergens. And the key issue, 60% of people everywhere are sensitized and allergic to house dust mite. Now, one lab study showed that house dust mite extracts in India have hardly any house dust mite proteins. And the main issue is the fungal contamination. All of us who knew how difficult the LJ medium was, because to do TB culture, it quickly get fungal contamination and the whole thing is waste. HTM culture is extremely difficult to have a pure culture, gets contaminated with fungal easily. And this is the most important allergen in India, and we don't have any good one from the Indian company. That's a big problem. And standardization of the food extracts for the locally relevant foods. With the CFTRI, we worked for 20 years only on brinjal allergy, but there are a lot of other locally relevant foods not used in the Western population. We don't even know what are the major and minor allergens of that food. Such work needs to be done. If you look at serum specific IgE, we screened about 32,000 people in Mysore and Bangalore for this study, and about 1,000 people we did the serum specific IgE as well as the skin prick testing. If you find that the main reason is IgE is protective, we are bitten by all the mosquitoes and various other insects, and the main detoxifying agent is IgE there. And like Africans, Indians are also very high IgE producers. Even for the foods that are not commonly consumed in India, you find that the serum specific IgE is very, very high. And if you look at the specific IgE 26.5, this is general population. This is not a diseased population. This is done in the field, in the community. Only 1.2 have probable food allergy. So serum specific IgE, you should be very careful. And people who have total IgE, you should be even more careful, because most of these were in people with the higher total IgE. And this is again true whether it is aerologen or food, it is the true. So when people have total IgE, more than 26% of normal population and more than 32% of the normal population are sensitive to either food and aerologens. The actual prevalence of probably food allergy in India is very, very low, despite very high sensitization rates. What are the protective factors? Very, very important for us to identify before we lose that, that kind of protective factors, and make sure that we retain it. I think that's critical. Looking at the management, I'm not going to deal with this. This is all published from the various guidelines. But what is key, none of the guidelines talk about disease progression. Now, all of us who treat patients with asthma and rhinitis know that very easily they respond in the first year, but they don't respond subsequently. As the time goes on, the response becomes less and less. So we need to, first of all, nobody in the world knows how to define a progressive disease. So we have made an attempt to say what is disease progression. And we believe that increase in the frequency of symptoms attacks, increase in the severity of attacks, increase in the annual medication requirement, increase time taken for symptoms attacks to respond. Once you start treating them, reduce response to medications. Rhinitis progressing to asthma or an asthmatic developing other organ disease would constitute disease progression. Now, this is one of our papers which we published in 2009. If you look at a very large group of patients do have progressive allergic disease according to those definitions. So 75% of patients with allergies have progressive disease. They're very, very afraid. 5 years ago, I was much better. Now it is so difficult. What's going to happen in the future? None of the guidelines talk about it. We know that immunotherapy is likely, with our experience. We have about 7,000 patients on immunotherapy. We know that it can halt the progression of the disease, but we need a lot of evidence and a lot of studies from the Indian population to confirm that. Treatment responsiveness is a very critical aspect. Not everybody responds the same, regardless of severity. You have a mild asthmatic, poorly treatment response. So how do we, sort of define this responsiveness? It is the ease at which control is achieved. Severity is the intrinsic intensity of disease. Control is the degree to which treatment goals are met after the treatment. Responsiveness is the ease at which the control is achieved. So this is a study. We had about 1,000 patients in this, including both controls and the asthmatics. We studied Adam 33, about 37 different polymorphisms we studied. These are the haplotypes that we developed. And we found that one particular polymorphism is associated with poor steroid responsiveness. Even after 3 months of treatment, the lung function remained very poor compared to other polymorphisms. Now, it is very difficult to really, we need to find out the reasons, because for the clinicians it becomes very difficult. Nearly half the patients did not reach normal lung functions in spite of treatment. And whether duration of asthma affects treatment responsiveness? Not really, it does not affect. Does severity of asthma affect treatment responsiveness? Absolutely. 70% of moderate persistent asthmatics cannot reach normal lung function. 94% of severe persistent asthmatics cannot reach normal lung function. We also did a cluster analysis, and we found 4 different clusters, and 2 of them, if you see, could not reach normal lung function. Again, due to paucity of time, I won't go into all the details that we have studied, but suffice it to know that we had 4 different clusters. One was a young group, and another is much older, and both these groups could not reach normal lung functions. So why are they poorly treatment responsive? What else can be done to actually improve treatment responsiveness in these patients? Is it a permanent feature? Can it be, is that reversible? So these are some of the key important points that we need to identify. We need to look at local pollens. People thought allergy because they are very heavy, they are transmitted by the insects. But it is not true. We had one of the common avenue tree in the Mysore-Bangalore area. Dolichondron is present everywhere across the world. And we found that it was the 4th most common cause of allergy. And none of the companies actually in the world have got Dolichondron platycalis. So it's very, very important that we look at all the locally relevant pollens. We need to have aerobiology centers across the country in different environments. We need to have regular pollen calendars with the reporting every week to help the clinician. We need to relook at newer plants and trees that have not been tested so far. And we need to have really institutes of eminence in the country taking this forward. Then we need to know, we know that 50% of patients with rhinitis will develop asthma. Who are these patients? We do not know. So this is one of the studies that we did. And we found that most people who develop asthma will do so within 2 years of developing rhinitis. So this is a very, very short time for if you want to plan for immunotherapy. And we found again some of the protective factors. Sensitization to dust mite was a very important or critical risk factor for the development of asthma when patients develop rhinitis. And one of the key preventive factors is allergen immunotherapy. When patient has rhinitis, you start immunotherapy, 70% you are able to prevent asthma. There's a lot of details on that, but such studies have not come out from India. It takes 10 years to do such a study. Therefore, it's very difficult. Funding is difficult. But those are the studies that need to come out from India. And definitely it can help to prevent the progression also. And it's very, very important and critical that a lot of studies come out from the Indian population. So we need to have a validated and more robust risk prediction scores that identify which patients with rhinitis have asthma. We need to start applying evidence from the meta-analysis on the prevention of asthma into clinical practice. And when patients should be referred to the allergy specialist is also very important, and give guidelines to the family practitioners and other specialists. I sincerely thank all my collaborators. I just touched upon some of the very important factors that are relevant based on my own experience over the last 25 years at this hospital where I work in Mysore. Thank you very much.
Thank you, sir. Thank you very much. Actually, as we are running short of time, we have to move ahead. We cannot take much more question. So may I allow the...
Hello. Hi, yes, I can hear you. Thank you. Thank you for the opportunity.
Thank you once again, sir. So may I request our technical team to project the CV slide for our next presenter. So, sir, Dr. P.A. Mohesh has beautifully illustrated the need of research in this allergy field to optimize therapy, to personalized therapy more. So now the next session is on urticaria and angioedema management considerations. And for that, we have Dr. Shravani Ghosh Joha. She had done his MD in dermatology from PGI Chandigarh, and she is the ex-associate professor in MIMS. So may I request Madam to proceed for the presentation.
Am I audible? Am I audible?
Yes, Madam.
Just give me a minute.
And we can see your screen also, Madam.
Okay.
No, now it is not there. You
Yeah,
have to
just
again.
give me a minute.
In between, we have Professor.
This is your presentation.
Yeah, Nihar Vistas, Professor Nihar Vistas. We can see you, sir. In between, if you want to make some comment, Professor Nihar Vistas.
Presentation first page ta kora nahi, bar kora nahi.
Sorry, I'm.
This is your presentation. No, एक second.
So while talking about research, in between, just I am sharing my a few points till Dr. Shravani Ghosh was sharing his screen. So for any research, we talk about ethics. So in ethics, two aim is important: morality and materialism. But another aim is also important, that is money. And I think that is one of the barrier in third world countries like India.
Can you see my slides? Can you
Yes,
see my?
now we can see.
A very good.
Yes, madam, you can
Yeah.
go.
Can I start? A very good afternoon to you all. I'm going to talk about a very common condition, urticaria, and not very uncommon condition, angioedema. So urticaria are hives. They are itchy raised areas of skin, and that can start at any age and without any warning. And angioedema is the swelling of the skin and subcutaneous tissue, which can be painful, and laryngeal edema sometimes can be really life-threatening. So the incidence of urticaria varies from 15 to 20% of the population. This is the Western data. We don't have our indigenous data. And acute urticaria is more common, with female preponderance, and the age is usually from 20 to 40 years. And we must understand that there's a group of patients where this urticaria and angioedema can overlap in 40% of the patients. So whenever a patient with urticaria, I'm sure all of you have faced this in your clinical practice, present with such severe lesions, the first thing they will ask you, doctor, why I'm having this? And as a physician, you should know what you are dealing with. How should you classify urticaria? What are the medical conditions or drugs could be responsible for this? What are the tests should be done? And how best you can treat your patient? So urticaria, if the duration of these urticarial lesions are more than 48 hours, we call it urticarial vasculitis. That is not what we are discussing today. If the lesions are more than 48 hours, then you look for the duration of the disease. If the duration is more than 6 weeks, we call it chronic urticaria. And if it is less than 6 weeks, we usually call it acute urticaria. And chronic urticaria can be divided to chronic spontaneous urticaria, inducible urticaria, and in certain cases, you can find some causes. Now, coming to the causes, in spite of our best efforts, most of the time we are unable to find any particular cause. So we call it idiopathic urticaria. You look for the list medications, not necessarily. This medication history is really a tricky part because most of the time the patient forgets that they have taken any medication. So repeated questioning is very important. History of any food, stings, any infection, or physical factors which could have aggravated the urticaria needs to be questioned. And sometimes in rare causes like neoplasm, collagen vascular disease, endocrine causes, they can be responsible. So what is the pathogenesis? This is an immune-mediated inflammatory disease. The exact pathophysiology is unfortunately not clearly known. In 30 to 50% cases of chronic urticaria, an autoimmune theory has been put forth. Mast cells, eosinophils, endothelial cells, there's complement activation, there are coagulation abnormalities, there's mixed Th1, Th2 response. But the bottom line is it is a mast cell driven disease. And these mast cells are the primary effector in urticaria. These cells are widely distributed in the skin mucosa, and they have this high affinity Ig receptor, which our previous speaker all highlighted. Urticaria results in release of mediators like histamine, bradykinin, leukotrienes, prostaglandins, etc., which give rise to the clinical symptoms. This is a schematic representation. There could be some extrinsic factors which can lead to mast cell degranulation. There could be intrinsic factors like autoimmunity, autoallergy, complement pathway activation, or splenic tyrosine kinase signaling defect. So all this leads to mast cell degranulation, and there's release of these chemical mediators. There's now the sensory nerve fibers are stimulated, which releases the substance P, which is actually responsible for the intractable itching that we come across in urticaria. And also these chemicals causes vasodilatation. There's mixed cell infiltrate, which leads to edema and erythema that we see clinically. So in acute urticaria, it can be IgE mediated, circulating antigens as food, drugs, insect stings, they can be responsible. There can be non-immunologic release of histamine, as happens with acetylcholine, opiates, etc. Or it can be complement or immune complex mediated. In chronic urticaria, we are less fortunate. It is the chronic urticaria which actually bothers us most. In 53% of patients, most of the time we can't find any cause. And in 23%, it can be physical urticaria. And if you're lucky, you can have some causes in a small number of patients. So physical urticaria, they are the group of urticaria where mechanical, pressure, thermal, solar radiation, etc. can cause the lesion. Of this dermographism is most common, where stroking of the skin can give rise to these linear lesions, and patients really feel very frightened. But if the patients are very symptomatic, then only we advise treatment. Otherwise, just the presence of dermographism should not warrant any treatment. Now, delayed pressure urticaria, where we put sustained perpendicular pressure, can cause articarial lesion. Cholinergic urticaria is a special group where they present with small discrete articarial lesions on exposure to heat, exertion, stress, and sometimes managing this urticaria can really be tricky. I had this tennis player who had this cholinergic urticaria. So, and the medicine which responds best is cyproheptadine, which can actually slow down this player. So sometimes it is the balancing about the patient's profession and the drug choice we have to make clinically. Cold urticaria happens on exposure to cold. Here we have induced cold urticaria on, on putting an ice cube. It will reveal a wheal and erythema, as we see in urticaria. So do remember that cold hemolysis and cold agglutinin disease should be ruled out if you come across patients of cold urticaria. Now, urticaria and COVID-19 needs special mentioning. My previous speakers have highlighted quite nicely. In last 2 years, whenever the patients have presented with new onset urticarial lesions, believe me or not, we have diagnosed so many patients of COVID-19 infection just by urticarial lesions, because the patients can be very asymptomatic, or the lesions can precede or start with other symptoms as well. So whenever you see the onset articarial lesions, it is important to look for other viral infection as well as COVID-19 infection. The pathophysiology may be related to the complement and mast cell activation by the direct cytopathic effect of the COVID-19 virus, or by the cytokine signaling. And also during these past 2 years, lots of antibiotics have been used, especially the doxycycline. So drug-induced urticaria became more common because we have used more and more drugs. And of course, last but not the least, vaccine-induced urticaria. My previous speakers spoke about hypersensitivity reactions, but urticarial reactions, which is more delayed onset, they are also being increasingly reported, especially after the second dose of vaccine. So coming to the management, diagnosis is the most important thing. You have to identify the cause, and appropriate investigations and treatment are necessary. So for diagnosis, history is the key factor. That is the most important thing to diagnose urticaria, because most of the patients, when they present to you, they don't have these urticarial lesions. So sometimes they bring pictures, so that can help you, but most of the times nothing is available. So it is the history which can help you to clinch to the diagnosis. For acute urticaria, ask about symptoms of anaphylaxis, because that is very important. If the patient have that, if we overlook that kind of tendency, that might be detrimental for the patients, and we have to advise the patient accordingly how to manage it. For acute urticaria, usually we don't advise much laboratory investigations. For chronic urticaria, most of the time, as I mentioned, we usually don't find any identifiable cause. If we history, if it suggests physical urticaria, we can do the challenge test, which I have demonstrated before. Patient often ask about food allergies. This IgA-mediated food allergy is far more likely to be present in acute urticaria. A detailed food diary or dietary modification may reveal foods or additives that can cause fluctuations in symptoms of chronic urticaria as well. So laboratory tests, as I was mentioning, for acute urticaria, usually none, but for chronic urticaria, sometimes we advise and thyroid antibodies. Skin biopsy rarely can be done to see the type of infiltrate, which actually can help us to decide what kind of medicine we are going to give. And other tests can be carried out depending on the symptoms of the patient. Now, autologous ASST means autologous serum stimulation test, which involves intradermal injections of patient's own serum into the patient's polar aspect of the patient's forearm in serial dilution and with histamine and normal saline as a control. And development of wheal is taken as a positive reaction. And it is it's an indication that the circulating antibodies of autoimmune urticaria. Now, differential diagnosis is very important, because urticaria can be confused with many other skin conditions, of which articarial vasculitis is most common. As I mentioned, articarial vasculitis lesion persists more than 48 hours. They can be painful. They can have other systemic symptoms, and usually they can leave some, hyperpigmentation once they heal, but usually histopathology will clinch the diagnosis. Systemic mastocytosis, Professor Moitra already highlighted. Darius sign is the key to clinch the diagnosis. Once you stroke, there is articarial reaction on the patches. So that is the key to the diagnosis of mastocytosis. And as he rightly pointed, this is really very often missed. Atopic dermatitis, non-bullous, bullous pemphigoid, erythema multiforme, they all can be confused with urticarial rashes. Now, as I mentioned, will clinch to the diagnosis. Now, coming to the drug treatment, treatment proper non-drug therapy includes explaining the patient education is the most important thing in treating urticaria, because addressing their anxiety, if you don't address the anxiety, half of the treatment will fail. Where you find the inducible causes, we have to avoid those, and exclusion diet or low pseudoallergen have also been tried. And coming to the treatment, this is World Health Organization, World Allergy Organization recommendation. The first line treatment is second generation H1 antihistamines. If the symptoms persist after 2 weeks, You can upscale the dose of antihistamine up to 4 times. You can increase the dose. If the symptoms still persist 2 to 4 weeks, you can consider introducing a third line therapy like omalizumab or cyclosporin. And at any point, if the lesions are uncontrollable, steroids can be used, and they advise not using steroids more than 10 days in a month. Now, treatment outcome, usually there are no tests by which we can say whether the patient is improving. So we ask the patient to record, which is called patient recorded outcome measures or PROMs, and Urticaria Activity Score is one of them. These are mainly used for research purposes to see the effect of the drug treatment. So in spite of our best efforts, chronic urticaria can become a huge challenge. By the time they come to us, they had multiple antihistamines, they had multiple courses of steroids, and steroids doesn't really change the course of the disease or alter the outcome. So there comes the role of third generation medications. Now, omalizumab, only biologic currently approved, it inhibits the binding of high affinity Ig to its receptor on the mast cell surface. And ligelizumab, which is undergoing clinical trial, they have shown promising results in clinical trials, and they have apparently 88% higher affinity towards this receptor binding. So we do hope probably we will have a better drug in future in managing chronic urticaria. Our search and omalizumab have been in various studies shown to be effective in adult as well as children, but we do know, and also the respiratory physicians know, that after some time this omalizumab doesn't really work. In some patients they don't work, and in others even they do work. After 3-4 months they loses its efficacy, and patients with higher Ig definitely tend to respond better. So the people have tried updosing this dose of omalizumab to 450 milligram, or even 600 has been tried, and they found better results with updosing of omalizumab. So the search for better drugs continues. There are loads of drugs undergoing trial, of which Bruton kinase inhibitor, this is a third generation BTK inhibitor. This forms a promising target for the treatment of chronic spontaneous urticaria. So Bruton kinase inhibitor binds here. So it prevents the transduction of the signal downstream into the cells. So inhibition of will prevent this downstream signaling, and the subsequent degranulation of the mast cell will be prevented. So they have undergone phase 2 trials, and phase 3 trials are on now. So coming to the next topic, angioedema. Angioedema is defined as vascular reaction of deep dermal subcutaneous tissues or mucosal, submucosal tissues with increased permeability of the blood vessels, resulting in tissue swelling. Many areas can be affected, like eyes, around the mouth, genitals, hands, feet, and there can be abdominal pain, shortness of breath, dizziness, and fainting. So here you can see the most of the cases, angioedema, we don't find the cause, but in 25% cases, there can be C1 inhibitor deficiency, which can be hereditary or acquired. And over last 2 decades, this AC inhibitor has been increasingly responsible for new onset angioedema. In this picture, you can see this asymmetric swelling of the mouth, and they can be painful. They can persist for longer duration, swelling of the hand, swelling of the lips, and of course, as I mentioned, there can be laryngeal edema, which can be dangerous. So the clinical features happen because of the capillary leak. There's urticaria, angioedema, laryngeal edema, and hypotension, syncope. Smooth muscle contraction gives to abdominal cramp, nausea, rhinitis, conjunctivitis, and mucosal secretion leads to bronchospasm and diarrhea. So these are the 2 mechanisms by which angioedema happens, because mast cell degranulation can lead to histamine, which can cause angioedema, and then there can be this complement activation, which can lead to secretion of bradykinin, that can lead to angioedema. And here I've tried to show the pathway where we can block with the medications. C1 esterase inhibitor, they can disrupt factor 12A and kallikrein, and thereby stops bradykinin production. Ecallantide again stops kallikrein, inhibits kallikrein, and icatibant is a B2 receptor which inhibits this angioedema formation. Now, these two sides, this is histamine mediated and this is bradykinin mediated symptoms. In histamine mediated, the onset is more acute. There is arterial rash, itching, and you can have hypotension, shock, and the response to epinephrine is of course better. Whereas in angioedema, it is slower onset. It can persist for 2 to 5 days. 50% can have abdominal symptoms, and family history can be positive, and definitely it is refractory to normal treatment we use for allergy. So these are the types of angioedema. I'm not going into the details because it's already quite late, but I just want to highlight this hereditary angioedema type 1 is because of C1 esterase deficiency, and type 2, the levels are normal, but there's functional abnormality. And this is AC-induced angioedema. And a third kind of hereditary angioedema has been described now due to factor 12A mutation. And also these days, this tissue plasminogen activator, which are increasingly being used for ischemic strokes, that has been shown to cause angioedema because it activates histamine release, but also it leads plasmin-mediated bradykinin release, which can cause this angioedematous reaction. So one has to be aware of this condition. So when do we suspect hereditary angioedema? When patients with history of recurrent angioedema with a positive family history is present in 25% of cases. History of minor trauma stress can trigger these attacks. Onset is between childhood and adolescence with painful abdominal symptoms, occurrence of upper airway edema, and these patients, of course, fail to respond to usual treatment. So presence of prodromal symptoms sometimes are there. There's no arterial reactions, and laboratory tests reveal C1 inhibitor is normal, but C4 can be low. So differential diagnosis of angioedema is also very important. The most common presentation is allergic contact dermatitis to hair dye. Then DRESS syndrome, the previous speaker spoke, but DRESS syndrome, there will, in addition to facial edema, there will be maculopapular rash or scaly rash. Dermatomyositis is another condition which can be confused, but you look for other systemic features, other skin features, which help us to clinch to the diagnosis. Granulomatous cheilitis, again, another condition where there's solid edema of the lower lip, which is persistent. Also, superior vena cava syndrome, subcutaneous emphysema, procedures over the face, they all can give subcutaneous edema and mimic as angioedema. So whenever you come across with the patients of angioedema, make sure about the airway. If the airway is not secure, secure the airway, and then you try to establish the diagnosis. Check for multi-system involvement. Again, if there's multi-system involvement, look for the signs, symptoms, and take according measures. Look for urticaria. If there is urticaria, you treat accordingly with antihistamine, steroid, whatever. If there's no urticaria, if there's any suspected allergy, if you don't find anything, look for whether the patient has known history of hereditary angioedema or any family history. If yes, then of course treat as hereditary angioedema. And do look for SCI therapy or non-steroidal anti-inflammatory drug exposure. Then again, they could possibly lead to angioedema. And if you don't find any other thing, then look for other underlying pathology like lymphoproliferative disease, collagen vascular disease, thyroid abnormalities, and try to manage the patient accordingly. The problem with us that we don't have the drugs available that are required to treat angioedema here except fresh frozen plasma. So that is the only option for us for bradykinin mediated disease. So treatment of acute attack, this is the World Allergy Organization. They have advised this treatment. But again, even if you diagnose, as I said, in bradykinin-induced angioedema, access to appropriate drugs becomes very difficult, and also there is no protocol in most of the emergencies. So the treating physician is in a dilemma how to manage the patients. Of course, we have this danazole, tranexamic acid, and fresh frozen plasma. These are the only medications we have in our hand to manage bradykinin-induced angioedema. So the rational decisions that needs to be made, whether your patient should receive prophylactic or on-demand treatment, this will decide on your patient's history and their risk. Management during surgery and dental procedures and minor other interventions is special mentioning, because we know that the physical trauma is known to precipitate these attacks. So difficulty may arise during intubation or even after 4 to 30 hours of the surgery. So your patient is not out of danger unless you monitor this patient properly. And prophylaxis will depend on known history of the patient and its procedural risk. For pregnant and lactating mothers, we can't use danazole, we have to use tranexamic acid. And for children, usually the attack is not very severe, and prompt control of the edema and short-term prophylaxis and intermittent treatment probably will be able to help this group of patients. So why this is important? Angioedema is rare, but it is a disabling disease. Identification of this disease is crucial because most of the time it is overlooked, and not all swellings are angioedema. Misdiagnosis can lead to potential serious conditions. So underlying clinical features unique to angioedema will actually help physicians to target appropriate treatment. Thank you very much, and I thank the organizers for giving me this opportunity. Thank you.
Thank you, madam, for your lucid presentation. May I now invite Professor Biswas sir for his concluding remarks.
Hello.
Over to Professor Biswas sir.
Hello. Yeah, can you hear me?
Yes, sir, you are audible.
Yeah, there are 3 speakers, I think.
Yes.
When will be the third speaker?
The third speaker is sir ready with his presentation. Then may
I think that is better. Let all the 3 speakers speak.
Okay, fine.
Then we can invite questions.
Okay, fine. Fine, sir.
Yeah. Okay. Yeah.
So I request the organizing team to put the introductory slide for Dr. P.C. Kathuria, sir. So I invite Dr. P.C. Kathuria, sir, to talk on role of immunotherapy in asthma, where we stand now. He is a senior consultant in the Department of Allergy and Asthma, National Allergy Center, and BLK Super Specialty Hospital, New Delhi. He is an erudite academician, and he has got 42 years of his experience in clinical practice of allergy and asthma diseases. He has been the chairman for and having 23 training courses in allergy testing and immunotherapy at National Allergy Center. So over to Dr. P.C. Kathuria, sir, for his talk.
Good afternoon, everybody. Am I audible?
Yes, sir, you are audible.
My greetings to all. Thanks the organizing chairman, secretary, Dr. Saber Moitra, Dr. Shambhu Samrat, and others key persons behind this whole team for giving me opportunity to share my thoughts on the role of allergen immunotherapy in asthma, where we are now in 2021. This era is not an era of the evidence-based medicine, but also the precision medicine. where you have to stratify the patients according to the phenotypic, endotypic characteristics and the biomarkers. And same story is with the allergen immunotherapy, which is a personalized medicine, is a customized medicines, and a tailor-made medicine. It determines which treatment patients should need, whether it's subcutaneous, sublingual, what doses, what schedule for the best of the patient. It is unique and an unmatched model because it is the only therapy which can modify the natural course of the disease. We love allergen immunotherapy because it has withstood the test of the time for more than 100 years. And there is a well documented efficacy on allergic rhinitis and asthma, secondary to the pollen, dust mite, and a cat. It has got a 3P specific characteristics. It decreases the progression of the disease from rhinitis to asthma. It has a long-lasting effect even after discontinuation, and it prevents from monosensitizations to the polysensitization. It started as a clinical experience in 1911. Now it is a clinical evidence as well as a precise medicine. The two legends, Noon and Freeman, started in 1911. It is an ongoing evolution. Now we are with the slit as well as the skit also. Variable region, variable practice. In USA, skit is more important rather than the slit, but most of the European countries, they are equally using the slit and skit. In our India, we are using predominantly skit, but some people, they have tried now to start the skit. No questions on the efficacy as well as the safety in respiratory allergy, as well as the insect bite hypersensitivity reactions. There is always questions on a food allergy, latex allergy, atopic dermatitis, and urticaria in relations to the house dust mite. We have got a good armamentarium of the drugs available: 5-group, LAVA, LAMA, ICS, xanthin, OCS, but none of the drugs acts as a preventive effect. It is the only allergen immunotherapy which has got the specifically the disease modifying effect, no preventive effect. Why we need allergen immunotherapy in our patients? Because there is a persistent loss of the lung function. There is a risk of exacerbations. Most of the studies, they have confirmed that it impacts asthma control as well as the future risk of the control. But there is a heterogeneity because of the different allergens available with us and different extracts available. There is a decrease in the risk, increase in the risk if my patient has an uncontrolled asthma, if my patient is a polysensitized, multiple sensitivity are associated with uncontrolled food allergy, atopic dermatitis, chronic rhinosinusitis, and nasal polyp. If my extract is not specific to the relevant clinical allergen, if my extract is not standardized, it doesn't have stability as well as the safety. And moreover, the allergen immunotherapy is a dose as well as a duration dependent. So risk will increase as well as the efficacy will decrease. But we can balance it on the base if we detect the clinical relevant allergen and we know the effective dose of the allergens. Skit has got a better efficacy. But even safety is also there. If we have a slowly increasing dose according to the protocol, if our modified extracts are able, if my patients is well controlled. So efficacy is much better with the skit, but slit is also better safety, but it is still questionable. In 1911, it was a known Freeman who started this Lancet paper came out more than 100 years back. We are following the same build-up dose and maintaining the dose. Take 20 weeks and maintenance may take 3 to 5 years. Initially, there is a early desensitization, then B cell tolerance, regulation of the ILC2 and the T cell tolerance. As it decrease in the TH2 cytokine, IL4, IL5, 13s, and there is increase in the interferon. At the same time, there is a synthesis of the T regulatory cells with a decrease in the IgE, which competes with the IgG4. So if you look at the benefits of the allergen-specific immunotherapy, they are more than the others which we give only the pharmacotherapy. The recent guidelines of Yaki says not only look for the clinical outcome, but also look for the serological outcome as well as the cellular outcomes. Clinical proven efficacy is based on house dust mite, pollen, mold, animal allergens, as well as the venom and cockroach. So why this proven allergens has got a strong efficacy? It depends on the recipe in our allergen extract we prepare. It is not the homemade recipe you prepare. You prepare the standardized products. Hard evidence needs proper effective dose. And this dose has been mentioned in the practice parameter. The dose should be specific. If you use the less than 7 micrograms, say for example, in a house dust mite, our immunotherapy becomes placebo therapy. Even this alternaria, you need 8 micrograms. This is the specific dose. These doses are specified for the specific allergens. Even there are 19 standardized extract allergens in USA, but there are also non-standardized extracts. If I look at our Indian setup, they are non-standardized, but still it is effective with the pollens. But rest of the universal allergens, still there is a question mark. If I go back to the study by Johnson et al., he did 40 in 1968. He found that even if he is using the extract of unstandardized 1 in 250, still the efficacy is 81% in the first 4 years, or 78% in further follow-up in 16 years of the age. So it was followed about 14 years after 2 years of the allergen immunotherapy. There is a strong reduction in the asthma if you give allergen immunotherapy. So, but now in 2021, we need standardized extracts. These standardized extracts, we know the potency, we know the dose, there is a therapeutic efficacy, there is a consistency in the batch, and safe. So the questions arise, what are the best endpoint in subcutaneous immunotherapy in asthma trial? If you look, there are up to 98 trial studies that have been done. 54 trials of the subcutaneous, 44 trials on the sublingual immunotherapy. And look at this, the statement given, primary outcome, no problem. Reduction in the medication, reduction in the symptom scoring. But secondary outcome, it is the subcutaneous immunotherapy which improved the quality of the life, decrease allergen-specific airway hyperreactivity. But this was not the case with the sublingual immunotherapy. There is no consistent effect on asthma control, exacerbations, lung function, and non-specific hyperreactivity. So subcutaneous immunotherapy in asthma is still has got a better edge. These are the studies recently found, Yaki guidelines. They do it specifically on the house dust mite driven allergic asthma. And they want rather the expectations were not only on the exacerbations, lung functions, but also on the airway hyperresponsiveness. And the diagnosis was made only those patients, those who have got a atopic constitution, atopic dermatitis, food allergy, allergic rhinitis. They were given immunotherapy. Those were excluded. Even asthma was there with sensitization, but no atopic constitution. And further, they found even those patients who are partially controlled, you can give an allergen immunotherapy. The question is there that these patients, even they give sub-slit tablet, they found decrease in the exacerbations, asthma control and others, but not in the AHR, not in the airway hyperresponsiveness. So why house dust mite is important? Because 85% of the patients in our setup, also more than 80%, they are sensitive to the house dust mite. There are 88 trials has been done, and 42 of the house dust mite and rest of the other allergens was done. And if you use a hypoallergenic, modified allergen like it was used initially when Allercon was there, and there is a strong reduction in the ICS doses was found. And also other studies found not only in the, even if the patient is a monosensitized or polysensitized, response is much better in both. So strong reduction in the ICS dose, the dose is 6 or 12 AQ is being used. Increased reduction of the ICS in even the partially controlled asthma was found with a house dust mite. So if you go back to the Cochrane and Brownson studies, that were found that 30 times decrease in the bronchial hyperresponsiveness. Please note, none of the drugs, none of the other therapy, which decreases the 30 times reduction in the AHR, airway hyperresponsiveness. That is the only therapy which decreases. Symptom scoring decreases as per the meta-analysis, medication scoring decreases as per the, look at the skit. Pendulum is still in the center, but slit. Pendulum is touching the center. So please note, skit is much better, more effective than the slit in a subcutaneous in our allergic asthma. Now, if I discuss about the GINA, GINA has come 2017 slit. Why? Otherwise, we have got a good database in 2010, 2015, and 2018 also. It was based on the study that they did 4,000 patients in children, so they found benefit. They found in stage 1 there is a reduction to the stage 2. Progression decreases. But slit in as per the GINA guidelines is based on only on the symptom control exacerbations, not on the remissions. They took even GINA step 1 and 3 or step 3 and 4, they found that there is a reduction in the symptoms and the medications score in short term. So meaningfully influence the progression of the severity. And FE1 should be more than 51 as per the statement, but the slit is only for, is under GINA guidelines. Otherwise, SCIT has got a better right if you are treating our patients of a allergic asthma. So look at this question mark. If we use the slit, no consistent effect on asthma control, exacerbations, lung function, and in non-specific airway hyperactivity with the slit. But it is good for allergic rhinitis, and there is a possible preventive effect on development of the asthma in children with hay fever or development of the new sensitization in a monosensitized. So where we stand now, if we use in a secondary prevention, patient is suffering from rhinitis, we prevent from ongoing inflammation. We can prevent to develop bronchial asthma. Our patient is a monosensitized, we can prevent to the polysensitized. But if my patient is a tertiary in a uncontrolled asthma, only the symptoms reduction is possible. And primary prevention, still there is no evidence. Now let me share the criteria where we stand in allergen. If the patient is only sensitized, belongs to the high risk parents, there are few evidence, but the efficacy is still poor. Like this case, GPEC study was done and they found that there is a no efficacy data due to the underpower of the study. Another study they did on the house dust mite only, and they found in children that there is no significant preventive effect was observed on house dust mite sensitization or allergy related. So in a primary prevention, allergen immunotherapy, poor evidence, still we are awaiting, studies are going on. But in case of a seasonal allergic rhinoconjunctivitis or rhinitis, there is a strong evidence. Volumes of the material is available with us that it is effective in prevention of the asthma and rhinitis and in prevention of the pneumonia. So this case, like this case, no asthma, no pneumonia, but only the rhinitis. Lot of the data is there. It prevents the ongoing inflammation. These are the studies has been done. Evidence is there that in patients with allergic rhinitis, allergen immunotherapy should be considered to prevent asthma. PET study is there, 3 years, follow-up done 10 years, prevention is possible. So this is a hard evidence with us that in these patients, 10 years follow-up, 25% hardly they get, while in placebo they got 45%. Next come the allergic asthma, seasonal allergic asthma, where we stand. These are the cases where we can give remission to them. Now, even if these patients, they are partially controlled, but one has to be differentiated of the atopic background. Patients have allergic rhinitis, atopic dermatitis. These patients you start early because these patients are not in a state of the remodeling. You start these patients without, they are not on the steroid. Their FE1 is normal. You can give remissions to this patient. But those patients, those who are a perennial allergic, simply on the lava ICS, even then remission is possible. But these patients, they are likely to produce more reactions because they are polysensitized. So for that way, what we will do, like these patients with 31 years old, our patients, the perennial symptoms is the seasonal exacerbations. These patients strongly positive, even he has got a steroid dependency, but still these patients improved with our allergen immunotherapy. Most of those patients, they are polysensitized in perennial asthmatic, and they not only need allergen immunotherapy, but they need biological also. Because if you add biological, you are increasing the efficacy and safety, and it is a synergistic effect. If you use a biological and you extend our, most of these patients, they have got a food allergy, atopic dermatitis. So in these cases, they are uncontrolled asthma. Biological are as a adjuvant effective, synergistic for us, and there is a reduction in the adverse events. Even these patients, if you add biological, they have got a steroid sparing effect. Like these are patients, we started cluster immunotherapy with the omalizumab, and there was a reduction in the OCs also, and this will achieve the MTD in 3 visits with this proper dose. Another patients, we use the series of rhinitis and asthma, and we achieve remission in some cases, those who are not in a state of the remodeling. Now, friends, we have come a long way, not only from allergic immunotherapy, then we had omalizumab. Now we are having those cases polysensitized using 2 or 3 groups of the allergens. One group we are giving the skip, another group we are giving the slit, and the efficacy is much better if you add both of them, skip and a slit. Now, again, the last type of these asthmatic patients, who are in a state of the FAO, fixed airway obstruction. These patients, at present, it does not have indication in our allergen immunotherapy. SLIT may have a future in combination with the biological. Further convincing evidence are needed. So these patients may be given allergen immunotherapy with a SLIT sublingual. Studies are going on, and we are awaiting the results. Sublingual immunotherapy, even in a severe asthma, but they should be controlled as add-on therapy with a biological as per the phenotypic and endotypic environment. So the key point, allergen immunotherapy is not expected to be less efficacious in subject with a asthma patients. Risk-benefit ratio should be assessed in all cases. Patient with a severe uncontrolled asthma are at increased risk of systemic reaction Therefore, allergen immunotherapy should be initiated when symptoms are controlled or partially controlled. Sublingual immunotherapy appears to be safer. However, the first dose is administered under it is only in a severe asthma, and these patients should be and take-home message, allergen immunotherapy can achieve substantial reduction in the short-term symptoms and medication scoring in allergic asthma. Subcutaneous immunotherapy improve quality of the life and small airway function and decreases specific airway hyperreactivity as a secondary outcome. This is not possible with a sublingual immunotherapy. GINA guidelines steps 1, 2, 3, 3, 4 decrease the risk of asthma progression. Efficacy of the allergen immunotherapy depends on the dose and duration. Safety of the allergen immunotherapy, allergens decreased by standardized extracts, modified extracts combined with the biological omalizumab, but maintaining the immunogenicity. So what we stand that when should be given well-controlled asthma, and it should be with product well standardized extracts, and it should be integrated with the biological. We expect decrease in the symptoms and medication score, as well as we want to decrease in the bronchial hyperreactivity, which is most important in our asthmatic patients. With this, thank you very much for your kind attention. Over to moderator. Thanks, sir.
Thank you, sir, for your lucid presentation. May I now invite Dr. Bishwas, sir, to pass the concluding remarks. Dr. Bishwas, sir.
I think there is something network issue from Nihar Biswas sir's end. So I am requesting now Professor Shantanu Kumar Tripathi sir. First of all, we should acknowledge our we are very much thankful to Professor
Thank you
P.C.
very
Kathuria
much.
sir.
This yeah. Can you hear me? Am I audible?
Yes.
Hello?
Yeah, now you are audible, sir.
Yes, we can hear you now.
Oh, okay.
Okay, so there may be some issue. So we are really thankful to Dr. P.C. Kathuria sir for this wonderful deliberation and giving us your valuable time. Thank you very much, sir, once again. So now we are at the end of our scientific session. There is one more lecture, and after that we have some we have another important part of our conference, that is paper presentation, scientific paper presentation. So before that, may I request Professor Shantanu Kumar Tripathi sir, because are you there, sir?
I'm there. Yeah.
Okay, sir. So there is one topic left by Professor Shantanu Kumar Tripathi sir, that is on the gut, the talking point of microbes and the host immune system. So may I request Professor Shantanu Kumar Tripathi sir, who is the renowned clinical pharmacologist in the country. Now he is the Director of Clinical Research at John C. Martin Center for Liver Research and Innovations, IILDS, Sonarpur, Kolkata, and also Academic Dean and Professor and Head of Pharmacology at Netaji Subhash Medical College, Patna. He is also the Visiting Professor of Indira Gandhi Institute of Medical Science, Patna. So I think we all know him. He is the President of Allergy Asthma Research Center also, whose national conference we are now organizing. So may I request, sir, to proceed for your presentation.
I have to share the screen, so you have to on screen now.
Yes, sir, sure.
Sir, you have to share your screen again.
Right. Is it visible now?
It is coming, sir. Yes, sir.
Okay. Before I start, I must thank Dr. Katuria, PC Katuria, for a wonderful presentation on the topic. It was very absorbing. Thank you very much, sir. Thank you very much. So it's our privilege to have you. Thank you very much. So I think this is mine is the last session. And after that, of course, there is a free paper session, which is, I think, competitive. So I'm not going to stand between the competitive session and all the members of the audience who have joined. So I'll just briefly go through this concept paper, you can say, that is talking point of microbes and host immune system. It's otherwise extremely important and relevant in the context of the whole issue of allergic disorders. We all know that how in the recent times, particularly maximum insight has been developed in the last 1.5 decades, that how the microbes and particularly the commensals microbiota, the impact on our host immune system. So a lot of new knowledge has actually gathered, and it's in itself it's a huge tending to become a sub-discipline. Okay, and in near future we are expecting that in another decade or so there are many more new vistas of knowledge will be explored and will make us wiser. I'll go through some of the basic concepts, rather philosophical aspects of this, and this is a highly evolving science and highly evolving discipline. To start with, when we talk of microbiome, let me have a full screen. Okay. So when you say microbiome, it is not just the microbiota, but the microbiota and their activities. And when you say activity, microbiome actually encompasses both the microbiota. Microbiota refers to the community of microorganisms of different kinds that otherwise are at the interface of our existence. Now, when we say community of microorganisms, broadly, we tend to refer to non-pathogenic organisms, which otherwise under usual situations do not cause disease. And to differentiate these with the pathogenic organisms, we call them pathogens. In fact, the microbiota and the pathogens, they are constantly in dialogue with or interacting with each other. And in the whole bargain, it is the host, human host, where the microbiota resides, is benefiting. The host is benefiting. Of course, the benefit is not unidirectional. The host has allowed the microbiota to stay and thrive. So thereby, it's kind of a give and take kind of relationship. We'll discuss that further. But the microbiota and their theater of activity, as has been expressed like this, when we say theater of activity, we actually mean by this, we refer to the structural elements of the microbiota, plus the metabolites or the signal molecules they generate, and also the surrounding environmental conditions where they operate. All together, we call it microbiome. Microbiota plus theater of activities. But there is also another school of thought which tries to define microbiome as the genetic or the genomic determinants of all these different individual microorganisms or the commensal organisms. That refers to microbiome. So, but broadly, biome is reasonably well-defined habitat which has distinct biological, physical, and chemical properties. So with this, let's move to the next slide. When we say we human beings, we consider ourselves as the most advanced species, but then time has come to remind ourselves that an individual human being is not rather an individual by himself or herself. It is actually all multicellular organisms, including humans. They exist as meta-organisms. The term meta-organism means that they are comprised of both the macroscopic host, in this case the human being, and its symbiotic commensal microbiota. So that means a human individual is not just one person. The human individual is a composite of his self as well as a host of symbiotic commensals, huge number of commensals. I'm not going into the different kinds of ratio that has been propounded, that the number of cells in a human host vis-a-vis the number of microorganisms, etc. There are differences of opinion, but more or less they say that it is 1:100, 1:10, and now recent figures have come whereby it say 1.3:1, something like that. So we are not going into that detail right now. The microbiota plays a fundamental role in the induction, training, and function of the host immune system. So whatever immune systems we are privileged with, that is again we owe to the microbiota, because the microbiota constantly are actually regulating how our immune system would function, okay, or how as an individual, okay, I will be responding to a pathogenic microorganism or an antigen. The host immune system has largely evolved as a means to maintain a symbiotic relationship of the host with the diverse and evolving microbes. We need to remember, as we are born, we are actually the gut of a fetus, okay, is actually sterile. During the time of birth, okay, if it is a normal delivery, that is the time when the maternal organisms, they actually come in contact with the newborn, and the newborn gut gradually is actually receiving these organisms from the maternal body, okay, and that is the first time, and gradually that actually will determine the overall microbial or microbiota as the child grows. And when there is, instead of a normal vaginal delivery, if there is a cesarean section, the chances of the natural microorganisms that is to enter into the child's gastrointestinal tract will be different, will be less, and of course there will be some other kind of organisms might enter, but the chances of relatively less number of organisms entering into the gut will be there. But not necessarily it is only the gut, there are all other different body cavities, and even the skin, they also harbor microorganisms, or they will also constitute the microbiota for that matter. So the host immune system has largely evolved as a means to maintain a symbiotic relationship of the host with the diverse and evolving microbes, and the immune system microbiota alliance allows the induction of protective responses to pathogens and of regulatory pathways that are involved in maintenance of tolerance to innocuous antigens. Now, this is a cartoon that shows the microbiome, immune system, pathogens crosstalk, how they interact with each other. Now, the microbiome, they actually modulate the immune defense pathways, and thereby they will alter the host susceptibility to the infections. And this is constantly, they are in tandem with interacting with each other, and depending on which one, whether the microbiome or the pathogen supervene, accordingly it will be determined whether we would be in health or in disease. But it is not just leading to a pathogenic organism in our system. Infectious disease, but their microbiome in a much bigger way by interacting with the immune system will also affect us or affect our health, and thereby predisposing to or determining the fate of or determining the possibility of the pathogenesis of a diverse kind of non-infective diseases also, including different immunological disorders, autoimmune disease, allergic diseases, etc., including quite a good number of inflammatory diseases also. So inflammatory diseases, immunological disorders, including autoimmune disorders, they are also determined, or their pathogenesis is determined by the constant functioning of the microbiomes in our system. Now, this is how we try to understand the interdependence of our life events of the normal environment where we are existing and the major stress events of life. And when we come in terms with the normal environment, okay, which a major component of which is the microbiome, the constant interaction between the microbiome and the host, in this case the human host, that is called symbiosis. Whenever there is any alteration in the symbiosis, there are important life events that are occurring. So like our development since childhood process, the different stress and reproduction. So they will always try to also impact on the symbiosis, and thereby there will be the altered symbiosis will take place. But then if it is otherwise very badly affected and it is dysregulated, when we call it dysbiosis, which can happen because of major stress events, including exposure to antibiotics, including infections, the climate change, malnutrition, toxins exposure, noise pollution even. So all these will tend to cause dysbiosis, and this dysbiosis will again be manifested as different kinds of disorders. Now, diet has a very important role. Diet, immunity, and microbiota, they keep on talking with each other constantly. Particularly when we talk of diet, it is vitamin A, vitamin D, folate, iron. So diet rich in these components, including the AHR ligands. AHR is aryl hydrocarbon receptor, which is nothing but a transcription factor which regulates, among other things, immunity and the development of multiple CD4 T cell subsets. The AHR is also believed to serve as a potential molecular link between the vitamin D and immune homeostasis. So it is, in fact, we can say vitamin D is a ligand to AHR or aryl hydrocarbon receptor. So these diets, they have profound influence in the immune system. On the other hand, the immune system also can affect the dietary intake. Diet has influence on the composition and metabolic capacity of the common cells, and the common cells also influences nutrition absorption, nutrient absorption. The immune system is able to exert control over both common cell composition and localization of the common cells. On the other hand, the common cell signals are also critical for development and function of the immune system. So that's how the diet, immunity, and microbiota, they constantly have mutual interdependence. Now, the mucosal firewall has been described. Okay, gut mucosa, there is a basic barrier between the external antigens or external pathogenic organisms, including the common cells also. So to what extent the common cells will translocate within the system, that is also determined by the mucosal barrier. The mucus represents the primary barrier between the microbiota and host tissue, and thereby microbial translocation is prevented. Epithelial cells produce the antimicrobial peptides that also play a significant role in limiting exposure to the common cell microbiota. Translocating common cells are rapidly eliminated by tissue-resident macrophages. Okay, and common cell can also be captured by the CD103, CD11B, and the DCs. Okay, that traffic to the MLN from the lamina propria in this here. Okay, but they do not penetrate further. The common cell antigens then leads to the differentiation of common cell specific to regulatory cells, that is Treg regulatory cells, T helper 17 cells, and the IgA producing B cells. Common cell specific lymphocytes traffic to the lamina propria and Peyer's patches. In the Peyer's patches, the Treg cells can further promote class switching and IgA generation against common cells. The combination of the epithelial barrier, mucus layer, immunoglobulin A, and the dendritic cells and T cells, they all comprise the mucosal firewall. And this firewall will limit the passage and exposure of common cells to the gut-associated lymphoid tissue, preventing untoward activation and pathology. So under usual circumstances, there is only limited influence of the common cells, okay, with the internal immune system, but it will only in a very measured manner, and only when there is challenged with the external or the pathogenic microorganisms, then only there will be the common cells will appropriately respond to that. But otherwise, its translocation into the internal system is otherwise there is some degree of control there. The gut microbiota dysbiosis driven immune signaling pathways have been shown here, that dysbiosis in the gut microbiota that leads to the elevated circulating and tissue MAMP, that is microbiome associated molecular pattern, that is the lipopolysaccharides and peptidoglycans. So they will ultimately determine the insulin sensitivity and the inflammation. So they are linked. Okay, so it is through that dysbiosis in the gut microbiota that the immune signaling pathways will be driven. The immune regulation by the microbiota, how it differs or how it is regulated during homeostasis in the resting phase and during inflammation, that has been shown here. The common cells promote the induction of regulatory T cells via direct sensing of the microbial products or the metabolites of the T cells, as has been shown here, and the dendritic cells. Further, common cells promote the induction of T helper 17 cells that can regulate the function of the homeostasis of the epithelial cells. The common cell derived metabolites, that is the SCFAs, the short chain fatty acids, can have a systemic effects on the inflammatory cells. The short chain fatty acids then can inhibit the neutrophil activation, and upon entrance into the tissue, inflammatory monocytes can also respond to microbial derived ligands by producing mediators such as prostaglandin E2 that limit neutrophil activation and tissue damage. So that also shows that how the common cells and the microbiota, they can actually decide that inflammation, whenever there is this homeostasis is disturbed, okay, then only this inflammation will set in. So thereby, in order to ensure that and many of these inflammatory diseases today can be explained by disturbance in the microbiota homeostasis. So commensals today are considered as the critical inducer of host immune regulatory responses. The Treg cells, whether they are thymus derived or they are gastrointestinal tract induced, they take the center stage in this regulatory activity. They maintain the peripheral and mucosal homeostasis with optimal maintenance of tolerance to commensal and environmental antigens through the whole of the host lifespan. So it is basically the T regulatory cells which is important in regulating the immune responses in the host. The gut environment, although both of them are important, thymus derived and gastrointestinal tract derived induced, but then the gut environment is a particularly privileged site for the induction of the Treg cells in response to the oral antigens. This is because the defined population of antigen presenting cells such as CD103, CD11b, etc., and the mucosal dendritic cells that can produce factors involved in the induction of Treg cells, such as the cytokine, TGF beta, and vitamin A metabolite like retinoic acid. So that is possible only in case of the gut derived or gut induced Treg cells. Besides, the tissue specific factors such as vitamin A, MUC2, which is nothing but a mucus glycoprotein which is produced by the intestinal goblet cells, they contribute to the regulatory specialization of the mucosal dendritic cells. The SCFAs, their role in the immune homeostasis has been also elucidated. The bacterial fermentation of dietary fibers, they actually produce this short chain fatty acids. In particular, we can consider about butyrate, and they control various aspects of immune responses like regulating lymphocyte function, regulating the size and function of the Treg cell network, and promoting induction of Treg cells in the colonic environment. Butyrate particularly is known to regulate gene expression by inhibiting histone deacetylase, and this property is currently proposed as an underlying mechanism of enhanced Treg generation in the gut. The action of the short chain fatty acids likely results from the manipulation of various cells that are involved in the induction of regulatory responses, and indeed the effect of short chain fatty acids on both T cell and dendritic cells have been linked in this regulation process. The recent works have revealed a major role of the microbiota in shaping the rapporteur, the number and activation of the tissue resident Treg cells, and in the maintenance of host microbiome mutualism at barrier sites. And based on the abundance and complexity of the flora, microbial flora, we can speculate a high opportunity for cross-reactivity between the different commensals and even between the commensals and the pathogens and pathogenic antigens or environmental antigens. The microbial pressure in the gut that is possibly responsible to lead to the induction and maintenance of a pool of activated Treg cells that may not only contribute to maintenance of mutualistic relationship with the microbiota, but also to the systematic control of immune responses. Now, microbiota regulates both the two arms, innate and adaptive immunity. The commensals can promote and calibrate the innate as well as the adaptive immunity. They reinforce the defined components of barrier immunity. On one hand, as we have just discussed, this is an effect that has the dual function of promoting their own containment. Own containment means containment of the microbiota themselves, and also limiting pathogen invasion. Now, the microbiota can also act as adjuvants to the immune system as a whole. But their precise role is there in both training the immune system as well as its functional tuning or conditioning. Now, how do they do this conditioning? They can induce production of interleukin-1 beta, which is a cytokine that is involved in host defense. And this is required for responding to infectious challenge, both locally as well as systemically. So all these are actually, we are much wiser now to understand that it is the microbiota that is actually also defining the pathogenesis of a host of different disorders, not just the infectious disease, but also the different autoimmune and allergic disorders. Now, how microbiota promote protective immunity? The microbiota host symbiosis has multiple relationships, as we were discussing about mutualistic relationship, parasitic relationship, and commensal relationships. The capacity of a given microbe to trigger or promote a disease is highly contextual. It depends on several factors: the host factor, environmental factor, okay, and then whether or not it will trigger or promote disease is contextual. Most microbes can shift from even the relationship can also change, shifting from mutualistic to commensal to parasitic, according to the state of activation of the host, whether there is any co-infection or there is localization of the organisms in a given area. Commensals control the pathogens by distinct mode. There are different several mechanisms, like it can compete with the invading pathogens for nutrients and thereby not allowing the pathogen to have enough nutrients from the host, and thereby their growth and further replication can be prevented. It can promote establishment of an environment that is hostile for pathogen survival or replication, like as we know in case of in the vagina, the lactobacillus, how they can alter the vaginal pH, and whenever there is any, okay, the pH is disturbed, the acidic pH is gone, then it is found that there are local infections there, fungal infection or otherwise. It can also produce antimicrobial molecule or metabolites that can affect the survival and virulence of the pathogenic organisms. It can promote production of antimicrobial peptides by epithelial cells that can also reinforce the tight junction. It can also modulate the function of the dendritic cells and other innate cells locally and systemically in order to promote the induction of effector T and B cell responses against the pathogens. Now, when this is uncontrolled, this adjuvant property of the microbiota can even promote inflammatory disorders. Now, protective effects of commensals, that is well demonstrated in the clinical setting, like we know when we are using broad spectrum antibiotics, okay, at a high dose or for a long time, it results in domination of the intestinal microbiota with some opportunistic other organisms, like even the VRE, as dangerous as VRE. Fecal transplantation of microbiota from a healthy donor, which may be, if it is rich with commensal Barnesiella, which is a defined non-pathogenic microbe and is endowed with superior adjuvant capacity, it is shown to eradicate some of the recurrent infection with some efficiency. So this is also being tried and has also been tried with some success. Infections that is caused by multi-drug resistant organisms are a huge concern now all around the world, and this is developing into an epidemic and endemic situations. There is a point in harnessing the microbiota to combat these types of infections with multi-drug resistant pathogens, and this would represent an important therapeutic avenue, which is the most spectacular results that has been obtained so far is in the context of Clostridium difficile colitis. So we have otherwise have experienced that any germ-free conditions, whenever there is either unknowingly, whenever we are promoting any germ-free conditions, that would result in impaired host immune responses to pathogens. Like alteration in the composition and function of the microbiota as a result of unnecessary antibiotic use, overdoses of antibiotics, diet evolution, exhaustive and repetitive deworming even, they can transform host microbial alleles into potential liabilities. The adjuvant property of the microbiota is revealed in a model of oral vaccination, an observation that may help to explain some of the failures of oral vaccination in some developing countries where malnutrition is a problem. Malnutrition and infections have profoundly affected the microbiota. So there is vaccination failure. Now, commensals and pathogens, they may interact with the host immune system through conserved ligands also. By these conserved ligands, we mean actually some kind of flagellin, okay, bacterial or commensal flagellin that signal through toll-like and nod-like receptors. Bacterial flagellin promotes bacterial chemotaxis, adhesion, and bacterial invasion of host tissue. Dendritic cells in the lamina propria of the intestine responds to flagellin by expressing chemokines, antimicrobial peptides, as well as cytokines involved in the initiation of immune response. And commensal flagellin, on the other hand, interacts with toll-like receptor 5, particularly in the context of barrier breach, and thereby it plays an important role in promotion of mucosal immunity. Under homeostatic conditions, both the inflammatory and regulatory signals are constantly integrated, and the sum of these signals leading to the establishment of an immune tone compatible with tissue immunity. That's how the tissue immunity is offered. Now, when we talk of finally the systemic control of protective immunity by the microbiota, exposure to microbial ligands shape systemic immunity at both the steady state as well as in the context of inflammation. The commensal derived signals, they can influence gene expression profiles of immune cells via epigenetic modifications of genes involved in innate responses, and thereby creating a transcriptional state that enables basal expression of host defense factors and rapid responses upon encounter with a pathogens. So that's how the microbiota is influencing the how our system or our host immune system would be responding to a pathogenic microorganism. But then a lot of things are still unknown, and we need to know it further, how permanent the effects of microbial sensing, okay, are, and to what extent tissue and hematopoietic stem cells are permanently influenced by this tonic sensing remains to be explored. So there is some degree of tonic sensing by the microbiota, which is otherwise ultimately leading to the sensitization or stimulation of the innate and the adaptive immunity, but then it needs to be further explored. So to summarize then, the autoimmune and inflammatory diseases are now known to be associated with dysregulated immune responses. Understanding of tissue environments has been pivotal as a determinant of immune response, with the integration of microbiota as an intrinsic regulator of all immune responses. The evolving insights in the role of microbiota, keystone bacterial species, of course, we have not discussed this keystone bacterial species, this is another concept that has come up, commensal derived immune regulatory products, and of their link in human health and disease. All these provide a unique opportunity to develop an integrated exploration that includes involvement of ecologists, nutritionists, geneticists, microbiologists, biochemists, and immunologists. So it's a multidisciplinary research approach that is required, and that is poised at manipulating on or restoring the defined aspects of immune system microbiota dialogue in order to promote or restore the health of the human metaorganism. So it's a complex area, but highly evolving area, and hopefully in another decade or so, there will be a lot more. We will be much more wiser, and many of these otherwise difficult to treat conditions, whether it is rheumatoid arthritis, whether it is atopic asthma, whether it is atopic dermatitis, or even bronchial asthma. So all these, I think, will be better off to actually understand their pathogenesis and the interaction of the microbiota or the involvement of the microbiota in their pathogenesis, and accordingly newer therapeutic avenues are likely to also usher in, and the management of all these diseases might have newer vistas in the near future. So with this, thank you very much. I think this was the last slide. Thank you again. Over.
Thank you, sir. Thank you very much. So as we are running short of time, we will not take any more question, and we will directly move to the scientific paper presentation session. So may I request Dr. Debojyoti Shah to moderate this.
Thank you. Thank you, sir, for your presentation. And it has been our pleasure to hear from you once again. So we will be having a free paper presentation now, and we have our panel of judges. Now I invite the panel of judges, which include Dr. Moitro sir, Dr. Das, and Dr. Shamasdar. And to chair this session, may I invite Dr. Sigdar. Over to Dr. Sigdar.
Good evening. I am Dr. Anand Shikdar. I am here to chair the scientific program paper presentation competitive, which is actually here. I have an announcement that there is a changes in the timing of the presentation. There will be 4 minutes of presentation time and 1 minute of question answer time for each. Okay, and now today's presenters are, I'm just running through the names who are going to present today. First is Dr. Anamika Bhadro, and second is Dr. Shrayan Ghosh, third Dr. Snigdha Mishra, fourth Dr. Shubhoshmita Pradhan, fifth is Dr. Aisha Naik, sixth Dr. Ranit Bagh, seventh is Dr. Debaroti Bera, eighth is Dr. Rika Debnathan, and ninth and Orgho Laha, Dr. Orgho Laha. So I like to start the session as we are also running short of our time. So from our judges, can we start the session?
Yes, I think so.
Yes, we can.
Okay. Yes, sir. So I'm inviting Dr. Anamika Bhadro to start the presentation, please.
I think everyone become now got the faculty link. They can, I think they can share their screen. If you have any problem in sharing, you can tell.
Hello?
Yeah. So
Sir,
Dr.
is my slide
Sharayan
visible?
Ghosh, you are not visible. So Dr. Sharayan Ghosh, you cannot, he is not getting the link. So I think the Allercon technical team, please send him the link. Otherwise, we can start. Huh?
Okay. Yeah, we can start. Dr. Anamika Bhadro.
Yes, sir, I have started sharing the slides. Is this visible?
No.
No.
Sir, now is this visible?
Yeah.
Okay. Should I start, sir?
Yes, please.
And please make yourself visible also.
Okay.
You may start.
Okay. Good afternoon, my respected teachers. Myself, Dr. Anamika Bhadro, a postgraduate trainee of Medical College and Hospital. I'll be presenting a case under the name of Don't Rush for a Rash. My patient, a 13 years old girl without any known pre-existing comorbidity, presented with the chief complaints of low-grade intermittent fever since last 4 days, followed by development of purpuric spots over both the lower limbs since last 2 days before admission.
Sorry to interrupt you. Sorry to interrupt you. You have to make it a full screen. Your slides are not. You have to make
done it, sir. Slide share, I have done this.
No. We cannot. Just you. We are seeing. Yeah, now it is changing. Make it a full screen mode.
Sir, the slide share on my laptop is here.
Yeah, your slide is on the laptop, but the whole screen is sharing. Means, but it's not that. You have to make a full screen of your slide. Make it a slideshow.
Sir, slideshow.
Okay, well, let's not interrupt her.
Yeah.
Carry on.
So you have to again share your screen.
Yes, sir. I'm doing that. So is this visible now?
Yeah, visible, but there is no. Your screen is visible, but the slide is not.
Sir,
You have to unshare and again reshare. Okay, you minimize the PowerPoint. Okay. You have to minimize, open the PowerPoint and minimize it. Again, you have to stop sharing. Then you have to restart.
Reshare.
Yeah.
Okay, sir. Sir, now is this visible? I have started resharing.
Your PPT is not visible.
So I'm facing a problem then. It's visible on my, your screen
Okay,
is sharing.
first stop sharing, then open the PPT first, then start sharing again, and then make it a full screen. Start the slideshow.
Sir, now?
Yes. Yes. Now the PPT should start the slideshow. Okay, you carry on. Okay, you carry on.
Sir, is this now visible? I have done that. Slide share.
Yeah, your whole slides are showing. So this is the first slide you are showing right now.
Yes,
you
yes,
carry
yes.
on. Yeah, you carry on, but it's not in the slideshow format. It's only on the PPT format only. You carry on. You start.
Okay.
You start.
Okay, sorry, sir. A 13-year-old girl presented without any known pre-existing comorbidity, presented with the chief complaints of low-grade intermittent fever since last 4 days, followed by development of purpuric spots over both the lower limbs since last 2 days before admission. At the presentation, She refused any history of any respiratory, urinary, abdominal, and musculoskeletal symptoms, any bleeding manifestations, and she also refused any regular drug intake. After hospitalization, during the course of hospitalization, she developed productive cough a week later. On clinical examination, while I was examining, the patient was hemodynamically stable, other than mild pallor, low-grade fever, tachypnea, and tachycardia. While examining the rash was palpable, it was painless, non-pruritic, and non-blanchic, purpuric spots over both the lower limbs. On respiratory system examination, coarse crepitations was found over the left infraaxillary and left infrascapular regions. On the routine blood examinations, microcytic hyperchromic anemia was present with the hemoglobin of 1.7 gram per deciliter. Globulin was raised compared to albumin. In and otherwise, LFT was normal. Thinking of it is a case of small vessel vasculitis, autoimmune markers and viral serology were sent. All turned out to be negative, including the ANCA profile and also the dengue serology and COVID RT-PCR in the era of the COVID. Now the skin biopsy was sent, which was consistent with small vessel vasculitis as shown in the picture. And as the patient developed productive cough during the hospitalization, sputum was expectorated and sputum was sent, which showed acid-fast bacilli. And on CBNet, no rifampicin resistance was detected. So we diagnosed this is a case of pulmonary tuberculosis, but whether the purpuric spots were due to tuberculosis or not, it was uncertain at that time. She was started on standard anti-tubercular regimen for 6 months, and after starting ATD, the fever subsided within 10 days and the purpuric spots completely disappeared within next 14 days, which did not recur further. And on subsequent follow-up visits in outdoor patient, the hemoglobin level of the patients also improved, and patient did not suffer from any adverse effects due to anti-tubercular drugs. So we
1 minute left.
So the final diagnosis was the pulmonary tuberculosis presented as cutaneous leukocytoclastic angiitis. Although tuberculosis is very common in India, but presenting a small vessel vasculitis was very rare. So apart from common infective organisms, tuberculosis has to be kept in mind. So as our teachers say, an atypical presentation of a common disease is more likely than a typical presentation of uncommon disease. We went through some literature and this showed these case reports regarding pulmonary tuberculosis presented as small vessel vasculitis. Thank you, sir.
Yes, very interesting.
Okay.
Dr. Bhadru. Okay, yeah, I hope you got this case report published. Yeah. And the only
Sir, any questions?
Yes, I will ask you one question. That what are the other infective causes of small vessel vasculitis or the leukocytoclastic vasculitis in a tropical country like India?
Sir, like there are many infective organisms causing like hepatitis B, hepatitis C, HIV, Staphylococcus aureus, Streptococcus, and parainfluenza A. Usually we get this.
Thank you.
Most commonly the viral etiologies.
Yes, okay. Thank you.
Any other questions? Any other questions?
If there is no other question, then we'll move forward.
Yes, yeah. And in time is over. So next presenter is Dr. Shreyan Ghosh. Dr. Shreyan Ghosh. Dr. Shreyan Ghosh is here. I think he is not here.
He's not here.
Please go to the next one then.
The next candidate.
Next. Third is Dr. Snigdha Mishra. Dr. Snigdha Mishra.
Hello? Hello? Am I audible?
Yeah.
Yeah. Please share your screen.
Yes, sir.
Dr. Snigdha, are you
Yes,
ready?
I'm trying to share, sir.
Okay.
Is it visible now?
Yeah, make it on the slideshow. And one thing, when you are changing the slides, you just select the slides because it's only showing the first slide only here.
Now
the
you,
slides are not.
you can make it full screen. It will be changed. You make it full screen. You are doing the right thing. Make it full screen.
Okay, sir. I have done this. I have done. Is it visible?
No.
Full screen?
It's not visible full screen. I
Not
don't know.
visible. Yeah, you
Sir,
make the
actually with Zoom-
slideshow.
You make it in the slideshow mode.
You make it in the slideshow. This is
Okay.
Bottom you see there is a small icon of slideshow. Just press on that. Yeah.
This is on the top top corner. There is
Right. That is the right one. Just press on that.
Can I start, sir? No?
Just that.
Can I start, sir?
You're on the right.
Select
icon.
that.
Select that.
Is it visible on full screen, sir?
It's not changing. Anyway, you then go ahead.
To go ahead and change the slides.
Okay, go
Okay,
ahead. Yes.
start. This time.
Good afternoon, teachers, sirs. I am Dr. Sanjay Mishra here from PG Department of Pharmacology, SCVNCS Cutter. Today my topic of presentation is stress of offending agents and response to treatment, a study in a tertiary care hospital. Stress means drug reaction with eosinophilia and systemic symptoms. Characterized by fever, cutaneous eruption, internal organ involvement, mainly liver, and hematologic abnormalities 1 to 8 weeks after the administration of the culprit drug. Mortality rate is about 10%. Incidence is from 1 in 10,000 to 1 in 1,000. Withdrawal of the offending agent along with the supportive care and topical or systemic corticosteroids during the modalities of treatment. In this study, to identify and compare different clinical presentation in relation to specific drugs and to know the response to treatment is our objectives. It is a prospective observational study done in Department of...
Sorry to interrupt. Sorry to interrupt you because the slides are not changing. You please come out of your full that is slideshow. Now it is okay. You have to click on that particular slide so that we can see. At least you do that. Okay.
Okay, sir. It is a prospective observational study done in the Department of Pharmacology and in collaboration with the Department of Dermatology in SCVMCS Cuttack from January 2021 to July 2021. All serious drug reaction patients of either sex admitted to the Department of Dermatology IPD are included in this study, and critical ill patients, pregnant women, patients who refused to consent and who were earlier taken the treatment with steroid are excluded from the study. Patients are admitted in the dermatology IPD with serious drug reactions. Their consents are taken and carefully examined for probable or definite rash according to the register criteria: type of rash, mucosal lesion, presence of edema, lymphadenopathy, complete blood count, LFT, RFT, absolute eosinophil count are studied. Then these tests are repeated after 3 days, and response to withdrawal of the culprit drug and the treatment were monitored. This slide shows the result of my study. The first diagram is the bar diagram. X-axis shows the drugs, Y-axis shows the latent period in days. We see that the latent period for nimesulide is minimum, that is 7 days, and for etoricoxib it is maximum, that is 60 days. The second table shows that the clinical features observed in race. Here in first column, left side is the drug and right side the number of patients we take. Number of patients are written. Means the total number of patients are 31, and phenytoin is the culprit drug for 8 number of patients. Here fever, rash are present all 100%, all the patients, and lymphadenopathy is present in 75% of patients. 75% of patients with phenytoin, and abnormal LFT is seen in 100% of patients with phenytoin, and other organ involvement such as kidney is present in the only 12% of patients in the with phenytoin. this pie chart, we see that time taken by RAS to subside. 22 number of patients, that is 71, almost 71% patients, the RAS subsides within 5 days. 8 number of patients that are subside within 7 days, and one patient whose RAS did not subside after 7 days. Now, coming to the discussion.
1 minute left.
Our study involved 31 diagnosed patients with mean age of 33.3 years, having male predominance, and as noted in the study called LGCC et al. And the latent period between the drug intake and the onset of symptoms was almost similar to that of previously reported by Kumari et al. Different types of rashes are noted, but maculopapular are the commonest type as reported by the NCC et al. To conclude, trace may have fever with or without rash and systemic involvement in any patient who has started taking drugs known to produce any adverse reaction during past 6 months. The absence of constitutional symptoms such as rash or eosinophilia by themselves does not rule out rash. Withdrawal of offending agent, offending drug, and administration of the prednisolone achieve cure in more than 95% of cases. Thank you.
Okay.
Okay, thank you.
We are open for question and answer.
Dr. Mishra, first of all, tell me that what is your primary objective in this study?
So primary objective is to know the symptoms with respect to the drug.
Okay. Okay. So, then what kind of study design it was?
It was a prospective observational study design, hospital based.
What do you mean by prospective?
Prospective means, sir,
your study period was from December to July, no? That was a study period. But what do you mean?
yes, sir, 6 months. 6 months. January 2021 to July 2021.
What do you mean by prospective?
From cause to effect.
Prospective, what do you mean by prospective? That's what I'm asking.
So prospective means from cause to effect. Means it goes forward. Study goes forward.
Did you, when your patient came to you, then you gave the patient the drug and then you followed them up over a period of 6 months and saw the effect?
Yes, sir. Yes, sir.
I don't think it was like that. The patient came to you with the symptom. That means the
Yes,
patient came to you with the effect.
Sir,
And then you took the history and you unearthed the what was the offending drug, right?
Yes, sir. Yes, sir.
So in that case, does it become a prospective study?
Yes, sir. We have administered the treatment. We have followed up after 3 days, 7 days, 14 days.
This was not an interventional study. It is an observational study, right?
Yes, sir. Yes, sir. Observational study.
Observational study, the patient came to you with a history of severe drug reaction.
Yes, sir.
Dress. So you
Yes,
took all the cases of the dress and you just evaluated that which was the culprit drug
Yes,
and
sir.
how was the patient's response.
Yes, sir.
So have you moved from the cause to effect?
No, sir.
So it is not a prospective study, it's a cross-sectional study.
Yes, sir.
You didn't have a cohort, so you call it a cross-sectional study. Okay.
Yes, sir. Okay, sir.
Would you please show the slide where the plan of study is written? Can you focus on that slide? Yeah.
So the patient's admitted in dermatology IPD with serious drug reaction. That is your starting point. Okay. Your starting point is not healthy individual, right? So these are your candidates which were included in your study after their consent. And then they were evaluated. So either you could say that it was a cross-sectional study, or you could say it was a case series report. Okay. Anyway, otherwise it was good.
Anyway, the thing is that if you are seeing the outcome of those patients, the treatment outcome of those patients, then because in your result it was not reflected, you may observe it prospectively, the outcome of the therapy that was given in your dermatology IPD, then that can be a prospective observational study. So you have to explain little better way. Okay, no problem. And in the methodology proportion, you had mentioned in the exclusion criteria, please focus on that, that you exclude the critically ill patient.
Yes.
So what is the reason of exclude the critically ill patient? Because a good number of critically ill patients, or we can say that among DRESS patients, a good number are critically ill. So excluding them, whether that is a we can say some limitation in your study or not. So why you exclude those patients?
So actually, race.
Okay, no problem.
Okay.
I think next.
Yeah.
Next participant we can go on. Dr. Shrayan Ghosh is there. He has joined. And so I am requesting Dr. Shrayan Ghosh to present his presentation.
Hello, good evening. Am I audible to everyone?
Yeah, audible. Please share your screen.
You have to share your screen.
1 second. Is it visible?
Yeah, it's visible.
Bol.
Please go to the first slide.
Yes. Sir?
Yeah, you start.
Yeah, you start.
I'm today presenting a prospective observation study, like a study of allergic reactions following COVID-19 vaccination in patients with past history of allergy. I'm Dr. Shrayan Ghosh, second year PGT Medical College, Kolkata. Like introduction, vaccines are the mainstay for fighting against COVID-19. It reduces the chance of severe infection, hospitalization, prevents death. So allergy is a contraindication for vaccination. In this study, patients have previous allergy history was evaluated after taking at least a dose of COVID vaccine. Inclusion and exclusion criteria has been mentioned. They were observed 30 minutes post-vaccination for adverse reaction. They were also asked to report any adverse reaction over telephone. I have taken information in 3 parts. First after 30 minutes, then after 3 days for any type 4 hypersensitivity, and last after 7 days for any regular checkup. The results, all the adverse effects that has been seen, the median age is where the allergic reactions can be seen is 34. Vaccine types are like Covishield and Covaxin. In Covishield, the effect has been more predominant with respect to Covaxin. There are no serious adverse effects. There are mild allergic reactions that has been seen in the patients of 2. There are mild reaction in respect to vaccine dose, one after the first dose, one after the second dose. Conclusion, practically, no patients have history of food or drug allergy, developed any adverse effects reaction after vaccination. So people having food or drug allergies should be encouraged to take COVID vaccines. Thank you.
Thank you, Dr.
Okay.
Okay. Again, the first thing, what is the primary objective in your study? Always when you're embarking on a study, you should have a primary objective, and if there is a secondary objective, which is optional. The primary objective decides your study design. What is the primary objective in your study? What was the primary objective?
Sir, my primary objective is to see that any adverse reaction related to allergy is occurring after COVID vaccination.
So you wanted to see, that means, what you wanted to do? Observe, right?
observations.
Observation study. So you wanted to determine any allergic adverse reaction following vaccination in patients having history of allergic diseases, right?
Yes, sir.
So this would have been your primary objective.
Yes, sir. This
Very
one.
good objective, is a very good study, I must say. Okay.
Thank you, sir.
The questions everybody asks. Okay. So do you have to very clear in what you are saying, okay, what you want to do, and then you actually saw these patients or the who were vaccinated, and then you tell me one thing. The next question is, how long did you observe these patients?
Sir, I have observed in 3 parts. First is I was a nodal officer of COVID vaccination center in medical college since last year. I have seen the patients who are vaccinated. After 30 minutes of vaccination. It's the first part. Second part is after 72 hours. I used to call the patients and get the information any adverse reaction has happened or not, and after 7 days for follow-up or any checkup.
So all these patients you took classes. Very good. Thank you.
Thank you, sir.
Okay.
Thank you. I
Any
don't have any
questions?
questions. Yeah.
Okay. Ma'am, do you have any questions? Okay. So we are moving on to the fourth contestant is Dr. Shubhashmita Pradhan.
Just 1 minute, I want to say, those who are presenting, please keep your camera open.
Okay. Okay, you are Dr. Shreyan Ghosh.
Yes, sir.
Okay, fine. So I am requesting Dr. Shubhashmita Pradhan to join and present her case.
Yes, sir. Yes, sir. Am I
Okay,
audible?
please share. Yeah, audible.
Sir, is it visible?
Visible.
Yeah.
Very good afternoon to all the esteemed judges and audience present. I am Dr. Subhrashmita Pradhan, second year PG student, Department of Pharmacology, Vimsar, Bulla. This is the topic of my presentation, a comparative analysis on efficacy of levocetirizine, prednisolone and their combination in the treatment of chronic urticaria. Coming to the introduction part, chronic urticaria, it is defined by recurrent episodes occurring at least twice a week for 6 weeks, possibly lasting for many months or many years. These lesions are a consequence of various stimuli like foods, drugs, allergens, immunological factors, infections, etc., which act on the mast cells, resulting in release of inflammatory mediators. Histamines, which get derived from the mast cells, they are the major mediator of urticaria. Hence, mainly we use antihistamines as the drug of choice in the therapy for most cases of urticaria, but in some refractory cases, it seems to be ineffective. So other treatment modalities include use of corticosteroids alone or in combination with antihistamines. So my aim and objective of this study is to compare the therapeutic effectiveness of levocetirizine, prednisolone and their combination in the treatment of chronic urticaria. The place of study, Department of Pharmacology in association with Department of Dermatology, Vimsar, Bulla. Study period is from Jan 2021 to April 2021. It is an observational prospective study. The study population are the patients attending dermatology OPD and diagnosed with chronic urticaria. We have taken 100 cases. Each patient was selected randomly and they were grouped into 3 groups. First group contained 34 patients and second and third group contains 33 patients each. They received, group 1 received tab levocetirizine alone 5 mg daily for 15 days. Group 2 received tab prednisolone alone 20 mg per day for initial 3 days, and later dose was gradually tapered by 5 mg every 3 days to 5 mg per day. The duration of treatment here is 12 days. And in group 3, they received a combination of levocetirizine and prednisolone. The dose and dosage schedule was same as in group 1 and 2. We have done the follow-up after 2 weeks of the treatment, and improvement in signs and symptoms of urticaria was graded as grade 1, there is complete relief from itching and skin lesions. Group 2, grade 2, skin lesions disappeared completely and itching decreased slightly. And in grade 3, no improvement of both itching or skin lesions. Blood investigations like total leukocyte count, differential count, absolute eosinophil count were done. Coming to the results part, first table is about the improvement grading in all the groups. We have seen that after analysis, we have seen that improvement in group 3, that is 85%, that is maximum. Then in group 1, that is 79%. Then in group 2, that is 54%.
1 minute left.
Then in table 2, we have compared the total leukocyte count, differential count of neutrophil lymphocytes before and after treatment, and we have seen there is slight alteration in their counts after treatment.
Dr. Pradhan? Dr. Pradhan?
Yeah, we could not hear you, Dr. Pradhan.
Dr. Pradhan? You're not audible.
Did she get disconnected?
Okay. So, should we wait?
We can go on to the next participant and come back to
next. Yeah. So next presenter is Dr. Aisha Naik.
Sir, am I audible? Hello.
Yeah, tell me your name.
Sir, I am Dr. Aisha Naik. Am I audible?
Yes, you're audible.
Yeah.
Yes,
audible.
Sir, sharing the screen.
No, actually, Dr. Pradhan is still on the sharing screen.
Has to.
I don't.
He has to unshare.
Means, is there some issues over there?
I think our technical team can help. Our technical team, I'm requesting technical team to unshare the screen from the existing screen. Then the other student can share his screen. Technical team, Kaushik, are you there? Yes. Okay, now you can share your screen.
Sir, is it visible?
Yeah, visible.
Sir, is it visible?
Yes.
Hello everyone. I am Dr. Aisha Naik, postgraduate PG resident, Department of Pharmacology, Vimsar Bulla. Today's topic of my presentation is effect of enoxaparin on D-dimer level in hospitalized COVID-19 patients and observational study. COVID-19 is associated with several coagulation abnormalities like venous thromboembolism, pulmonary embolism, stroke, myocardial infarction. D-dimer, which is a fibrin degradation product, is increased in COVID-19 patients, which indicate poor prognosis and high mortality. Individuals with comorbidities like diabetes mellitus, hypertension tend to have high D-dimer and increased mortality. A low molecular weight heparin, that is enoxaparin, have shown beneficial results in prevention and treatment, reducing the risk of mortality. So with this background, my aim is to evaluate the changes in a D-dimer before and after subcutaneous enoxaparin therapy in patients with COVID-19.
Dr. Aisha, please open your camera.
Sir, yes, sir, opening, sir. Sir, am I visible?
Yeah.
Yes, sir.
Please continue.
Sir. So this study is conducted in COVID hospital, Bhimsar Bulla. This is an observational retrospective study conducted for period from May to September 2021. After taking permission from Institutional Ethical Committee, VIMSAR, 86 patients were enrolled and statistical analysis were done using SPSS software version 21 and group comparisons done using Wilcoxon signed rank test. COVID-19 patient with D-dimer level more than 0.5 milligram per liter were included in our study, and the patient whose age is less than 18 years and more than 80 years and the patient with bleeding disorder, thrombocytopenia, severe anemia, coagulation abnormality, previous HIT, and an antiplatelet therapy were excluded from our study. Coming to the result part, table 1 showing the effect on D-dimer level before and after enoxaparin usage among general COVID-19 patients, where we can see that there is significant reduction in D-dimer level after subcutaneous enoxaparin, that is from 6.88 plus minus 7.12 to 3.74 plus minus 5.03 and p-value less than 0.001. There is a bar diagram showing the effect on D-dimer level before and after enoxaparin usage in COVID-19 patient having diabetes, where we can see that in non-diabetics there is significant reduction in D-dimer level after subcutaneous enoxaparin, but in patients with diabetes there is reduction in D-dimer level, but it is not significant. Likewise, there is another bar diagram showing the effect on D-dimer level before and after enoxaparin usage in COVID-19 patients having hypertension, in which we can see that in non-hypertensive there is significant reduction in D-dimer level after enoxaparin, but in patients having hypertension, though there is reduction
1
in
minute left.
D-dimer level, it is not significant. We saw without comorbid condition, D-dimer value reduced after enoxaparin. Group difference found to be highly significant. This study correlates with another study done by Jekothatchil, where enoxaparin reduced the D-dimer level and mortality. I want to conclude treatment with enoxaparin was associated with decreased D-dimer level in hospitalized COVID-19 patients, as the usefulness of enoxaparin in improving clinical outcomes seem consistent and it is used routinely in many COVID hospitals. There is urgent need of multi-centric trial to evaluate its efficacy in COVID-19 patients. These are my references. Thank you.
Okay. Thank you.
Open for question.
Yeah, thank you, Dr. Nayak.
Thank you, sir.
Nayak, tell me, what do you mean by observational retrospective study?
Sir, we observe the case records of a patient, which is from effect to cause.
Why do you call it retrospective?
Because we observed
Call it an observational study only, and the study period may be in the past. Okay, and it is from a date. It is from the data abstraction form. This is from the medical records. Okay.
Yes, sir.
Always this term prospective, retrospective, ambispective, whatever you use, this is always used for the studies which goes from the effect to cause. Okay, or the cause, that is from intervention that you are doing, or maybe some that is there is some there is some cause, there is to effect. Okay, so that is how you go. Okay, and if you are taking the data from the cause to the effect, then you call it a prospective, and if you're taking it it's like that. Ambispective is both the ways, and the retrospective is in the past. Always when you're taking a data for a certain period of time, that period of time maybe in the future, maybe in the past, maybe in the present, that does not matter. Okay. But this is actually cross-sectional study, number one. Number two question is that did all the COVID-19 patients who were included in your study, the severity of disease in all of them? Was there a variation in severity of the disease?
So they belong to moderate or severe, sir, hospitalized patient category.
Okay, so the moderate to severe hospitalized patients, do you think that there would have been a difference in the D-dimer level between the moderate and the severe COVID-19 patients in the D-dimer levels?
Yes, sir. Maybe in severe it will be more, sir. So we will be giving BD dose of enoxaparin.
No, see, the thing is that whether you're giving a prophylactic dose of the heparin or a therapeutic dose of the heparin depends upon the disease state. Okay.
Sir.
So if you are giving a therapeutic, did you give the same dose to all the patients?
No, sir.
So
Sir, depending upon the body weight, below 70 kg, sir,
I'm asking, did you give the prophylactic dose to all the patients, or to some patients you give the prophylactic dose and some patients you give the therapeutic dose? What did you did in that?
sir, we have given prophylactic doses to everyone, sir.
So you give prophylactic enoxaparin giving to all the patients,
Sir.
and some patients being in the severe your COVID, then
Sir.
why didn't you give the therapeutic dose in those patients?
Sir.
Don't you think that these are some of the parameters so which would have affected your result?
Sir.
Is
Yes,
number
sir.
one. Number two, number three is that that your data, was the data normally distributed?
Sir, it was not normally distributed.
Okay, so it was a non-parametric.
Non-parametric test, sir.
Exactly. So when we are dealing with a non-parametric data, okay, and that too from the hospital records, your only the single data is the D-dimer level, right? The
Sir.
before giving the enoxaparin and after giving the enoxaparin. So that means a paired non-normal data, right?
Then they are non-normal data, sir.
Paired non-normal data, when you are comparing, what are the test of significance you can use apart from what you have used?
Sir, I could not understand, sir.
If you are comparing the mean of
Sir.
two data sets which
Sir.
are paired and
Sir.
not normal, what other test of significance to determine difference in the mean you could have used apart from the test that
Sir, we have used Wilcoxon sign rank test, sir.
you have told me? Tell me the name of another test
Sir,
which is more common.
Sir, Fisher,
No, not at all.
Man Whitney. Don't know, sir.
Okay, thank you.
Okay, sir. Thank you, sir.
Okay, any other questions?
One question regarding the risk benefit analysis of low molecular weight heparin therapy. So is your hospital using some specific risk score?
Sir, it is following the guideline of ICMR and NIH guideline.
Okay, so do you want to see some risk of thrombosis in those patients while giving low molecular weight heparin?
Sir, what, sir? Could not understand.
Any
sir.
risk score?
Yes, sir. ICH DTH score. It based on the investigational findings of D-dimer, prothrombin time, and platelet count.
Do you know what is Padua score? PADUA? Padua
Sir,
score?
Padua score is used for mild cases of COVID.
No.
To give the
No, you have to read. You have to read one paper on low molecular weight heparin.
Sir.
That is published in JAPI very recently.
Okay, sir. Sir, okay.
Risk benefit analysis in reference to use of low molecular weight heparin in COVID-19.
Okay,
you may write low molecular weight heparin, COVID-19, and JAPI, JAPI, Journal of Association of Physicians India. So you will find that paper. This is a good paper to read.
Okay, sir. I will read. Thank you, sir.
Thank you.
Okay, sir.
Okay, so we're going to the next participant, Dr. Ranit Bagh.
Yes, sir. Am I audible?
Yeah, audible. Please start sharing your screen.
Okay.
Dr. Shubhasmita Pradhan, whether he's
not online. She's not.
She's there. Shubhasmita
No,
Pradhan.
no.
Okay, then we'll move to Dr. Ranit Bagh.
So may I share the screen?
Yeah, share your screen, please.
So good afternoon to my senior professors and the faculties. Today I am Dr. Ronit Bag, the second year PGT of Calcutta National Medical College and Hospital. Today I am going to discuss the topic about pharmacovigilance of cutaneous adverse drug reaction, focused research in times of COVID pandemic. The background, the drug allergy is an abnormal reaction of immune system to a medication and is a special kind of adverse drug reaction. So cutaneous adverse reaction following the drug therapy of COVID-19 are common. All we know the drugs commonly used in the COVID-19 are antimicrobials, antiparasites, and antivirals, which potentiate the risks of development of the drug allergy in the form of cutaneous adverse reaction. So materials and methods. It is a cross-sectional study. The duration of study is 6 months. The sample size is a convenient sample size of 30 was considered, but there is also only 6 cases I given due to some limitations. And the study inclusions, all the patients with the cutaneous adverse reaction are PCR positive, who came in the COVID ward in CNMC. And the exclusion criteria are the patients who are not willing to participate or having the severe mental illness. So the primary objective of my study is to observe the number of cases of cutaneous adverse reaction out of treatment of COVID pneumonia. So at first I will show the clinical epidemiological table of the patients. The first case is a 42-year-old male who presented with the maculopapular rash in the trunk and the back after 4 days after administration of the cortimoxazole drug, which given due to the COVID-19. This is the first case, and next also I scored according to the Naranja score, it is 5, and the WHO UMC score, it is probable. Next, the 11-year-old female patient who presented with acute generalized exanthematous pustulosis after 5 days after administration of the azithromycin drug, and the date of recovery is 12 days after withdrawal. The Naranja scoring is 4, and WHO UMC score is possible. This is the second picture. And next, the 82-year-old male patient who presented with maculopapular rash after administration of the remdesivir, which is commonly given in, which is given in the COVID-19 guideline, and the date of onset is 6 days after the intake, and the date of recovery is 13 days after the withdrawal. The Naranja score is 6, and WHO UMC score is probable. Next, the 40-year-old male who is also presented with maculopapular rash after administration of the hydroxychloroquine, and date of recovery is 7 days after withdrawal. The Naranja score is 6.
1 minute left.
And WHO score is probable. Next, 15-year-old male patient who presented with fixed dose eruption after administration of doxycycline. Naranja score is 7, and WHO score is probable. Next, the 50-year-old male who is presented with maculopapular rash after administration of azithromycin, and date of recovery is 13 days after withdrawal, and Naranja score is 5, and WHO score is probable. There are 6 cases also, and 4 cases is maculopapular rash, and 1 case is FT, and another case is acute generalized exanthematous pustulosis. All the cases are reported under the pharmacovigilance programs of India. So the diagnosis of drug allergy is based mainly on clinical examination and the history taking, as confirmatory laboratories are very limited. So the role of the pharmacovigilance
Time's up.
is restricted to reporting.
Time's up.
Okay.
Okay, doctor. Thank you. Dr. Bag. So again, the same thing. All of you are presenting, but you are not saying the primary objective, though you said it, but you haven't written it on your slides. Tell me your studies or what kind of study?
So this is a cross-sectional study.
Huh? What?
This is a cross-sectional study.
No, cross-sectional study is fine, but this is a what type? In a major category, what is it? A descriptive study or an analytical study?
It's an observational study.
Observational study, then what type? Descriptive, right?
A prospective observational study.
Is it a descriptive study? What are the various types of observational studies you have?
We have a cohort study, case control, and cross-sectional study.
See, always remember one thing, cohort and the case control are the analytical studies. Okay.
Okay.
And in the observational study, you can have the analytical studies and you can have the descriptive studies. Okay. In analytical studies, you have the cohort and case control. Descriptive study, you can have case series, case report, or a descriptive cross-sectional study. So what you did was a descriptive cross-sectional study, right?
Yes.
All the patients who had a cutaneous adverse drug reactions following the drug therapy of the COVID-19, you just actually tabulated them, saw what are the drugs, how severe was the reaction. So this was what you did, is a descriptive cross-sectional study.
Okay.
How did you say a sample size of 30 was considered? Why was a sample size of 30 was considered? Were you sure that you will be getting 30 adverse drug reactions in the COVID-19 treatment? And what was the need of this sample size? How did you came to how was the sample size calculation was done? That is my main question.
Within the period of 6 months, in our pharmacology OPD, the patients were also reported with the adverse drug reaction, but not all the patients gave the informed consent. So I just only take the 6 or 7 6 cases for.
No, I'm not asking that. I'm asking how did you reach to this magical number of 30 in your case? The 30 that you have said, that sample size of 30 was considered. How did you get this 30?
I also take the information from the from our pharmacovigilance monitoring centers in our college, in our hospital.
What information did you take?
Why the 30 is taken?
What information did you take from there?
Exact number is not 30, but it is about 30.
No, what information did you take from there, from your pharmacovigilance record? So that's what I'm asking.
The question is how you should calculate the sample size.
And another thing that in a descriptive cross-sectional study, do you really need to calculate a sample size? You are not needed to calculate sample size.
No, sir.
You are not needed.
No, sir.
If you are not doing an analytical study, you are not needed. If you are doing an interventional study, if you are doing an analytical study, then you are needed to calculate sample size. But if you are doing a descriptive study, you are not needed to calculate sample size. Even if you have calculated a sample size, you will actually take a sample size of 30. Then how did you came to this number 30? So that was my question, second question. It was not needed in your case. Sample size calculation, how it is being done. When you have committed 30, there must be some basis. You say from a pharmacovigilance record, you have taken 30. That's absolutely right. But what have you taken? What have you seen in a pharmacovigilance record that made you to commit a number 30 or around 30, whatever it is?
So from the studies, I also got the prevalence of the cutaneous adverse reaction of the COVID-19. So according to that,
prevalence of the cutaneous adverse drug reactions in the patients undergoing COVID-19 therapy. Exactly. So that means you took the proportion.
Yes, sir.
Okay.
Yes.
This is the proportion formula you apply to achieve or to arrive to a sample size. But this was not needed in your case since it was a descriptive cross-sectional study. Okay, thank you.
Okay, thank you.
Okay.
Can
we
you
are running out of
just one the next slide, you to just go through the next slide. Next slide. Okay, so among these all hypersensitivity reaction or drug allergy you are mentioning, can you please let me know that what type of hypersensitivity reactions are those?
These are mainly type 4 hypersensitivity reactions.
All type 4?
So mainly acute generalized extensivous pustulosis. It is delayed type of, so it can be the type 4D hypersensitivity reaction.
Okay.
Only AGEP is type 4.
Okay.
Maculopapular rash could be type 1 also.
Type 1 also. Yeah.
What kind of hypersensitivity reaction is a fixed drug eruptions, FDE? Is it a hypersensitivity reaction, number 1? And if yes, then what kind? And if no, it settles the issue.
It may be
No, maybe.
between the type 1 and type 4.
FD is a type 1. Okay. Next. Then let's proceed. Okay. Thank you. Anyway, Dr. Bhagat.
Okay.
Thank you.
Okay, thank you, Dr. Bhagat.
The next presenter.
Okay, so you have to, yeah. So next presenter, who is the next presenter? Acha, Dr. Shubhosmita Pradhan.
Dr. Devarati Bera. Dr. Devarati Bera. I am just on the mute. That's why.
No, we have
this is
to.
Dr. Devaruti De, sorry.
Yeah. Dr. Shubhosmita Pradhan, are you there?
No. She has just left up chat box one.
Okay, then
chat,
proceed for the next presentation, please.
Yeah. Dr. Devarati Bera. Okay.
Are the
Let's
slides
start.
visible properly?
Yes.
Yeah.
Okay, thank you.
Let's start.
Good evening, everyone. I'm Dr. Devaruti De from the Department of Zoology, University of Calcutta. Today, the title of my presentation is Association of Interleukin-6 and Interleukin gene polymorphism with House Dust Mite Induced Nasobronchial Allergy in India. So to start with a brief background, the genetic background of nasobronchial allergy is well documented. House dust mites are reported to elicit NBS symptoms. Now, susceptibility to HDM sensitization varies considerably from one individual to another. And IL-6, interleukin-6 and 8 are studied previously for the genetic association with several diseases. But to our knowledge, this kind of association study regarding HDM-induced NBA is not largely investigated in India before. So the primary objective of our work was to investigate any possible association of IL-6 -572 and -597 polymorphism and IL-8 -251 plus 781 polymorphism with a risk of HDM sensitization. Secondly, we wanted to analyze any possible link between the severity of HDM sensitization with these two polymorphisms. And lastly, DP and DF, those are the two major house dust mites found in India. DP and DF sensitized groups were individually tested to find out any association with the same polymorphisms. So for our study, we have taken 425 patients, those visited to ARC Kolkata during 1 year. They are diagnosed with HDM. They are diagnosed with, initially diagnosed with nasobronchial allergic symptoms, and 110 control subjects we have taken. So among these 425 patients, we got, based on SPT sensitization, we got HDM sensitization as 87.5%. Now, among these patients, we have categorized these patients in one way, like a type of sensitization, that is whether they are DP or DF sensitized. And another way is the severity of sensitization, that is whether they are moderately or severely sensitized. Now, we wanted to check the polymorphism effect on all these group of patients based on genotyping. For genotyping, we have taken PCR RFLP method that included endonuclease digestion followed by PCR method. So these are our results. Here you can see for IL-6 572 polymorphism,
these are the genotypes, these are the number of patients, and these are the number of controls. So the genotype frequency between the number of patient and number of controls varied significantly when we tested this with statistical test, that is chi-square test. Now, when we tested the allele frequency, G and C allele, here C is the minor allele. When we tested allele frequency through Fisher test, we found significant association for IL-6 minus 572 polymorphism. And for IL-8 minus 251 polymorphism, also we found significant difference between the patient and control population in respect with genotype frequency and allele frequency, both. In the table, you can
1
see
minute
that.
left.
Okay. And when we plotted minor allele frequency for both the polymorphisms in the studied groups, you can see in comparison to the control group, both the moderately and severely sensitized groups were significantly associated, and that found for both the polymorphisms. And the same kind of results were found for DP sensitized and DF sensitized group separately. So to conclude, I can say that IL-6, 572 and IL-8 minus 251 polymorphisms varied significantly among the patient and control group, that indicated a strong association with HTM sensitization risk, whereas no association was found for IL-6, 597 and IL-8, 781 polymorphism. This kind of study is probably the pioneer study in the Indian population to suggest these two particular polymorphisms with HTM sensitization risk. Thank you.
Time up. Thank you.
Okay, thank you, Devarati.
Thank you, sir.
Let's go back to your first slide. First slide. Yes. In the objectives, first of all, this DPDF sensitized group was tested separately. This is not an objective. Okay. So first and foremost, your primary objective is to investigate any possible association between IL-6 and IL-8 polymorphisms and the risk of house dust mite sensitization leading to subsequent nasobronchial allergy symptoms, right?
Yes.
So when you have to detect the risk, okay, for detecting a risk can only be detected if you are showing the patients having an interleukin 6 and interleukin 8 polymorphism that you have stated, then following this patient up, and this patient should be actually skin prick test negative for the house dust mite sensitization, then followed over a period of time, and we see that how many of these patients become house dust mite sensitized, that means becoming skin prick test positivity, that means change in the skin prick test reaction from negative to positive, and subsequently they are developing a nasobronchial allergy. Always risk estimation is a longitudinal study where the patients has to be followed up, and when you embark on that study, at that time the patient should not have the effect which is under consideration. Okay, so if you are talking about the which here also is house dust mite sensitization, means skin prick test positive or having a specific IgE to DF or DP, right?
Yeah,
so if you're saying the risk of the development of a sensitization, that means when you start with the study, then at that time the patient should not have this sensitization positivity. Okay, and then to follow them up, which was not the means the actually study design in your case. You actually took the patients who came to the OPD, that means they're patients, that means have the nasobronchial allergy symptoms. Okay, and they also had this DFDP skin prick test positive.
Positive.
Right?
Yes.
So that means you had them who already had DFDP positive, who already had a nasobronchial symptoms, and in them you saw whether the IL-6 and IL-8 polymorphisms are present or not. Am I right?
Yes, sir. Whether the IL-6 and IL-8, that particular allele, the risk allele for those two polymorphisms, yes, these are, they are, could they differ between the patient and the control population?
No, I'm not going to control. I'm talking about the patient. So that means
Okay.
whether those allele polymorphisms are present in those patients or not that you studied.
Yeah.
Okay, so you did not study the risk. When you talk about the risk is a very sacrosanct statistical term. Okay, if you are talking about risk in your study design, that means you have to say that, see, if I am like cycling on the road, okay, what is my risk of meeting with an accident in a Calcutta busy street? So that means I haven't met with the accident, but actually if like I am like you're started cycling on the road, then what will be my risk of getting an accident? So if you want to say that, that means I have studied the all the cyclists who have started cycling and then followed up and then measured that how many of them met with an accident. This is how the risk is calculated. And for the calculation of the risk, you always do a cohort study where you calculate the relative risk. Okay, but in your study you have calculated the odds ratio, right? Odds ratio is usually calculated in a case control study. Odds ratio does not give us the estimation of the risk. Okay, odds ratio just gives that how frequent and that actually means in the cases and the controls, how frequent the effect is in the cases, how frequent the effect is in the controls. So when you are talking about risk, you have to be like that. And what were your controls?
Controls, they were SPT negative.
Age matched healthy individuals. Okay, that means they were healthy and the skin prick test to the house dust mite DFDP were negative, right?
Yes.
Or they were positive?
No, negative.
Right.
PPT
So to highlight it very clearly that age matched healthy. See, sensitization does not mean having a disease. This has to be very clear. Sensitization is an immunological term which only means that you have that specific IgE in your blood or that specific IgE bound to mast cells in your skin. This does not entail that the person would be having a disease. That person can be absolutely healthy. Okay, but that person could have been got already sensitized. So when you say healthy, it does not mean anything since you are seeing the sensitizations. Okay, so you have to say healthy individuals who are negative in the skin prick test with EF and DP, they were my controls. Okay, and so this is what type of study you did? What was the study design?
So basically, the main thing is whether the risk allele is more frequently present in the patient population or the control population.
Yes.
That is the base.
So what kind of study design is that? What type of study is this?
Case control study.
This is not a case control study. Okay, this is an analytical cross-sectional study. You took the data from the patient once. Okay, best way to say it, it is an analytical cross-sectional study. You took two groups, one healthy and one is the diseased. Okay, and you both the groups actually you saw that what was the frequency of the IL-6 and IL-8 polymorphisms, and then you compared the frequency of the IL-6 IL-8 polymorphism in the disease group and in the healthy group. Okay, the only problematic thing which I means, how did you arrive to this, that the sensitization and the disease, okay, that is a temporal event. Okay, it takes time from getting sensitized and then having the disease. Okay, but when you took the patient sample, at that time they were already diseased.
Yes, they were already diseased.
So I mean, going from the sensitization to the disease, actually that could not have been measured from this study, does not have that power to measure that thing. Okay, this can only say that how frequent is this polymorphism in the disease group vis-a-vis your this healthy group. Okay, otherwise it's a very good study, but when you write it, you should keep these points in your mind. Thank you.
Okay, sir. Okay, thank you, sir.
Thank you. I
Okay.
just want to
Any
ask
more?
whether you need any ethics committee approval for this particular study.
Yes, we actually take all the data from ARC. So from ARC, we got the ethics committee approval.
When? Mane, before doing this study, you
Sorry?
got the committee permission.
Yes, I have that paper with me to show.
Okay.
Okay. I think we have to proceed for the next one. Thank you, Dr. Debarati. Your name is Debarati De, right?
Yes.
Not Debarati
Yes.
Bera.
No,
Okay.
Debarati Day.
Okay, fine. Right. So, sir, we are proceeding for the next presenter. Next presenter is Dr. Rekha Devanathan.
Yeah, sir. Am I audible?
Yeah. Please share your screen, please.
Please make yourself visible.
Yeah, ma'am. Yeah, ma'am. Is my slide is visible, sir?
Yes.
Yes.
Yes. Okay. Thank you. Good evening, everyone. I'm Dr. Rekha from the Department of Pharmacology, JIPMA. I'm here to present a paper titled Association of NAT-P15 and ITPA genetic polymorphisms with azathioprine-induced adverse effects in South Indian patients. So with the background of azathioprine knowledge, like it is a commonly used immunosuppressive medication with a wide inter-individual variations, and it is a potential drug to prove the concept of pharmacogenomics affecting the medical background. Like in this drug, US FDA, British National Formulary and Clinical Pharmacogenetics Implementation Consortium recommended preemptive testing of a genetic polymorphism called TPMT, thiopurine methyltransferase, in the year 2011. So even after such testing, even in India, it is being commonly applied year and day. Still, adverse effects with azathioprine are severe in our population. When we go on digging about the cause for it, many of the Indian studies proved that TPMT prevalence is low in our population, whereas involvement of many other genetic polymorphisms like NAT-P15, ITPA are more in our population. So the aim of my study was to evaluate the association of NAT-P15, that is nucleoside diphosphate linked moiety X type motor 15, and ITP, inosine triphosphate pyrophosphatase genetic polymorphisms with azathioprine induced adverse effects in South Indian patients. So my primary objective was to compare the frequencies of these two genetic polymorphisms with the occurrence of azathioprine induced hepatotoxicity, myelosuppression, and gastrointestinal adverse effects in South Indian patients. The study design was cross-sectional observational study, and the study population were patients from the outpatient departments of dermatology and medical gastroenterology, JIPMA. Inclusion criteria was to the patients diagnosed with immunobilous disorders or inflammatory bowel disease who have previously received azathioprine or currently on it for at least 6 months, irrespective of age and sex. The exclusion criteria were pregnant and lactating women and patients who are not on regular follow-up. The sample size was calculated to be 120 using OpenEpi software with the allele frequency of around 8.5%. The study duration was for about 21 months. It started from May 2019 to Jan 2021. So the study flow where after obtaining ethics committee approval, screening of patients in both dermatology as well as in medical gastroenterology OPD, after explaining the contents of patient information sheet, written informed consent was obtained from the patient. 5 ml of venous blood was collected under aseptic precautions, and the sample was centrifuged, and the DNA was extracted using phenylchloroform method, and the extracted DNA was quantified. Then genetic analysis was done for these two SNPs. The 1168 codes for NAT-P15 genetic polymorphism, and this one for ITPA using the RT-PCR technique. So the statistical methods used here were the datasheet was analyzed using SPSS version 2022 and also using R software version 3.5.2. So the normality of the data was confirmed by Kolmogorov-Smirnov test, and baseline characteristics were summarized as mean and standard deviation for parametric variables, median with range for non-parametric variables, and for categorical variables it will be numbers with frequency or population. So the assessment of RD-Weinberg equilibrium as well as comparison of allele and genotype frequencies and association between the genotypes and the development of adverse drug reactions was done using chi-square test. Analysis of effects of covariates, gene-gene interaction also done using multiple logistic regression analysis. The p-value less than 0.05 is considered to be statistically significant. moving on to the results, this table shows the frequency of various adverse drug reactions reported with my study population. So myelosuppression was around 17%, and also hepatotoxicity were there for around 3%. So the second table shows the genotype frequency distributions for both the genetic polymorphisms in my study population. Like NAT50 wild genotypes were around 98, and also mutant genotypes were 22. The
1 minute left.
Okay. Then this is the table showing association of all the three important adverse effects in my study population, where myelosuppression showed a statistical significance with an odds of 7.79. So ITPA doesn't show any statistical significance, and multiple logistic regression for myelosuppression after adjusting all the variables, it showed an odds of 10.96 with a p-value significant. And this gene-gene interaction analysis showed CT genotype of NAT15, AC genotype of ITPA, when combined in a single patient, showed an increased odds of 27.2 for the development of myelosuppression in the study population. So for discussion, this showed the incidence of adverse effect was around 23%, and around 25% of the people discontinued the drug, and 77% of the people have interruption in the drug therapy. So this finds the significance of myelosuppression with the azathioprine therapy with an adjusted odds ratio of 10.96, and this gene-gene interaction analysis showed that CT in NAT15 and AC in ITPA affect the occurrence of myelosuppression with an adjusted odds of 27.2. The mechanism behind this NAT15 prefers the substrates, and according to in vitro and cellular studies, it will affect the protein stability, and thereby it will lead to fast proteasomal breakdown in cells, and no significant associations for between hepatotoxicity and GI adverse effects. And this study also suggests that age was also an important factor in increasing the odds for getting myelosuppression. So conclusion, so for getting a myelosuppression in the patients who are having mutant genotypes of NAT15, then okay, the age of the participants were also an important factor, and it leads to the occurrence of hematological toxicity. Thank you.
Thank you. Yeah, right. Quite well designed study. Yeah, I must say.
Thank you, sir.
Okay, two things. What were the parametric variables in your study?
So, sir, I would like to show my basic demographic variables, which I haven't shown during my presentation, sir, due to the.
Just say which were the parametric variables.
Yes, sir. Like basic demographics, like even age, gender, under the sorry, not gender. Age, gender, and also age, weight, and the maximum dose received by the participants, and also the clinic drug discontinuation, comorbidities, and the dose reduction, everything were based. So
these are the descriptive variables.
So
okay, these in your study design, the demographic descriptive variables are these. Okay.
Yes, sir. Yes, sir.
Okay, so this does not, when you say a parametric or a non-parametric, that means
it follows normal.
You're actually comparing anything, and then in one variable is the normally distributed.
Distributed, yes, sir. Yes, sir.
So means when you had taken this incidences of those what were these talking about, this two
genetic polymorphisms, so
genetic polymorphisms, the frequency of those genetic polymorphisms, were they parametric variable or non-parametric?
So frequencies usually we will be taking into categorical variables. So yes, sir.
তোরই সকালে করে হাঁটতে যাবে উঠে ঘুম থেকে 6টার সময় উঠবি 10টার সময়
Hello. Yes.
Hello.
Disturbances. Okay. So tell another thing that I would like to ask in this study is that are you aware of any gene-wide association studies which has been done in South India in relation to these two genes in azathioprine adverse drug reactions?
So actually there were studies. One study reported by an author called Dorababu et al. From Hyderabad, sir, and one more study was done in CMC Vellore, sir.
Final question, what are the limitations of your study?
So one thing is that I have included the patients who already taken the drug and who also had the event occurred before my study, sir. So if it could be a prospective study design, So that thing we are very sure about the what dose will be dependent on the each and every side effects. And one more thing is that if I could able to detect the phenotypic variations along with the genotypic variations, it also adds a little important value to my study. So
what did you say the first point? What was that?
so first, this is not the prospective study design also. Before starting the treatment, preemptively we are not testing the genetic polymorphism in the patient. The patients whom I recruited was already taken the drug. They are suffering from polymorphism. They add the adverse event or not. So if we could modify the study design to prospective study design, and we can able to deduct what exactly dose the population are carrying, so like a low or intermediate or high metabolizers or poor metabolizers like that. So
how will you design a prospective study design in your case? If you have to design a study prospectively, what will you do? What will be your inclusion criteria?
So actually, I have included the patients of immunobullous disorders with
criteria. If you have to do a prospective study in this case, that means what will be your target population?
So target population, like for immunobullous disorders, so like pemphigus vulgaris, in this patients, before starting the therapy, they are doing baseline CBC analysis, sir, in our setup. So along with the CBC analysis, if we could able to do a genotypic analysis as their routine part, it would be beneficial for the patient as well as the clinicians.
Who are the patients in whom you will be giving the azathioprine in your case?
So for whom I am giving
from what? These patients are suffering from what? Whom you are given the azathioprine?
So in my study, we have recruited patients from suffering from immunobullous disorders as well as IBDs, or inflammatory bowel diseases.
So that means all the patients suffering from the IBD and the Buller's disease who are treated for the azathioprine therapy, they will be actually included in the target population, right?
Yes, sir.
And then, before giving the azathioprine, you will be doing this gene polymorphism
analysis. Yes, sir.
Then you will see that in this group who are given the azathioprine, say 100 patients, you did the gene polymorphisms. Maybe in 50 you got the polymorphism, 50 you didn't get the polymorphism. You gave these are the two groups.
Yes, sir.
You gave the drug, followed them up. It's a cohort, okay,
yes,
and you'll find that what are the reactions occurring.
Yes, sir. Yes, sir.
Only another limitation that these are all association studies, you know.
Yes, sir. Yes,
so this does not satisfy the causality, actually the guidelines or principles.
Yes, sir.
So
yes,
these are only association studies. You can only say these are association studies, right?
Yes, sir. Yes,
Thank
sir.
you very well presented.
Thank you, sir. Thank you, sir.
Thank you, Dr. Rekha. It was a wonderful study.
Thank you, sir.
And one thing I just want to ask you,
yes, sir.
that as per your study title, and
yes,
this type of study
yes,
actually violates one of the basic principles of ethics. But actually the science requires to protect for the requirement of the science, we need to violate those ethics. So can you please explain this? Which ethical principle you are breaking?
So like in my title, sir?
Yeah.
Okay. Maybe in South Indian population?
Yeah.
Yes,
yes, in South Indian patients, you are violating which principles of ethics?
Sir.
And sometimes we see it in different genetic polymorphism studies.
Yes, sir.
Like in maybe in some specific Brahmin communities,
yes,
we are
sir.
doing
yes,
some
sir.
studies.
Yes, sir.
In certain Islamic groups, we are doing these studies. So which principles of ethics we are violating?
Sir, like autonomy.
What are the different principles of ethics?
So justice, autonomy, equality, beneficence, and non-maleficence.
So which basic principles is actually we are breaking here?
So maybe like informed consent we are getting. So,
what is justice? What is justice?
So like it should involve all the population, like in general. It should not be posed it into a community or a subset of population?
Yeah, so this is one type of studies where we have to sacrifice these principles for the science. Okay, thank you very much. Thank you.
Thank you, sir.
Thank you. So we are moving on to the next participant, Dr. Orgho Laha.
Am I audible?
Audible.
Yeah, you are audible. Please start sharing your screen.
Yes, my screen is visible to all of you.
Yes.
Yeah, screen is visible.
Okay. Good afternoon, respected dignitaries in the dais. Myself, Orgho Laha, and my topic of presentation is effect of HLA-DQ and IL-13 gene polymorphism in shrimp allergy among West Bengal population, India. As we all know, shrimp is one of the leading causes of food allergy in West Bengal, and it is mostly prevalent among adults. However, a little is known about its genetic causes. Genome-wide association studies identified HLA-DQ and IL-13 gene as plausible candidate behind this. We have tested one single nucleotide polymorphism from HLA-DQ gene RS9275596TC polymorphism. From IL-13, we have two SNP, one in promoter region RS1800925CT polymorphism. Another located in exon 4 RS20541GA polymorphism. HLA-DQ is a HLA class 2 group gene that serve to present peptides of exogenous origin to CD4 plus T cell, that is Th2 cell. Polymorphism in HLA-DQ may lead to allelic forms that are more effective in presenting allergenic peptides, thus leading to increased production of IgE in sensitized individuals. On the other hand, IL-13 is a cytokine secreted by Th2 cell that mediates its action through JAK-STAT pathway, leading to enhanced phosphorylation of STAT6 and expression of IL-13 in patients with food allergy. Have a look at our work plan schematically described. We have selected 532 patients about 20 years of age. All of them passed through questionnaire survey. Among them, 503 were included in our study. 378 patients have reported positive history of shrimp allergy treated as patient, and rest of the 125 individuals with negative history treated as control. All the patients have undergone skin prick test, specific IG and oral challenge. 160 were negative in WebC but positive in either SPT or specific IG or both, considered as sensitive patient. 113 found WebC positive are called as allergic patient. Genetic analysis was performed among these three groups by PCR-RFLP method followed by sequencing. Let's move to our finding. In table 1, genotype distribution of these SNPs was shown.
Dr. Orgho?
I think
it's disconnected.
Yeah. So another student who has not presented.
Dr. Snigdha Mishra. No, Dr. Shubhashmita Pradhan. Sorry.
He has joined.
Yeah.
Joined. Shambhu, I cannot evaluate him since I was there I'm there in the study.
Okay,
hello. Hello.
Yeah. Yes, please.
Hello.
Yes, please continue.
Yes. However, this is found significant in case of sensitive patient. When we stratified this distribution according to age group, we found significant odds ratio for 20 to 40-year age group, only shown by red colored figure in table 2. Next, in figure 1, it is shown that the RIX genotype had significantly higher IG level in both SIM challenge positive and sensitive patient. However, the level was superior for the challenge positive patient. Sorry, I cannot change my slide.
Okay, you carry on, please.
Oh, yes. We did haplotype analysis for two IL-13 SNPs and found that these two SNPs were in high linkage disequilibrium as shown in figure 2. In table 3, it was shown that TA haplotype bearing patient having significantly higher odd ratio than control. On the other hand, CA haplotype found protective for shrimp allergy. We did gene interaction study in figure 3 and found that the combined effect of CG haplotype and heterozygous TC genotype of HLA had protective effect in shrimp allergy. On the other hand, TA haplotype and CC genotype of HLA had significantly higher odd ratio for higher IG level. Finally, we can conclude that our finding clearly indicate that these SNPs were possible risk factor for shrimp allergy. We also clearly distinguish between shrimp sensitivity and clinical shrimp allergy. However, more studies are required in other ethnic population to validate our findings. This study will open a new era of target-specific therapeutics in the treatment of shrimp allergy in near future. And I will thank the Allercon 2021 organizing committee for giving me the opportunity to present here. Thank you.
Thank you. Your last slide is not visible to us actually. Shambhu, Dr. Shambhu. Dr. Shambhu.
Yeah, thank you. So, hello.
Hello. Hello.
This is your audible, Shambhu.
Yeah. So, thank you very much. So, what is the objective of your study?
My objective is to associate HLA-DQ1 polymorphism and 2 IL-13 polymorphism with the shrimp allergic patient. Shrimp allergy causes.
So already known shrimp allergy patient, you just you want to see the.
No. I have the patient, those who come to the Allergy Asthma Research Center, the doctor diagnosed on basis of their self-reported history. And those reported no history, they were treated as control. And those who are reported positive history, we undergone for skin prick test and specific IG and oral challenge. Those who are negative in oral challenge, but positive in either skin prick test or specific or both, we consider them sensitive. But those who are positive in oral challenge, we consider them allergic patient. And we tested the association study in these three groups: allergic, sensitive, and control.
Okay, so which type of study it is?
It is a cross-sectional analytical study. It's a case control-based study.
Case control.
Yes. Here
So
it is. I can.
You had just told cross-sectional analytical.
Yes, analytical means I have.
Yeah, cross-sectional analytical. Okay, but again, why it is case control study?
Because I have associated and see the odds ratio in all these polymorphism in the case group, that is my allergic and sensitive group, and in the control group.
Okay, the next question is regarding the ethics, whether this type of study requires ethical committee clearance.
Yes, I have ethical committee clearance before my going for the study. From the Allergy Asthma Research Center. I have shown in the work plan slide. I can show it.
Okay, no problem. Okay, thank you for this presentation.
Here it is written. Ethical clearance number.
Thank you all for your lovely presentations. You all have worked very hard, and I hope and I wish you'll do better next time. And there were few technical hurdles which we couldn't cross. So hopefully next time it will be offline, and so that these problems will not be faced by you all. So I congratulate once again everybody, and I wish all the best for your future. Thank you.
Pradhan, is she there? Dr. Subhashmita Pradhan?
Dr. Shubhashmita Pradhan, are you there?
Dr. Shubhashmita Pradhan is not there. Sir. She has left a message few times back, and after that there is no contact with her.
Okay, then we just exclude her from this competition. Okay.
Okay, so we conclude our all participants.
Yeah. So thank you, the chairperson, because you had done a toughest job, I think. And we will wait
all
for
judges.
Yeah, we will wait for 15 minutes for our calculation, and then we will announce the prizes during our valedictory session. So I am requesting all of you to stay with us. So this 15 minutes will be a sponsored break. So we'll take a 15-minute sponsored break, and then we'll come for the valedictory session where we will announce the prizes. So once again, thank you all. So we are
Thanks
coming
all
back
to the
after 15
judges
minutes.
and
Thank you.
And
Thank you,
to the
Dr.
participants. Thank you.
Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic catenic protein or ECP, Heman IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhale nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Okay.
Hello, Jayati madam, have you joined?
সমস্ত ওইটাকে ইয়ে করি, তাই তো? আর কাছে করলেই হবে। এইটা বন্ধ করতে হলে এইটা বন্ধ করতে হবে।
Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic catenic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center.
Good evening, everyone. So I think Dr. Jayati Das, Madam, also had joined. Hello. Yeah, hello. Am I audible?
Yes, you are audible.
Okay, Shondivda. So we are at the end of 2 days conference, Allercon 2021. So Jayati Madam has joined. Madam, are you there? Dr. Shoibal Moitro, sir? Okay, so it is really a great pleasure to organize this national conference with the help of a full team of Allergy Asthma Research Center and Allergy Asthma Treatment Center. So, Goshamida, are you there? You can.
Yes, I'm here.
Yeah, switch on your video then. So, may I request Mr. Sandeep Goswami, who is the treasurer of this whole conference, to say something, to have his concluding remarks.
Thank you, everybody. This session is a fantastic participants and scientists who have participated, and the students also. We tried our little best to organize at the, but sometimes we had to face. We're not in our hands sometimes. Definitely, it will be. It will not be there when we are going to do it after pandemic scenario physically. Which we have done earlier also so many years. And I wish all the members for your good health and better future. Thank you very much. Thank you, Shambhu. Thank you very much.
Thank you, Sandeep Da. So may I request Secretary of Allergy Asthma Research Center, Dr. Jayati Das, to say her concluding remarks. She is traveling now, but please, madam.
Thank you so much, Shambhu. I must congratulate everybody who all have taken part in this Allercon 2021 and who all have worked very, very hard, especially Shambhu Shamadar, who has really worked very hard to make this program a very grand success, absolutely. And let's hope next year we'll be able to meet and make the program offline. And I must congratulate the new students who have taken part and presented their papers. The papers were really good. I wish them all the best. And we want to carry on with this Allercon for another, say, maybe 20 or more years. Thank you so much. Thank you.
Thank you, madam. Thank you. So it was your concept that we were trying to materialize. So now I also from core of my heart, I just want to thank Mr. Shubir Dolui, who is not directly a part of this Allergy Asthma Research Center, but he had given his days and night to make this event successful. I am really thankful to him. Mr. Shubir Dolui, are you there? Okay, so we are really thankful to you. And another person, Mr. Arijit Kundu, he also helped us a lot, though he was not a direct part of our Allergy Asthma Research Center, but as a friend, as a colleague, he helped me a lot. And not last but not the least, that Dr. Devojyoti Shaha. Dr. Devojyoti Shah was continuously moderating 2 halls for last 2 days. We are really thankful to you, and we are no words to appreciate your involvement. Dr. Devojyoti, are you there? Okay, so we are really thankful to Dr. Devojyoti Shaha, and after all, our guide, Dr. Shoibal Moitro and Dr. Shantanu Tripathi, who had made this program, these scientific events, designed it. So we are really thankful to them. And our organizing chairperson, Dr. Aratrika Das, she also took immense pain to make successful this event. And I don't know, madam, most probably now in hospital, giving her round, so we are not getting her now, but we are again thankful to Dr. Aratrika Das. And whether Dr. Arijit Das is available, sir is there. So Dr. Arijit Das is the powerhouse of our Allergy Asthma Research Center. So may I request sir to say something? Sir is there, yeah.
It was a stupendous program, Shambho, and thanks very much to you and other members, especially to you. You managed this whole vast program so well. And I wish we have a success every year on this, and a symposium of this type every year. So thank you all very much, and wish you all good luck and good success.
Thank you very much. Thank you, sir. So also we should thank our sponsors, the pharmaceutical industry, specifically the Lupin Respira team, and also the other sectors of Lupin industry who are supporting us. And also we are thankful to Cipla also, Cipla Respiratory team, for giving us some sort of support as an academic grant to make successful event. And now also I want to thank Mr. Kaushik Dhar. Kaushik Dhar was actually organizing this whole event with us. Their technical team was supporting us. Thank you, Kaushik Da. Thank you very much. So now the final announcement. The today's presentations all were excellent, extraordinary, but we need, as a custom, we need to announce first, second, third. So the third prize goes to Dr. Aisha Nayak. So congratulations, Dr. Aisha Nayak.
Thank you, sir. Yes, sir. Thank you, sir.
So open your video, and we are really appreciating your effort. So
Thank you, sir.
you got the third prize. So Dr.
Yes,
Aisha Nayak, you were third in that prize papers presentations. But again, I am telling that everyone who are participating, everyone, they are actually fast, but it is a custom, so we have to announce this type of thing. So you are the third. Now the second prize goes to Dr. Orgho Laha. Congratulations, Dr. Orgho Laha. Are you there?
Hello. Thank you, sir.
Thank you, Dr. Orgho Laha, for this wonderful presentation. So
Thank you,
second
thank
prize goes to you. Thank you.
Thank you.
And the first prize goes to Dr. Rekha Devanathan. So congratulations, Dr. Rekha Devanathan.
Thank you, sir. Thank you so much.
Yeah, so congratulations. Where is your video?
1 sec, sir.
Okay,
Thank you, sir.
so congratulations.
Thank you,
You had
sir.
done a wonderful job.
Thank
So
you, sir.
congratulations. So first prize goes to Dr. Rekha Devanathan. Second prize goes to Dr. Orgho Laha. And third prize goes to Dr. Ayesha Naik. But all the other participants also had done a great job. Congratulations to all of you. And now I think it is time to end. And we hope that the next year we could organize this Allercon 2021 in a hybrid mode. So both virtual and physical mode. So let's see what happened. Once again, I just want to congratulate all the other participants also, along with the first, second, third prize winners. All of you will get the recognition certificates, and obviously there are some first, second, third prizes that will be later you will know about that first, second, third prizes from our center. So with that, I want to conclude today this valedictory session with thanking all of you. Thank you all. Thank you very much.
Thank you, Shambhu.
Thank you, Dr. Shambhu. Thank you very much.
Shambhu, have you taken the photograph?
I think we could not get all of us, so we need to.
Who all were there? Have you taken the photograph?
So may I request all of us may just open the video, and I think Kaushikda is there.
Yes.
So Kaushikda, can you please take one photo of all of us in one background so that you can give us later?
Okay. Please switch on the video.
Yeah, I'm requesting all of you to switch on the video. So please take a photograph of all of us in one frame.
Sari is not in the frame.
I don't think.
Dr. Orji does. Sari.
I can see myself.
Yeah. You are in the frame in the computer. I think.
Actually, I may not be recognizable because I'm wearing a mask.
Yeah. You are in the frame.
So I've already got a dark background and I'm wearing a mask.
Thank you, sir.
Okay. Thank you. So
thank you very much.
Thank you all. Bye.
Thanks everyone.
Thank you.
এটার যে প্রিন্ট স্ক্রিনটা মেরেছি এটাকে একটা সেভ করে দিই আমি